know that TB and sharing of information. We know that there are so many people who still don't know about TB and are not aware about TB, or they have wrong information about TB, and there is need to communicate and to even embrace different methods of communication. I think one of the areas we've not done very well is that we have stuck to the traditional methods of communication and giving TB information or health information, and sometimes leaving out a constituency of people who may have or may have embraced a different way of communication. So today we will be having a team who will be sharing with us on how we can harness art, that is music and drama, for TB awareness, so that we see how we can reach all the constituencies, different constituencies with different method of communication. We have a team called Utena, and at this point I want to welcome Nicholas Wambua to come and introduce to us this wonderful team. So we can welcome him with an applause. Welcome, Nicholas.
Thank you so much. Good morning. Good morning. My name is Nicholas Wambua. I work for Utena Youth Organization. Utena is a community-based organization based in Makadara, but working in Nairobi County. And as John said, we are not scientific, but we take the science from the scientifics, and we convey that message to the community, to the target group, through use of performing art, through use of drama. So we do edutainment. That is, we entertain as we educate. So at this point, I want to now introduce our professional artists who are very good at doing this. So ladies and gentlemen, I want to request us to welcome this team with claps, kindly. Wanaanzia tu mahali. Thank you so much.
Nimesikia nani Siradroda anafukuza watu huku. Hata jana siamekea nani kifuri mpya.
Nini kama unataka kusema ujui jirani yako anaigegia?
Nani huyo?
Bwana ya Martha hapo kando, haujui anaenda?
Oh, kaina ni ukweli. By the unajua nilisikia akikohoa. Ni kuhu. Alikuwa anakohoa usiku mzima. Unajua alianzia 6 jioni. Akafuatanisha hivyo hadi usiku. Unaona hata asubuhi karibu nidhani drama wanapiga huko. Amekohoa. Na hata nikuambie.
Shida inaweza kuwa nini?
Unajua babu yangu aliniambia, in case umesikia mtu akikohoa hivyo, directly hiyo ni TB. Na sio hivyo tu. Kwanza hainaga tiba. Huyo anaenda. Na unajua, can you imagine? Uwezi survive zaidi ya siku ngapi? Ni bili. Hata hii ya June bonus. Hawezi survive. Na unajua, kwanza babu yangu aliniambia, ukiona mtu ako na TB, inaweza kuwa ni uchawi. Hiyo ni uchawi. Hiyo ni
unataka kusema kaka one bedroom amehamia ndio watu wanamwedea.
Na mimi naweza amini. Unajua alikuwa ameniambia eti kuna huu family member wao kazini yake amsikilii vizuri, ati jua kwa sababu jua amekaa one bedroom
wampatie TB shwari. Umesema ako karibu kukufa.
Lakini enye anasikia vibaya. Mimi kwanza mtu nahurumia ni bibi yake. Bibi yake ako na stress guy. Can you imagine? Unajua saa hii, unajua mtu ako na TB nilisikia lazima akuwe na sahani yake, kikombe yake, sufuria yake, hata mwiko. Imagine ati anafaa sabadilishe vyombo zote kwa nyumba.
Anaanza zero. Hapana, usiniambie Martha anapitia hayo yote.
Acha hiyo kumhurumia. Babu yangu aliniambia. Ukisikia mtu ako na TB, lazima ataona na ukimwi.
Wanaenda.
Kweli ni kweli. Wewe umemuona? Umemuona amekoda. Hiyo ni nini? Sinaendana hivyo. Wewe kwani ujui? Sasa wacha. Kuna ingine nilisikia kuhusu TB. Hii ni moto.
Wacha na hiyo moto. Unakumbuka wa Kenywa? Si walianzaga babu yake, shosho yake, inamaliza generation.
Yote. Inafuata hivi generation mzima.
Yaani Martha na mtoto wake wako
wote.
Si hao tu, hata wenye watakuja wote wataenda. Kwanza kuna ingine nilisikia. Unaona TB ni baya sana. Na hii hakuna mtu anajua. Hii niliambiwa na nyanya yangu.
Tuambie.
Na hii iko hivi. Ukisikia mtu ako na
by a bacteria known as Mycobacterium tuberculosis. Now, how is this transmitted? It is transmitted through the air. When someone who has the bacteria coughs, talks, sings, or sneezes when in close contact with you, in poor ventilated places, in public spaces, and also in places where there is overcrowded places. Who are people who are more vulnerable to this disease? Little children, elderly people, and people who have weak immune system.
And what are the symptoms of tuberculosis? Prolonged cough, which at times comes with spots of blood, fever, chest pain or weak joints, fever, fatigue, loss of weight, and even dry skin.
Is inherited. TB can never be cured. Mbona nadanganya? These are all myths. Sindio? These are all myths about TB. TB doesn't only affect lungs. It affects kidney, brain, and other body organs. TB is not a sign of witchcraft. TB is just a bacteria which is transmitted through air. TB is curable. So when I told you that TB is uncurable, I was wrong. TB is curable when you search for the right medication at the right time.
Now let's talk about the medication. Patients that are diagnosed with tuberculosis undergoes medication for about 6 months. They're being put under antibiotics, which makes them go under the medication. And for those who are drug resistance, do go under a period of 10 to 24 months, and they are being put on stronger medication. What is the key to success? Let us all are there. That is only the key to cure. Thank you so much.
Kama we ni muogo. Kama na we maheni. Si hata ukidakue vitu za ukweli. Yaani unataka kusema bwana ya Martha ako na ukimwi shwari kama. We dakuwa na ukweli. We tujipage hata twende tuone Martha. We tigara hauna maheni masaka.
Sasa simkuje basi tukule.
Let's also see about the statistics. 32% undiagnosed, meaning the bacteria was not detected. 89 was successfully treated. Unfortunately, we had only 12% deaths. Utena performing artists. Thank you.
Thank you. Thank you very much. Can we appreciate them better? Utena team, thank you very much. For that, I think we need to appreciate them in a better way. Tutawapimia na tuwaangushie, si ndio? So let us measure for them. Utena team, you receive this. We are measuring for you, and let's measure. We make it bigger and bigger and bigger. Then tuwaangushie. Thank you very much. So these are methods of communication that works at the community level. I don't know whether we have this at the mic. This works very well at the community level. For us here, we may use different methods of communication, but at the community level, maybe these are the methods we need to see how we can adopt them and use them so that health information can reach to the grassroots. So thank you very much, Utena team, for that. Then at this point, we would like to move to another session where yesterday we were given a lot of numbers of people with TB, numbers affected by TB. We've had numbers of people getting post-lung disease complications and all that. But we need to get a point where we put this number now to a face. These are people. These are people, and we need to listen and hear them because TB journey is always long, most of the time long journey with a lot of challenges, and the end is not always smooth. So today, I would like to welcome two people who have walked the journey of TB to join us here on the stage. I want to welcome Millisent Mutula. Welcome on stage, Millicent. Is Millicent in the room? Karibu sana, Millicent. Let's appreciate her for being so brave to come and share with us her story. Karibu sana, Millicent. Then I would like also to welcome Karibu, have a seat. Then number 2, I would like to welcome Nzeimana Charles. Nzeimana Charles, welcome. Karibu. Let's appreciate him better. Okay, thank you very much. Like I have said before, TB journeys sometimes end up with other complications and other challenges, and thereafter life may never be the same again after TB. And I would like to welcome Millicent Mutula, who is a post TB lung disease survivor, to share with us. So Millicent, karibu sana.
Good morning, everyone. Good morning. Good morning this side. Good morning. I am Millicent Mutula. I am Millicent Awor Mutula. I am a TB champion, and I am a peer educator in one of the hospitals there back in Kasarani. And I would like to share my journey. It has not been an easy journey. I know some of you, I've met some of you, different places. I can remember back in 2021, nilikuwa na TB and I was not aware. But my aunt told me that, you've been coughing. What could be this? Then the hospital that I was taken, they told my aunt, this girl had kilimi, akakatwe. I was done that, but the coughing could not stop. I want to tell you one thing. Even in the hospital, sometimes the way you receive us, I don't know how to put it, but saa zingine mnatubeba tu ni kama, unajua, the first, we see you people, and we see help. But saa zingine, when you visit the hospital, the way you're going to be treated, I think it hurts more. One of the hospitals that I'm not going to mention really mistreated me. But I thank God, tunaambiwa you knock so many doors for you to get help. I would like also to thank Madam Evelyn Kibuchi, have tried and walked with me through the journey. And Professor Steve Anguva. The journey of TB was a bit friendly. I was coughing and coughing hard, and everything was done. After the test of sputum was taken, I was called, please come to the facility, results were out. And I was told I was TB positive. It was not easy for me, like Aje. But I was told it's only 6 months, you'll be out of this. I took those drugs very well without defaulting. After 2021, 2022, 2023, January 24th, I start coughing, sweating, losing weight. And you see I'm slim. If I lose weight, what will remain? Nothing, honestly. So I start losing weight. So now I took myself to the hospital. And I asked them, I finished my drugs. Then I was told, wewe ni defaulter. Hukumaliza. But I told them and I showed them and I even told them, you can call this number. I finished those drugs. They told me to go and do a chest x-ray. Showed I was again TB positive. Again I was put on drugs. Again 6 months. Finishing these drugs at TB. It was not easy. I took them. Side effects and everything, but I was okay with them. Come this year, 2024, 2025, again the same January, the situation worsened. Now I was vomiting blood, and when I cough, zinatoka na uzito sana. Then I told my sister to call me a clinician in Jiru. He could not pick the call because ilikuwa siku sana. But I called a friend also. Then they reached back at around 6. Then they told me, because umekuwa Mama Lucy, let's go back there. Just go there, we are coming. I'm telling you, friends, this journey needs support. This journey, you cannot walk alone. The journey of TB and lungs, you cannot just walk alone. We need people to walk with us. We need people to show us the way. And that's why I decided to come a TB champion, only to help the community. And those people who are living with TB and HIV. Because I know what people are facing and the difficulty they're going through. It is not easy. So when I was rushed to Mama Lucy, they gave me the referral to Kenyatta Hospital. I was received well. Again there, I won't mention that name. I'm called Millisent. No, so you might think I'm a Kamba, but I'm a Luo. Somebody talked very bad in Luo. Na kaongea. And I was listening. Then after walking out, I asked my friend, Kwani, how do I look like? Simuniambie tu kweli, how do I look like? No, Millicent, yuko tu sawa. No. There's something I've had in the room. You people, you are lying. This year, I've had something. But you people, it's good you tell somebody something so that I live knowing. Sometimes, the discrimination starts all the way from the hospital. Sometimes you receive a patient and you think she or he does not know anything. Na siku hizi life, we are in digital life. Somebody can do something wrong. I might record if maybe I was having that evil mind. But because I was weak, and she talked. Then akaniambia, go to the next room. And I went. I was treated very well in the next room. I was given so many tests to go and do. The day I was in this CT scan room, another, I don't know, clinician also asked me, Millicent, have you been having TB? Then I said, yes. Can I be? It's okay. You go, you come for the results. When I come back for the results, I went back to the clinician, and they were being treated well in Kenyatta. If you're in here and you're in Kenyatta, feel appreciated. They treated me well. So today, the result came out, and I was told that I'm having an issue with my lungs. Lung collapse completely one side, left side is gone, and even this side, imekulika kidogo. But I thank God because I'm okay. You cannot know not unless I share with you. And I help many people with the same problem. I walk the journey with them, even if I don't have money, but I walk the journey. I call Anguva. When I have a client or a patient who is going through the same, I call Anguva. Then I want to say something. Discrimination and stigma. If I was not aware of TB, of HIV, many clients are dying because of how they are treated. And some are saying, me, I'm not going back there. Millicent, if you will be able to bring me these drugs here, I'll take. But me, I'm not coming to some of the hospital. Personally, I know how to deal. Unaweza jua venye una deal na some of the problems that you're facing. But it doesn't mean if you're having lung issues or TB, you should be discriminated. Even with the family. My sister told me that this yours is too much. My aunt told me this one, yours is too much. But there are people who stood with me and they showed me the way. I just don't know how I can reward them, but how I pray God to reward them on my behalf. Secondly, I would like also to talk about my journey, a little journey. When I was told that I was having lung problem, I asked that doc, wanaishingi? Nitaishi siku ngapi? Nitatembea? But things have changed. Me, I cannot carry heavy things the way I used to. Me, I cannot walk faster like I used to. I cannot run and I used to run. So chest pain is somehow is there, inakuja ikipotea, but it's there. But I thank God I'm still visiting the hospital, I'm still getting treatment, and I know all will go well. Thank you.
Thank you. Thank you very much, Millicent. Maybe we can appreciate her better. It takes a lot of courage to stand here and share that journey. Thank you very much. So I want now to move to the next session where we have Charles, Mr. Charles, who is also a TB survivor, to share his journey with us. Karibu sana, Charles.
Hello. Mimi mtanionea radhi. Kiingereza yangu nilibaki pale nje kidogo. Nimekakuja hapa na Kiswahili. Jana nilisikia watu wanaongea Kizungu sana, na sasa hii my sister naye alikuwa anaongea Kizungu mingi sana. So acha tuongee Kiswahili kidogo. Mimi niko hapa kuelezea ukweli. TB iko. Na TB inaweza isha. Ile naongea ni ukweli. Kivipi? Ni kitambo kidogo, maybe wengine walikuwa shule au nini au pale pengine. It was 203. Kaanza kusikia mwili si mzuri sana, lakini kaendelea na kazi nilikuwa nafanya. Ikakuja ikaisha nguvu kabisa. Usiku silali, Kuanzia saa 7 ya usiku mpaka asubuhi silali, na sweti na toka jasho ni mingi sana. Nikaendelea tu. One day nikauliza my partner, nikamuuliza hii shida yangu ni gani? Maybe ni kazi unafanya, ni kuchoka whatever na kadhalika. Nikaenda hospitali, nikafanywa test, akakuta niko na TB. Na nikawa na uoga mwingi, na sasa nimeisha natembea kwa barabara, watu wakiniona wanasema wewe haupumziki, wewe ukitoka kazi ile yako mzito unaenda kwa bar, wewe ni mrefu kila siku. Siku anaweza kutembea hivi nikienda kwa barabara, kwa sababu sina nguvu, appetite ya chakula sina. Lakini bahati mzuri vile nilipewa ndawa, ngashauriwa usikose hata 1 day kunywa dawa zako vizuri, utapona. Haya, hiyo mashauri kaizingatia. Nilikunywa dawa vizuri. Kumaliza kwenda kufanya check up, akaniambia una TB. Karudi kwa community. Wenye walijua niko na TB, nakumbuka kuna jirani yangu aliambia watoto wake wasikaribie pale nipo, au waingie kwetu, wanaweza kufa. Sisi tumejiuka wachawi. Kitu ya kwanza, usitenge ule mtu wako na TB please. Usimtenge. Kama ningetengwa saa singekuwa, lakini daktari wanikaribia, wakanishauri, wakanikaribisha, nikapewa dawa, nikakunywa, nikapona. Wale majirani wengine walinitenga, kuna wenye wako na si TB waua, walikufa kwa vifo zingine. TB ukizingatia itapona. Kitu ya muhimu, huo mtu ako na TB, kama amekuelezea kweli ako na TB, au kama wewe unajua ako na TB, mshauri, msupport. Si mlisikia jana wakisema shida ya kwanza ni poverty. Mtu ako na TB, ana chakula, atakunywa dawa namna gani? Ukimutenga badala kumsupport, wewe unamtenga. Hiyo ni ukweli. Lakini ukimsupport, angalau umpelekee ka unga, atengenezewe ka uji, wewe mtatapona. Lakini ukisema sikaribia ule ako na TB, hataenda. Na wewe ni kesho. Kuimaliza TB ni kushikana. Tujishikana, hiyo kitu itaisha. Lakini kama tunatengana, haitawezekana. Wengi wanaweza sema maybe huyu mzee anaweza kuwa anaongea vitu si kweli. Mimi nilikuwa na TB. Na kitu nakwambia ni ukweli, 2 or 3. Ushahidi niko nayo. Hii ni kadi nilitumia wakati huo. Unaweza elezea? Hii ni kadi nilitumia wakati huo. Nilikuwa na TB. Sikuwa naweza kufanya chochote hiyo period, kwa sababu vile nilikuwa. Lakini sasa hii unaonaje? Kwa sababu nilisupportiwa. Kwa sababu nilisikia ushauri wa wenye walikuwa tunza. Sina mengi ya kusema, but vile tulisikia jana poverty Ni kitu ya kwanza. Ujiangalia watu wako pale kwa mtaa mabanda, ile mazingira wanaishi, hiyo ndio chanzo ya kwanza kuwa na TB. Ujiangalia wale watu wako mtaa mabanda, ile chakula tunakula, ile chakula yani vile tuko, vile tunavaa, vile tunaishi, hizo nyumba tunaishi, vitu tunatumia, hiyo moshi, hiyo nini, hizo vitu zote chanzo cha TB. Vile daktari profesa alisema jana, poverty. Kwa usu upande wa chakula ni tiba. Mtu akiwa na TB akunywe dawa na hajakula, huyo mtu atapona kweli? Huyo mtu atapona? Yes, usiseme simupingi, lakini anajiuliza kukula sana bila dawa. Yes, ni kinga, lakini tumia dawa na ukule na uishi mazingira mazuri. TB itaisha. Lakini tukiendelea kuishi vile nani zetu zinataka, hiyo si sawa. Tusapotiane, tuinuane, maisha itakuwa sawa. Sina mengi ya kusema, but tuangamize TB. TB inaisha. Asante sana.
Let's appreciate him better. Nimeona kadi. Asante sana. Asante. So let's appreciate him better. So I think they have shared with us their journey, and you can see that there are some themes. The themes that we always see every time that are still coming up in their journey about the long period to diagnosis, the post-lung complications, the stigma and discrimination, the difficulties people face in the navigating through the health system. You can see those themes. Maybe the biggest question that this Millicent and Charles would like to ask you is, what can you do to make that journey easier? What can you do to make that journey not end with complications? What can you do, you who sit here as the healthcare worker and policy makers, to make their journey friendly, to make it early diagnosis, to ensure early diagnosis and all that? That is the biggest question that they are putting on our table today, and I think you can think about it. And maybe at this point, is there any question or comment to our guests? Anybody in the room, any comment? We can take two. Anybody else? I have seen one. Anybody else? Okay.
All right. So asante sana Millicent na Charles for your sharing. We appreciate, and normally it's good to hear, feedback from somebody who's walked the journey, because it helps us reflect. We pause back and we think and kind of say, what could have been done better. It might not apply to you now, but it will apply to somebody else. So I think, thank you for sharing your story, because it gives us points of reflection. So let me talk about, so Millicent, I think post-TB lung disease is something that it's just in the recent past that it has become more and more talked about. And clearly from your story, it shows that even though the message is out there, it hasn't reached the lower level facilities, the ones that people walk into every other time. And that's why you find people being treated twice, thrice, fourth for TB, while really it's because of maybe the lung damage. And just to say that post-TB, now we call it even post-TB disease because some is lung, but others, you know, could traverse in every part of the body. But maybe now a reflection to you, you know, what have you been told, and what's the journey? What are you supposed to do now post this diagnosis, for example, if you're free to share, because it's good to hear maybe what information then actually goes out to patients who have been found, maybe, for example, for you, you shared that it was a lung collapse. And then Charles, asante sana. Nitajaribu kuongea na Kiswahili just to warm everything up. But shirika lenye nafanyia kazi tumefanya research is utafiti wa kuangalia vile men especially you know, seek care wanakuja kwa facility. Vile wewe ulianza, hata vile ulianza kuwa mgonjwa, ni level gani ya hospitali ulienda kwanza ndio uanzishwe hiyo journey? So ulinunua dawa, ulifanya nini? Na maybe what informed that choice? And then having gone through the 6 months ya madawa, ni nini hasa unaweza ambia wale wanafanya kazi kwa facility wanaweza fanya ndio men wakuwe comfortable kukuja? Are there things that could have been done for you that you think, I wish they could have done this and this, and it would even, kama mwanaume sasa uangalie kutoka pande yako ya kufikiria ukiwa mwanamume, unajua vile labda hawapendi kwenda hospitali etc. What could have been done better to even reach them earlier, ndio ungepata help hata kabla usikie uko mgonjwa sana. Asante.
Thank you very much. We can start with Millicent and then we go to Charles.
Thank you so much for the question. Okay, I've done so many tests, and right now I'm waiting for another test. I have done it already. I'm waiting for the result. So after receiving that result, I think they're going to tell me what next, because I've been going to Kenyatta for treatment, and I've been taking, the only thing that they've been giving me all along, it is intraconazole. I've been taking intraconazole, not any other drugs. But the test that I was told to do, I've already done it at Lancet, and now I'm waiting for the result. And I trust after getting that result, I know there are better answers. I hope so. Thank you so much.
Thank you. Charles, can I address the question?
Yes, nilikuwa nasema hivi. Kujiamini si mbaya, lakini kizuri ni kushauriwa. Ukiwa na shida fulani, approach mtu akushauri. Ukisikia kichwa kinakuuma, si vizuri sana ukimbile kwa chemist kununua nani. Ujui chanzo cha hiyo kichwa. Hospitali zimejengwa kwa sababu yetu. Kwa nini Mungu alinipea maybe ujuzi wa kuendesha gari au ndege? Hakunipatia ujuzi wa kujua chanzo cha maisha yangu. Tushauriane. Yes, kuitwa mwanaume sio kusema wewe ni kujiamini wewe tu peke yako. Amina wengine wako around you. Wale washa muongee. Kama uko na shida fulani, unasikia maybe uko sawa, ule ako karibu na wewe muulize, mbona niko hivi na hivi na hivi? Mimi in time kisikia mwili wangu si sawa, siseme kwa sababu mimi ni mwanaume siwezi kauliza daktari mwanamke. Mimi sio mimi ule wa kwenda kwa daktari niseme naumwa, niko na shida, lakini naumwa pale chini. Chini wapi? Ongea shida uko nayo. Kama unasikia kifua si mzuri, na usianze kujishuku wewe. Useme kwa sababu nasikia kifua kikiwa mbaya nitakunywa. No, enda kwa daktari. Maybe akona shida ya kifua. Ufanywe testing. Watakuja kujua ni nini kunakuumiza. Lakini kujiita mwanaume sio kusema kwa sababu naweza acha nifanye kivyangu tu. Hapa nafanya na wengine. Mshauriane. Ni hayo tu.
Thank you. Thank you, Charles. So as there is one more there. So we can take that one comment there and then we'll be done. You can help me pass the mic, Kaidri?
Tunashukuru sana kwa uhamasisho ambayo mumepatia community, na tunawaomba sana muendelee kuenda hospitalini kama mko na shida yoyote. Lakini swali langu ni, mumetupa historia yenu wakati mlianza kuwa wagonjwa na pia vile mlienda hospitali mkahudumiwa na vile mlitangamana na familia zenu. Lakini swali langu ni, kweli upande wa kazi, mahali mnafanya kazi, mumeweza kuchukuliwa vipi mkiwa wagonjwa? Kwa sababu sasa unapata sisi madaktari saa zingine wagonjwa wanatukujia, tunawapatia sick leave ili waweze kupumzika. Wakati unafanya kazi, ulipata changamoto aina yoyote?
So is there any other comment? You can maybe we can take yours and has the last one.
Okay, now that I have the mic, thank you.
Yes.
Asanteni sana. Swali moja tu kabla uanze kujisikia vibaya, yani kutofika kiafya. Ulikuwa unajua chochote kuhusu TB? Ulikuwa umeshasikia nini kuhusu TB kabla ya wewe kujua unajisikia vibaya ukaanza kutafuta usaidizi hospitalini ama wa kiafya wote? Asante.
Thank you. We can have Grace.
Asanteni sana. Swali langu ni, kwa sababu najua mnaishi kwa communities na tunajua kazi ambayo CHPs wanafanya. Kwa huo muda wote kabla ya hospitali, mlikuwa na ushauri wowote kutoka kwa CHPs? Because tumewafanyia uhamasisho sana kwa maneno ya TB, kuscreen kwa community. So nilikuwa nataka kusikia kama walikuwa na jambo lolote. Asante.
Thank you. So Charles, you can go first and then Millicent.
Nasema hivi, nataka nijibu ule aliuliza swali kuhusu pale pa kazi. Ni ngumu sana madam. Uwezi ukapewa rifu kwa sababu wewe ni mgonjwa na ni kibarua. Maybe kama umeandikwa sawa, lakini sisi wajua wa kibarua barua, maybe kama umeandikwa sawa kuna barua, lakini kama ni unaenda kuhakikisha vile kwa nyumba yako kutaingia unga, hiyo ni vigumu sana. Unajikaza tu, wewe mgonjwa usiwe mgonjwa, unaenda tu. Ukijua wewe huwezi kwenda, unabaki kwa nyumba. Jana profesa kasema poverty ndio shida sana kuhusu TB. Madam akisema chakula, huwezi kujua kama maisha yako yuko namna gani. Utatetea nani, utatetewa na nani? Wewe unajitetea tu, una mwingine wa kukuangalia. Ndio maana tuchiungana. Serikali kiweka nani support, itakuwa mzuri. Lakini ukiacha mtu aende hivyo, wataumia. Kuhusu kushauriwa na hao watu wa ushauri kwa community, yes, wanapita vaccination ya watoto, lakini hakuna mtu anaweza kuingia kupari kwa nyumba kuambia by the way, mimi hakuna mtu aliniambia kuhusu TB. Mimi niligonjeka tu, ngasikia mwili wangu si sawa, kaenda kwa kupimwa. Vile nilipimwa kaambiwa niko na TB, nikakuja kaambia my wife, ujue leo niko na TB. Kama ni kikombe yangu weka kando, kama ni blanketi yangu weka kando. Akaniambia hapana, si hivyo Charles. Kama uliambukizwa uko na TB na umejua leo na tumekaa na wewe, maybe na mimi niko nayo, chenye naweza fanya na mimi ni kwenda kupimwa, nikikuta tuko nayo tuendelea na dawa, lakini kukutenga mimi sitakutenga. Unaona ni support. Kama ngenitenga ningekuwa wapi? Yaani ningeweza kujiosha nguo au sahani? Ngitengo nilale pale mimi peke yangu na maybe tuko na blanketi moja. Si unaona kuna shida hapo? Maybe ajisema chukua hiyo blanketi. Yeye alale peke yake na nani kashuka. Baridi sije muingia. Achukue na pneumonia. Lakini kwa sababu ni support na mimi ngashika. Na mjua vizuri sana ukiona mtu ako na TB akinywa dawa vizuri na kianza dawa hawezi kuambukiza. Hakikisha huo mgonjwa amepata dawa, na umfuatilie vizuri sana, umfundishe kunywa hiyo dawa, hautaambukizwa. Kwa nini mtenga? Ni vizuri sana kumkaribia, umfundishe vile atakunywa dawa, hataambukiza wengine. Tukiwa na uoga au tukijisema ni mimi peke yangu, tutaishi peke yetu na tutaisha hivyo hivyo tu. Lakini tukiungana, TB itaisha. Asante sana.
Okay. Somebody have asked, kwa kazi inakuaje? To be honest, you cannot walk around and start disclosing your status. Ati niko na TB. Tunaambiwa mara mingi, wewe uko na TB, mko wangapi hapo kazini? Do you think I'll come and tell you the truth? I can't. Because when wanaamini aliye na TB ana virusi. Personally, Mtula, I can't. So I'll lie. And after lying, I'll come because pia nagopa kelele kwa hospitali. Takwambia mimi siendi kazi, mimi nauza tu mahindi. And those are the things that we receive from the community. Sasa nikiambia mtu niko na TB, ni waleta timaambiwa mkuje hospitali mpimwe, kuna venye atanibeba. And that's what it's our fear. So I'm not going to keep on telling people I'm TB positive and the doctor have requested you people also you come, you get tested. I fear because they start questioning so many things about me. And at working place, how you interact and how your colleagues taking you, personally I can say it was tricky. Especially there's another lady alinotice haraka sana, kanambia na tumgutu wako tunafura na hii TB ni kama haikuisha. So they started telling me Mtula ile room ikue yako. And I took it positive because TB inatiba, TB is treatable, TB is manageable. So I took it positive though. Lakini kwa watu wengine wale kwa community hapo nje, wako pale kwa mjengo, ambiwe kesho usikuje. There's somebody who told me Mtula mniandikie barua, Muhindi amesema nikae nje 6 months bila kulipwa. Na hii ndio maana sikutaka niwaambie nafanya kazi wapi. Now I've lost my job. It's painful for those people hustling. So some of them, they don't tell us the truth. Okay, and CHP, before I get TB, me nilisoma TB in high school, in primary. But personally, I couldn't believe that one day I'll become a victim. So when I realized that I'm TB positive, I started asking myself so many questions. But I thank God, nilikuwa naambiwa TB na tiba. But my worry was, why is it every day after 1 year I'm testing TB positive? Why? And every now and then you go to the hospital, definitely if you do x-ray itatoa TB. Again unaikwa kwa TB drugs. So until the last day, somebody told me, Mtula, this one yours is not TB now. You need to do more about it. And now I thank God for this this symposium. We get to know more about lungs. Itatusaidia sana even in the community. We are going to reach many people and to tell them more about lung issue. TB is real, lung issues are real, and there are other people who are not even having TB, but they're having lung issues. So you people, you need to support us. As we get out of place, we need to support together. Thank you so much.
Thank you, Charles, and thank you, Millicent, for sharing with us. We've come to the end of this session. Unfortunately, we are not able to take another question. I'm sorry, because we need to switch to the next session. But we need to appreciate these very wonderful people. You can stand here for people to appreciate you. We can arise and clap for them for the. Thank you very much, and asanteni sana. So thank you. So yeah, so thank you. So we now need to switch gear, but you have heard about the journey, the stigma, all the
can I try mine? Then as you work on that one.
Yeah.
Okay. Can you see mine? Can you see mine?
Yes, we can. Is that Dr. Aweru?
Yes.
Okay. So if Dr. Aweru is coming first, thank you, Doc, for joining. I hope you can put your slide in slideshow. Okay. So let me introduce Dr. Aweru. He is a physician pulmonologist. He did his undergraduate studies. Yes, we can. Is that Dr. Aweru? So if Dr. Aweru is coming first, thank you, Doc, for joining. So if Dr. Aweru is coming first, thank you, Doc, for joining. You can put your slide. Okay. So let me introduce Dr. Aweru. So let me. Can I?
I'm not able to share full. Moses, I am not able to share full slide. The one for presentation mode. Moses.
Okay, it's fine, Doc. You can continue as it is. But allow me to first introduce you, and then you will go ahead with the presentation. Is that okay?
That's fine, thank you.
Okay, so Dr. Aweru did his undergrad studies at the University of Nairobi, graduated in 1998, and he completed his M.Med studies. Okay, it's fine, Doc. You can, but allow me to first introduce you, and then is that okay? Is that okay? Okay, so Dr. Aweru did his undergrad studies at the Wow, technology. Prof. Lodge, what do you have to say? Okay. So he completed his M.Med studies in 2008 and subsequently fellowship in pulmonology and critical care in 2011. Thereafter, he taught at the Aga Khan University in Nairobi until 2017. When he opted to go to private practice, he has trained in interventional pulmonology locally and internationally. His publications.
Are you having trouble sharing?
Wow. Okay. So I think we just continue. Those of you who know Dr. Aweru, he has not changed. He's still the same guy. Those of you who don't know, please listen through and you get to know him better. Next time he'll be here physically. I hand this over to you, Dr. Aweru. I hope you can now hear. The floor is yours.
Moses, I've tried again, but still not moving. I'm sorry. I had sent my slides. Yes, I did on email. Yes. Okay, that's okay. Let's go then. Thank you. So you're on the first slide. Okay, so thank you, and I hope the audience can hear me. Can the audience hear me? Thank you. The first slide. So I was tasked to discuss the role of interventional pulmonology in pleural disease. And when Professor Chakaya called me about this, I thought it was a very good time to discuss about interventional pulmonology, because this is something that has come up, and I saw that the theme of the meeting was innovations in pulmonology, TB, and lung diseases. So over the last 2 years, we've gone quite a few steps ahead in terms of interventional pulmonology. I'll talk about pleura, and my colleagues will talk about the other aspects of the lung diseases. Next slide, please. So in summary, interventional pulmonology is a process which offers minimally invasive tools to diagnose and manage pleural diseases. And the main diseases we are looking at are pleural effusions, pleural masses, and pneumothorax. The key things relate to thoracentesis, and this is used in getting fluid, and the removal of the fluid may be to send the fluid for analysis or to give relief for patients who have dyspnea due to excessive fluid accumulation in the pleural space. There's also medical thoracoscopies, and these are also important in getting fluid out, getting guided pleural biopsies, as other processes like cryobiopsies, and we also have insertion of indwelling pleural catheters, and these are very important in management of chronic malignant or non-malignant pleural effusion. And we also have pleurodesis, which essentially is instilling a chemical into the pleural space so that you have the parietal and the visceral pleura fusing, so that you can prevent recurrent effusions and recurrent pneumothoraces. The advantage of interventional pulmonology is that these processes are faster, they are quite safe, they may not sometimes require any theater time, and they are very, very effective in terms of managing pleural conditions. For instance, you can imagine if you have a pleural mass, you can easily see it if you do a if you do some of these interventions. And we look at each of them as they have come up in our practices. The modalities I'll talk about are thoracic ultrasound, transthoracic biopsies. There are different modalities of doing this, medical thoracoscopies, and different types of pleural drains that are available. So thoracic ultrasound, we have moved way ahead, because in the past we needed to take patients to radiology to get an ultrasound done. So you are competing with other people who need ultrasounds. But lately we do have even pocket-sized ultrasound, because not only do they help us make diagnosis immediately, they can also aid in excluding other common. For example, we may have a pleural effusion, whether this pleural effusion is due to infections, is it due to renal failure? And when you are checking your patient, not only can you confirm the presence of effusion, you can same advantage and do get a sample of the fluid, and at the same time you look at your heart and you may failure which was previously undiagnosed. And therefore, when you get your pleural fluid analysis, you can very quickly say, I'm going to fix a drain here, or I'm just going to give diuretics and wait. The current machines that we have to do ultrasound, although they are very portable, they are small, they have very also The nobology is not so complicated. You know, in the other ultrasounds, you have to change, oh, I'm going to an abdominal screening, I'm going to cardiac screening. In this one, it's just software which helps you to determine. You just tick on the phone or on the pad, and immediately you can change from screening for the heart to screening for the lung, or screening for the lung to screening for the abdomen. So they have made life very, very easy. And currently, we have a few people who are training us to use these ultrasounds, both abdomen and so on. And there are also online resources on YouTube and other places where you get very good information on how to interpret the images that one is getting. So this is coming in a very big way of thoracic management of thoracic conditions. It is real decision immediately. You can also determine, is this empyema or not? You can determine the volume of the fluid. You can determine also whether there is a change on the pleural surface. For instance, are there masses? Is there thickening? And this helps you guide where you will get your biopsy immediately. So very, very good. It also helps prevent injure organs. For instance, if you are putting your drain very close to the diaphragm, you can clearly see the diaphragmatic position and movement. And when you are putting your drain, it is very easy to avoid that. So even the risks pertaining to the procedures we do in the chest is markedly reduced by using the ultrasound. The challenges we have is that the equipment is a bit pricey, because you may find some systems are going for about 400,000 and so on, but it is money very well spent. These machines also require us to get some training, and I have seen in the chest organizations, for instance, the ultrasound. The challenges we have, the Nairobi hospital, the ICE, of the things they are training, some systems are going for, and I have seen this and so on, but it is money very well spent. These machines also require us to get some training, and I have seen in the chest organizations, the ultrasound, pleurobiopsy, the Nairobi hospital, the ICE, of the things they are training. You have to do, for instance, if you're in a resource limited area, you do your chest x-ray, you see an effusion, you take advantage when you are doing your pleural chest, your chest tube, you take advantage and take a pleural biopsy. Even if you don't have an ultrasound, if you're suspecting things like TB, you have a very good chance of getting the diagnosis if you even do a blind biopsy. But to do a guided biopsy, particularly if you're able to localize your lesion using an ultrasound. And you may use Abraham's needle, which is the basic one, or you may use true cut needles. Image guided is superior. This is why you use either CT scan or ultrasound. And the kind of needles we use are the Abrams and true cut needles. Let me just show you how they look like. The Abrams needle is the one you see on the left, and it has 3 components or 4 components depending on the need. And what you do is, after you make your entry through the intercostal space, the technique is really very easy. You give local anesthesia, you insert this needle, and you're able to take the parietal pleura. This is in contrast to the true cut biopsy, which is more refined, so to speak. It's a very fine needle compared to the Abrams biopsy. And what it does is that it the technique is really very easy. Get very good quality material for analysis. You need to do multiple biopsies during the time you're taking your biopsies to increase the yield of your histology. And you can see that to aim to do a pleural biopsy. And this can be done even in very small centers, because if you get an Abraham's needle, you have a big effusion, it is easy if you learn the technique. Then we have medical thoracoscopy. This is a minimally invasive endoscopic procedure that allows for direct visualization and intervention within the pleural space. And here we use a machine, an equipment called a thoracoscope. The medical thoracoscopy is a simple procedure. It is done under local anesthesia. Then we have medical thoracoscopy. This is a minimally invasive endoscopy. These two things make it accessible in many places, especially if you have a thoracoscopy. The key thing is that you may not even need to use an anesthetist. You may not need to use a theater. You can use it in a clean side room. I've seen the Nairobi hospital, the KNH team have perfected this. They do very many medical thoracoscopies in their endoscopy suite, and they have very good outcomes. And during that time, you can drain fluid, you can take biopsies, you can, and the good thing is that you're taking biopsies from areas which you can see have pathology, and you can do complete drainage of fluid, and if your lung is expanding very well, you can do fluorodesis at the same sitting. So a very, very useful intervention if it is available. So the thoracoscope allows one to visualize the areas, and we have two kinds of thoracoscopes. Some are rigid, some are the advantage of the rigid is that it uses very big forceps, so you can tissue. So a very, very the flex available. So the thoracoscope and rigid allows the rigid one visualize the areas, and we have two kinds of. We see when you go in the panel on the left, you can see the fluoroscope has been inserted in between the reeds, and there's a you can see imaging on the other. The use in taking a biopsy is that if you allow the rigid one, get is small, and sometimes it is crushed, and therefore the histologist may not give you very good answers. To improve that, number one, you take multiple biopsies. And now, if you're in a facility able to do something called cryobiopsy, it's even superior. Now, the problem sometimes we get with this kind of forceps is that they are weak. They sometimes are unable to take the very tough tissue that we sometimes get with this mass. The upper panel is showing what we see when we get an empyema. All that material there is passed, and when you do fluoroscopy, you are able to very good samples and clean up the pleural space so that you improve the chances of the patient healing. The lower panel on the right is showing membranes. These are membranes which we see when one has a loculated effusion. And that is why sometimes by doing ultrasound and you discover your patient has a loculated effusion, you may opt to do fluoroscopy rather than just put a chest drain, because the chest tube may just drain one of the locules and the rest of the fluid is left in place. So you'd have done half the job. So all these modalities, ultrasound, fluoroscopy, they all work together to try and improve our interventions. Then if you look on the left, you can see what we see on TB. The upper panel, you can see those are the caseating granulomas. You can see on C, that is called Saga appearance, and that is pathognomonic for TB. You see that you are almost 100% sure that you're dealing with TB. D is showing the membranes that we sometimes see with TB, and in this kind of case, depending on how the membranes are, you may need to break them so that you're able to drain the effusion properly. This is in comparison with the malignancies, which is seen on the right panel, and you can see some of those are they really resemble TB. So a history is very, very important. If your patient has no fever, has just lost weight, coughing, you need to really take a good history to be able to say this is likely malignancy or this is likely TB. But some are obvious. You see masses, and sometimes you are able to get very good biopsies when you do your fluoroscopy. So advantages of fluoroscopy: minimally invasive, you can simultaneously make a diagnosis. And now what is happening, we also have to be able to say this is like tissue evaluation or ROS. So once you get your tissue during fluoroscopy, you give it to the pathologist immediately, or you have a microscope in theater, you place this tissue on a slide, you take a picture of that, and the pathologist can tell you, doc, you have good tissue, you can taking more samples, or doc, the tissue you have is normal pleural, please take more biopsies. So by the time you're leaving theater, you're sometimes able to tell the patient, this is what we find and your diagnosis is this, and you're going home with this treatment. So it is very, very effective. The other thing is that it allows us to do therapeutics, such as draining the fluid and doing fluorodesis at the same time. We have some complications. Pain is a common complication, and therefore sometimes we give local anesthesia, long-lasting local anesthesia to control the pain. Sometimes we have pneumothoraces, which we treat depending on how big they are. If they are small, we may leave them alone. If they are big, then we may have to put a tube. Rarely we get bleeding. You may introduce infection, pulmonary edema due to re-expansion of the lung, and some rare, very rarely we get allergic reactions to the. Then sometimes medical thoracoscopy is not enough, and what we may need is video-assisted thoracoscopy. What is the difference? When you're dealing with medical thoracoscopy, the procedure is the interventional pulmonologist, can be done in theater or in endoscopy. We use local anesthesia with sedation, and we generally use one entry port, and you may do a mini thoracoscopy or rigid, as I had talked about. When you're dealing with medical thoracoscopy, the procedure is the interventional pulmonologist, can be done in theater or in endoscopy. We use local anesthesia with sedation. We have single lung ventilation. So it is a more complex kind of procedure. And here we may use uniportal, that is where they are using a single entry point, or needlescopic. What is needlescopic? This is when they use very, very small ports. The normal ports are between 5 to 10 millimeters. But when we are using needlescopic, here we are using 2 to 3 millimeters. And therefore you can see things like pain complications will be much lower, but the access is still very good. Sometimes we also do it in non-intubated patients. So it's not everyone who gets video-assisted thoracoscopy who needs to be intubated. So the indications for medical thoracoscopy include pleural effusion, especially if they are unexplained, lung cancer staging if you suspect pleural cancer spread, diffuse malignant conditions, especially mesothelioma, and also if you want to do fluorodesis. On the other side, when you're doing video-assisted thoracoscopy, this is for more complex work. Things like lung biopsy, lobectomies, pneumonectomies, decortication when a patient has a reed surrounding the lung and you want the lung to expand, including things like esophageal cancer, removal of tumors, removal of cysts. You can even use VATS for esophagectomy. So quite a lot of work can be done through video-assisted thoracoscopy, and these are minimally invasive procedures. Even patients who have got chylous effusion, you can do thoracic duct ligation through video-assisted thoracoscopy. So these days, the indications for open thoracotomy are less and less because you can offer less invasive, or rather minimally invasive surgeries, similar problems as we used to need. Even patients who have got thoracotomies for, you can do thoracic duct. Complications are many but rare. So things like hypoxia, cardiac arrhythmias, pneumothoraces, prolonged air leaks, all these things can happen, but they are not very frequent. If we talk about pleural fluid management, we can deal with acute pleural effusions or recurrent collections, or loculated or chronic effusions. And but the approach is as shown. On the right, you can see an X-ray which has bilateral effusion, take a good history and find out, could this patient be having congestive heart failure? Is it kidney failure? Is it liver cirrhosis? Is it urinary thorax? All those things, because the management is slightly different. If the patient does not have a reason for all those things, the congestive heart failure, there you are thinking about an exudative effusion. If they have all those things, but they also have fever, or there is a risk of pneumonia, or you are worried about malignancy, then you're going to shift to the right side. But if the suspicion is that this patient has got a reason
Yes.
all those things, the congestive heart failure, there you are thinking about
Okay, so I hope you have muted so you can't hear us. We totally agree that it is an important topic.
But if the suspicion is that this patient has
So we agree it is an important topic.
Which doctor?
Okay, so I hope you have muted so you can't hear us. We totally agree that it is an important topic.
But if the suspicion is that this patient has
So we agree it is an important topic.
Which doctor?
Okay, so let's appreciate our ICT team. I have seen they have touched all the buttons. They have tried to touch all the buttons, but it couldn't work. So we suspect maybe he has two devices on the other side. We tried to reach out to his colleagues to tell him mute one and just have one, but it couldn't work. So I don't think there are any questions at the moment. Are there any questions for him? Okay. So we're going to try the next speaker. I'm told in different rooms, so maybe shida ni ile room ya Dr. Waweru. Let me confirm if Dr. Navid can hear us. But picking the little bit that we have picked from Dr. Aweru's presentation, I think it's interesting to hear that as a country, we are able to do some of these interventions in our government and some private hospitals. I think that's the way countries should be moving. The minimal invasive procedures are very important in this day and age to ensure that diagnoses are made quickly, healing is better, complications are minimized. I think that's the way to go. We hope to have a better talk maybe in the next conference where they'll have an opportunity to share this in details and also give some case studies of what they are doing in the country. Okay, let's see if Dr. Navid can hear us. Dr. Mahmoud, are you in the house? Abdulaziz, you know you'd have saved us here. Yes, you'd have saved us here. You see now where we've landed. But anyway, thank you. I know you'll be coming next. Let's see if Dr. Navid can hear us. Dr. Mahmoud, are you in the house? Abdulaziz.
Can
you'd
you
have
hear
saved
me?
us here. Yes, you'd have saved us
Yeah, we
here.
can hear you, Navid.
You see now where
hear
we've
me.
landed.
Okay, I
But
think
anyway,
it's
thank you.
Moses
I know
who
you'll be
can't
coming
hear.
next.
Moses, can you hear? Okay, then let me open. All right, hold on, I'm gonna do it for you.
Dr. Mahmoud, are you in the house?
Okay, I'm gonna share my screen now. Can you hear me?
Yes, you'd have
Okay, can you see my screen?
See now where we've landed.
Okay, can you see my screen? Moses
I know
who
you'll be
can't
coming
hear.
next.
All right. Okay, then I'm gonna put it on slideshow. Can you see the slideshow clearly? All right. Hold on.
Yes, you can see it.
All right. Can you see me and hear me clearly? Then we can start. Okay, perfect. Good. So I'm just gonna get started. Can you see my so thank you for having me here to think. All right. We're going to discuss lung nodule diagnostics in Kenya, specifically the advanced kind of diagnostics. We call this peripheral bronchoscopy because we're going to try to target nodules that are in the peripheral areas of the lung. I don't have any disclosures. And before we start, I'd just like to thank Riso for the chance to present here, Professor Chakaya for putting this together, my mentors, teachers, and my family, and my team. You can see the team in the photo there. All right, so lung cancer accounts for about 12% of all cancers. Lung cancer is very common. More than twice as high as any of the other cancers. And this is related to the lung cancer survival curve. For example, if you look at lung cancer when you diagnose it in stage 1, the 5-year survival tends to be over 75%. So the 5-year survival in stage 1 lung cancer is quite good. But compare it to stage 4 lung cancer, the 5-year survival rate comes to about 25%. So between stage 1 and stage 4, your survival rate drops by over 50%, and this is in the best of centers. When we look at, for example, the majority of the lung cancer patients that are diagnosed here in Kenya, most of our patients are actually stage 4 patients, which means that over 75% of our lung cancer patients will die within 5 years, which is a huge number. There are several prediction models that come to that sometimes help us when it comes to diagnosing lung nodules to tell us whether we should biopsy a nodule, not biopsy a nodule, is it a high-risk nodule, not a high-risk nodule. But one of the problems with these prediction models, for example, the Brock model, is that these models were designed in smoking populations. If you look at this mortality graph, you'll see that tobacco-related lung disease had the highest number of deaths in 2020. However, if you look at the second bar in red, I think this is the 5th one, the 5th highest mortality was actually non-smoke. Surgical treatment, you can do what we call as stereotactic radiation treatment because these are the patients that have good survival. The aim is to catch these patients in the early stage. The best is T1A or stage 1A, where the nodule is less than 3 centimeters and you have no nodal spread. The minute that you've got nodal spread, the staging goes from stage 1 to stage 2. And the more nodes that you have, the staging moves from 2 to 3 to 4. So you have to catch the lung cancer before it has moved into the lymph nodes. And the earlier you get it, the better, because one of the determinants of success of lung cancer treatment is resectability. And if you're able to resect the tumor, then you have a higher chance of success. And resectability is determined by achieving good margins. And good margins mean the nodules have to be small. We live in Kenya, so one of the things that we have to remember is that not all nodules are cancers. We cannot forget benign nodules, and this is a paper that came out of Germany, where they did a case series on lung nodules that were suspicious for lung cancer. They did peripheral bronchoscopy and cone beam CT guided biopsy, and they found a series of patients who all had mycobacterial infections. This is pretty common in Kenya because we live in a high TB endemic area. So when it comes to accurate diagnosis of lung nodules, there's several choices that we can choose, and sometimes there are too many choices. You could either, go for a bronchoscopic approach, use some kind of navigation, use robotics, use imaging systems like fluoroscopy, augmented fluoroscopy, cone beam CT. You could do an ultrasound-guided biopsy or CT-guided biopsy. Now, what helps us to decide between these is several factors. You have to balance the safety of the investigation that you're going to do, how invasive it is, what the diagnostic yield is, what's the cost. The technical expertise is very important. What's the capacity of the institution, the patient preferences, and you make an individualized, tailored approach for each patient. So it's not a one-size-fits-all. Every patient will have a slightly different approach depending on the patient factors, what are the risks, how expensive it is, what can the patient afford, do you need to perform mediastinal staging, do you have ROSE or rapid on-site cytopathology. Then you can create the best plan for each patient. When we compare head-to-head navigational bronchoscopy, peripheral bronchoscopic techniques versus transthoracic needle biopsy, this is the latest paper. It was a randomized trial done in 2025, or published this year, and there was no significant difference. There's no difference in the diagnostic accuracy when it comes to transthoracic CT-guided biopsy, which had a 73% accuracy, versus a navigational bronchoscopy, which had a 79% accuracy. The difference comes with the complication rate. Navigational bronchoscopy had a complication rate of only 5%. CT-guided transthoracic needle biopsy had a complication rate of 29%. And majority of the complications arises from pneumothorax. And the pneumothorax rate in navigational bronchoscopy was only 3%, and 0.8% had severe pneumothorax. So it was almost negligible. However, with CT-guided or transthoracic biopsy, the pneumothorax rate was as high as 28%. 11% of the patients had severe grade 3 or grade 4 pneumothorax. And that is significant because when you've got a high number of patients developing pneumothorax, it doesn't, it helps us to see which techniques are safer. So it helps us to balance and see that, okay, you've got two different types of techniques. One type, the diagnostic accuracy is the same for both, but one has got a higher complication. It's not fair to generalize and say all transthoracic needle biopsies have got a pneumothorax rate of 28%. No, of course, peripheral lesions have got, or lesions very close to the pleura have got lower rates. Lesions that are more central have got higher pneumothorax rates, but this is just a generalized data. When it comes to peripheral bronchoscopic techniques, we've got a navigation method. We use either virtual, manual, or electromagnetic navigation. You have some method of driving, so this is either a normal bronchoscope, thin bronchoscope, ultra thin. You have to do lesion confirmation using a radial probe endobronchial ultrasound, and an imaging system. So you have either fluoroscopy, which is 2D, augmented, or cone beam CT, which is the best. You have a biopsy tool, for example, a cryoprobe, a needle, or a forceps, and I'll show this to you a bit later. So when it comes to navigation systems, this is called a branch tracing. I'll apologize in advance for my bad handwriting, but this is how we do it. We convert a CT image to a bronchoscopic view. It's affordable. You only need a pen and a paper. However, it's time consuming. It's dependent on the skill of whoever is doing the airway mapping. It takes a long time to learn. And the diagnostic accuracy is similar to electromagnetic navigation systems or computerized systems when it's done by a skilled provider. This is virtual navigation. It's a software-based airway remodeling using 3D virtual models that does nodule segmentation, creates a path, and allows you to view it. I'm going to just play this video so that you can actually take a look at it. This is the Synapse 3D navigation system. This is what we have locally available. And it allows us to basically create an airway map beforehand. And we take this with us to theater so that we can know which way to go. This is an intraoperative fluoroscopy system. It's simple, it's easy to use, it's affordable, it's got low radiation dose, but it's two-dimensional imaging. If you look at the picture on the left, that's the nodule we were trying to biopsy, or this kind of nodular lesion. Then you have the radial probe signal that confirms that we've got, you know, a region or the target. And then we have the probe in the right location. But with 2D, again, you can barely see the nodule on the imaging system, but because it's a two-dimensional image. Again, this is a similar case using 2D fluoroscopy. This is the nodule we were biopsying. It's 1.8 centimeters, so under 2 centimeters. That's the signal we got. So it's a mixed concentric with a laser signal. And then you can see where the arrow is, a small arrow on the screen showing where the nodule is. And this biopsy was done, and the patient actually had a granulomatous lesion with tuberculosis. This is cone beam CT. Cone beam is the gold standard imaging system. It's 3D. It gives us tool-in lesion, means we can confirm that we are actually inside the nodule. It allows us to do real-time adjustments. However, cone beam is expensive. The machine is very expensive. It's got higher radiation. I'll show you what it looks like, and this is a video from OOR. So we have the patient on the table. We have a bronchoscope that is fixed in place, and then we've got a cone beam arm that is going to rotate around the patient and give us a 3D image. So when we get the 3D image, we can then do a full reconstruction. And you'll see it in the next slide here. I'm going to play the video here. And you can see the nodule very clearly on the 3D recon. You can see the bronchoscope. You can see the tool itself, the biopsy tool, is right in the middle of the lesion. And when we look at the reconstructions here, you can see on the axial, the coronal section, and the sagittal section, that the biopsy tool, marked by the X, is right in the middle of the lesion. So we have got tool-in lesion confirmation. So we are very sure that we're biopsying the right place. It doesn't guarantee a diagnosis. For example, you could get a necrotic area that you can't see, but it increases our confidence. This is robotic bronchoscopy. Unfortunately, we don't have this in Kenya yet. It's got excellent stability. The highest maneuverability, the highest diagnostic yield actually comes from robotics. It's got navigation inbuilt, but it's extremely expensive. There's different types of robotic systems like the Galaxy system, the Ion system, which all have different benefits. But this is how it looks. It uses some kind of controller. But diagnostic yield tends to be better when you combine robotics with an advanced imaging like cone beam CT. We have to ask ourselves sometimes, why do we do all this? Or what is the ultimate goal of spending, for example, so much money biopsying nodules when the nodules are early? Why not just wait to see, for example, if the nodules are growing? Or why not just wait and, give the patient a little bit of time, see if the nodules resolve spontaneously? And this is a study that was done in Zurich, in one of the best centers in the world, where they use robotic bronchoscopy as routine with cone beam CT, so they have all the technology here. And they actually found something very interesting when they looked at their data. So before they integrated all the technology, their diagnosis rate of stage 1A lung cancer was 24%. The diagnosis of stage 4 lung cancer was 25% for stage 4B and 13% for stage 4A. So about almost 40% of their patients were diagnosed with stage 4 lung cancer. Only 24% of the patients were diagnosed with stage 1 lung cancer. When they changed their approach and they introduced robotics and cone beam and everything, they found 55% of their patients now were diagnosed with stage 1 lung cancer, and less than 20% of their patients were diagnosed with stage 4 lung cancer. So there was a massive stage shift whereby the majority of the patients moved from being diagnosed at stage 4 to being diagnosed at stage 1. And if you look at the survival curves here, the stage 1A survival is about 84% versus the stage 4B survival, which is 4%, which means that the majority of their patients now were receiving care for stage 1 lung cancer and had a very high survival rate. And this is the ultimate goal. It's to change the diagnosis of our patients. The patient should not be diagnosed at stage 4. We want to aim to diagnose the majority of our patients at stage 1 lung cancer, because then we can cure the patient. And when they integrated the technology, you look at the graph here from 2018 to 2024, there was an increase of 290% in terms of their stage 1A diagnosis. And this is because they integrated robotics with cone beam CT, with navigation, and put it all together, and had an excellent team, and then the game changed completely. So the take-home messages for this presentation is that an individualized approach would be the best approach. You have to have a very good balance between the patient, the cost, the expertise of your center, the expertise of your team, the safety of the procedure, because your patients have to be able to tolerate anesthesia, to tolerate general anesthesia. You need to diagnose the patient earlier. The entire paradigm for lung nodules is changing, because where we could afford to wait to make a diagnosis of lung nodules, if we can diagnose these patients safely and we can do it earlier, then we might actually be able to prevent metastasis. We can't ignore benign nodules in Kenya. So even if we see a nodule and the first question is it malignant, is it benign? Even if it's a benign nodule, because we live in a high tuberculous region, we have to be able to make a diagnosis of the nodule and say, okay, is it an infection? Is it tuberculosis? Because tuberculosis has treatment, and it is unfair to let the disease spread. And early referral to a center of excellence is important, because we have to be able to say, okay, this is a patient who will benefit from this kind of technology, and we send the patient to the center that can do it. That brings me to the end of my first presentation. I believe there'll be questions later. Thank you. I have a second presentation. Should I just continue? All right. So what I'm going to do is just going to open the second one. Okay, I'm going to share my screen again. Okay. Hold on. Okay, good. You should be able to see my screen now. Can you see my screen? Yes, in presentation. Good. You can see clearly. Can you? It's okay. Can you hear me and see me? Okay, good. All right. So we covered lung nodules in the last in my previous presentation. We're going to change gears and move into an interventional approach to post-tuberculosis airway disease. And you'll excuse me if I take 5 minutes more than my allocated time, because I've got some videos on this. And there we go. Good. You can see my first slide, the introduction slide. Okay. Perfect. So post-TB airway stenosis. Now, this is the leading cause of tracheobronchial stenosis in endemic areas. Endobronchial TB is actually more common than we thought. It occurs in between 6 to 50% of tuberculosis. Or who have endobronchial TB will develop some form of airway fibrosis. This occurs because there's some kind of airway injury, there's scar tissue formation, there's permanent airway damage. This causes now dyspnea, chronic complications, and even a complete lung collapse. But post-TB airway stenosis is one of the very common complications. We have to first ask ourselves, and this is an interesting paper that was published from here, what are the factors associated with post-tuberculosis lung disease? What's the magnitude of this problem? And this was a good systemic review done by Professor Obimbo and her team. And if we looked at the prevalence of abnormal lung function, so this was based on spirometry findings, 46% of patients who had tuberculosis developed abnormal lung function, which is almost half the patients, which is a huge number. And 41% of patients who had tuberculosis had persistent respiratory symptoms. So it's not something we can ignore. It's almost half of our patients will have abnormal lung function. Almost like half the patients will have some kind of chronic respiratory symptoms. There's an interesting paper that came out of Korea, which looked at what was the incidence of endobronchial TB. Because we know that patients who have endobronchial TB are at high risk of post-TB airway stenosis. The incidence of endobronchial TB was actually 54%. It's more common in ladies, 69% versus 43%. 46% of the endobronchial TB lesions were in the lobar bronchi, and that is significant because lobar bronchi, if they get stenosed, can cause respiratory problems. Segmental bronchi tend to be less problematic. So more than half of the patients with TB actually had endobronchial TB. And if we look at how many patients who had endobronchial TB developed stenosis, grade 1 stenosis was present in 79% of patients. So it's actually the majority of patients actually develop some kind of stenosis, and they graded it in 3 grades, so up to 1/3, 2/3, and 3/3. So grade 1, so up to 1/3 of the airway was stenosed in, 79%. And grade 2 and 3 stenosis, which is severe stenosis, was moderate to severe, was present in 20% of patients. So again, significant. These are big numbers. We ask ourselves, is there light at the end of the tunnel? So, you know, when we've got this big problem, is there anything we can do to fix it, or is there anything we can do? And this is where interventional bronchoscopy starts to become very important. The first thing to do is to try to classify post-TB airway stenosis, and the best way is actually the Freitag classification. We do it based on the location: upper, middle, lower, right main bronchus, and left main bronchus, the degree. So from 0 to more than 90%, we can classify how severe the stenosis is. Then we can classify it based on the morphology. For example, intrinsic, distortions, if there is a saber-shaped trachea or some kind of tracheomalacia, excessive dynamic airway collapse, web stenosis, extrinsic compression. So this is based on the morphology of stenosis, and this is the most comprehensive way to classify airway stenosis. So what imaging tests should we do? Preliminary HRCT is mandatory. X-ray helps. It's not that it doesn't. It helps, for example, if the patient has a lung collapse or if the patient has tracheal stenosis, but you still need a CT scan anyway because you need to check the length of the stenosis. You need some information on the complexity. You need the CT if you're going to plan stenting, some kind of intervention or surgery. And with the CT, you can do a virtual bronchogram or a virtual bronchoscopy. If the patient is suspected to have malacia, then you have to get a dynamic CT, which is done during an active expiratory and active inspiratory phase. It's difficult to do. Very few centers actually do this properly. These investigations help bronchoscopic diagnosis and help increase procedure planning. Spirometry is good. It helps with large airway disease, but the results are very variable. Usually when you see the classical flattening of the inspiratory limbs on spirometry, the disease tends to be very advanced, and it's not always the present. So we asked ourselves, what's the role of bronchoscopy in the diagnosis of post-tuberculosis lung disease? Actually, diagnostic bronchoscopy is recommended if you suspect endobronchial TB. All patients who have had endobronchial TB ideally should have a surveillance bronchoscopy post-treatment. If they're symptomatic, they should have a diagnostic bronchoscopy earlier. If patients with tuberculosis have wheeze, stridor, or persistent dyspnea either after or during treatment, they should have a bronchoscopy. It's commonly misdiagnosed for asthma, so a lot of patients who have got post-tuberculosis lung disease get treated for asthma without improvement until they end up getting some kind of a bronchoscopic diagnosis. If there is evidence of stenosis on imaging, they need it. And if there's any evidence of lung collapse, then this is urgent. So this is where you don't delay, because a delayed intervention could lead to a destroyed lung, which becomes unsalvageable. So bronchoscopy is the gold standard for diagnosis of airway stenosis. In terms of therapeutics, the first thing we usually do is dilatation. It's the mainstay of bronchoscopic therapy for airway stenosis. You can do balloon dilatation or rigid dilatation. You can do electrocautery or laser assisted. It depends on the equipment, it depends on the expertise. You can repeat the dilatation up to 3 times and even every 1 to 2 months. So it's something that's done quite frequently, done quite commonly. This is a picture of a controlled radial expansion balloon that's opening up a stenotic airway. Airway stenting is usually one of the key modalities. This is a large study done in Korea on rigid bronchoscopy post-tuberculosis on over 400 patients. 83% of patients actually required a stent, and 17% of patients had dilatation alone. The good thing is that even in the stented patients, they achieved stent removal at 70%. 28%, which is a large number, required a lifelong or permanent stent. And where the region that was affected was left main most commonly, followed by right main bronchus and then the fracture. In terms of the stent, silicone is always preferred in benign airway disease and is preferred compared to self-expanding metallic stents. Straight stents are used more commonly compared to angulated stents. Y stents very, very rare. Post removal of stents, 84% of patients after repair had stable outcomes, with a good FEV1 more than 75% after 1 year. So in a large number of patients who received bronchoscopic treatment, the majority of the patients actually had sustainable or stable long-term outcomes. However, 20% of patients needed repeat stenting, again, which is a large number. Stent-related complications are definitely there, granulomas, migration, and all of that has to be factored in when making a decision. This is a video of post-TB stenosis, courtesy of a colleague and a friend, Dr. Nicolas Gilbert from Toulouse. And this is how a really stenotic left main bronchus looks like. It's almost obliterated. There is almost no lumen, it's just a pinhole. And this is usually the kind of airway that needs urgent repair. And this is how the airway looked after repair and after placement of a silicone stent. You can see there is good airway patency. The main bronchus is open. There is a stent there to support the airway because this is an unstable airway. And you can see the upper and lower lobe bronchi and segments quite clearly. And this is a very good outcome for a very severe stenosis. In such a patient, normally, if an airway like this was not repaired, the patient usually would end up with chronic infections and most likely would end up requiring a pneumonia. When it comes to mitomycin C, many people ask about the usefulness of this. This is a study done actually by my mentors here in Istanbul, where they did a comparison of patients who received mitomycin versus those who didn't. There was some benefit. The percentage of patients who required repeat dilatation or repeat airway interventions was actually lower in those who received mitomycin versus those who didn't. This is one of our own cases, 21-year-old male who had tuberculosis. He had an obliterated left main bronchus, and he had multiple webs in the right main bronchus, as you can see. He actually had distortion of the carinus. This is actually a complex repair. And I'll show you how it looks after. So this is after laser-assisted balloon dilatation. The left main bronchus is now completely open. The right main bronchus, the webs have been cut. The airway is taken. We opted not to place a stent in this patient because the airway was stable, but also because of financial reasons, social reasons, difficult follow-up, so we opted not to stent here. This is a second patient who had TB. She's a 42-year-old lady. She had tuberculosis twice with endobronchial involvement. She had chronic wheeze, she had shortness of breath, and a complex left main bronchial stenosis. More than 50% of the lumen was occluded, and she had Malaysia as well. If you look at the CT scan, you can see the difference between the right and the left main bronchus. The left is actually more than half the size of the right bronchus. This is when the inspection bronchoscopy done. And you can see the left main is already affected. It's got a conical kind of taper, and it's got a severe stenosis at the distal left main bronchus. The bronchoscope can't even pass through, so it's quite badly affected. So we opted to do balloon dilatation for this patient, and this is how the airway looks post-dilatation. You can see the distal left main looks quite good. You can see the upper lobe, which is still significantly stenotic, but you can see all the lower lobe segments very clearly. The airway is nice and open. The bronchoscope can go through. So this was a good case. We applied lithromycin in this patient, and this was how she looked on a follow-up bronchoscopy that we did after about 2 months. And what you see here is there is some depth expiratory central airway collapse. There is an invagination of the posterior membrane into the lumen. However, the lumen is still patent. And in this patient, because the expiratory central airway collapse or the Malaysia was not severe, her symptoms were much better. She could carry out her daily activities comfortably. We opted not to stent her. Instead, we opted to do repeat dilatation. And that seems to have worked well for us. So we try to avoid stenting in general because stenting has got a large number of complications. However, if the patient will benefit, then you shouldn't withhold them. Is there a role for surgery? So if you've got a complex stenosis that's more than 1 centimeter, especially with tracheal stenosis, you can do a resection in end-to-end anastomosis. If you have tracheomalacia, if it's short segment, you can do resection and anastomosis. If it's long segment, then you need to consider doing a tracheoplasty and placement of a mesh, and this is done after a stent trial. Then there's surgical bronchoplasty, which can be done, but it's not that common. In my experience, or at least from our center, we haven't had a patient who requires it. We tend to prefer doing the bronchoscopic approaches first. The take-home from this is that with every patient who has post-TB stenosis, the counseling is very important. You have to evaluate and see, does the patient have symptoms? Does the patient have recurrent pneumonia? Does the CT scan show salvageable lung? Or are you just going to open a bronchus that is patent, but the vasculature is destroyed and the parenchyma is destroyed, then you only increase dead space? You need to counsel the patient on the outcome success rate, the need for repeat procedures. We always write to the insurances and we tell the patient that this is never or almost never going to be a one-time procedure. They have to come back for surveillance, come back for repeat dilatation, sometimes even 3 or 4 or 5 times. So they have to be ready for that. Before stenting, we always discuss the implications, the post-stent care, surveillance bronchoscopies, and the cost. Because these are not cheap things to do. These are expensive. The equipment is expensive. And the patients have to be aware that this is something that is going to take, 1 or 2 years of interventions before the outcome or before the treatment is sustainable. And we'll stop here now. I think we've made it within 15 minutes, and we can leave it open for questions.
I hope this was much better. Did you follow through? So I hope you can hear. It is on. Is it on?
I can hear you. I can't hear the audience.
Okay. So
No problem. Thanks.
can you hear me? Mimi niko hapa, mnanisikia? Okay, so we which one? They're not working. Okay, this one is working. So thank you, Dr. Navid and Dr. Waweru. We appreciate the two presentations that have been done. And okay. Okay, so now we want to take questions. I don't know if there are any questions, and I hope you're able to follow through. Okay, thank you. So there are some hands up, and I'll be taking the mic. I hope you will be able to hear this and respond.
If I can't hear, then you can always repeat the question.
Okay. So I start with Prof. Aloch.
Can you hear me, Navid?
I can hear.
Thank you for excellent presentation. I'd just like to ask you a simple question. As technology advances in medicine, there will be less and less invasive procedures for diagnostic purposes. Do you see a place of virtual biopsy in the diagnosis of some of these lung nodules?
Hi, sorry, the audio is not that clear. Can somebody just repeat the question for me close to the microphone that's feeding the virtual stream?
Do you see, can you hear me now?
Yes, I can hear you.
Do you see a place of virtual biopsy in the diagnosis of some of these lung nodules in future to replace invasive procedure?
Virtual biopsy.
Mm-hmm.
Yes, so there's an interesting technology. It's called confocal laser endomicroscopy, where basically a specific endomicroscope is put through the working channel of the bronchoscope. So when you get to the nodule, then you put something called a confocal laser endomicroscope.
No.
You can actually
that is not virtual biopsy.
The nodule and can give you guidance on whether it's malignant or benign. However, the goal is always to get tissue, because even in the future, I think we will still need tissue for genetics or next generation sequencing, immunohistochemistry, standard histopathology. I think the amount of tissue that is required will go down as the pathology becomes more advanced, but I think they will always need tissue.
What I say is that in virtual biopsy, you don't take any tissue.
I think it's a potential, but I think we're still very, very far from that at the moment, because pathology still requires tissue for any kind of custom-made diagnosis.
Actually, virtual biopsies in an AI enables the reading of the radiological images, not physical biopsy.
Okay, thank you. So we take the next question. Any other questions?
Thank you for the wonderful presentation. What's the average cost of diagnosis of these complications and management, and where these services available? For example, ballooning and stenting, the ones that you just said.
Okay, I hope you heard that. Allow me to take the third one, then you respond to all of them.
Thank you for the good presentation. My question is on the nodules. So not all nodules are... Can you hear me?
Just speak slightly louder, I think, because it's catching the audio.
Okay. So my question is on nodules. Not all nodules are cancerous, but you've talked of nodules which have spontaneous resolutions. Maybe you can comment about that.
Okay, so you can respond to those ones first.
Okay, good. So I've got both the questions. The first question was on cost. Dr. Waweru, who's online with me, can even answer that. So most of you know Dr. Waweru is my colleague and partner. We work together. So Dr. Waweru, you can answer that question on where the services are available and cost.
Is Dr. Waweru still in?
Okay, I think maybe he will be.
Okay.
Might be. All right, it's okay. So I'll just answer this. So services are available. The balloon dilatation, stenting, everything that I've put in the presentation, including the videos, almost all of those are actually our videos, our case videos from procedures we've done, except robotics. I think the only thing that we don't have right now is robotics. Most 90% of the interventional work is done at Avenue. That's where our IP or interventional unit is based because of the equipment. But a lot of the work can be done now, I believe, at Kenyatta. I think they've got some capacity to do some of the airway work as well. Other hospitals, a lot of our equipment can be moved around. So sometimes we can move it, for example, say to NP Shah or another private hospital. But for all purposes, yes, at Avenue, that's where most of 90% of the equipment and everything is, especially when it comes to like the cone beam machine, the radial probe ultrasound, and cryo machines, and everything is based there. In terms of cost, it's very variable. For example, the cost of placing a stent is very high. And the reason is the stent alone costs almost 1,000 euros. That's just the stent. You have to do the procedure under general anesthesia. You have to do the procedure, for example, in theater. It takes about almost 2 hours. You don't know how much equipment you need. So it's costly. A lot of the time, we try to subsidize the costs for patients who can't afford. If we were, for example, placing, a silicone stent with balloon dilatation, everything can cost almost 300 to 400,000, because even the balloon is not cheap. Sometimes you use more than one balloon. Sometimes you actually place a stent and find that the stent isn't fitting right, and you need to place another one. So it's costly. What we try to say is that even if a patient cannot afford it, refer the patient, because a lot of the time we do charity programs, we do cases for free. We try to see if we can get a donation to help the patient, because we don't want, for example, patients to develop long-term complications because they couldn't afford a life-saving procedure. So if you do have some of these patients, even if cost is an issue, just refer, because we try to work around the cost or try to see what we can do to lower the cost of this procedure. When it comes to nodules, yes, there's some inflammatory nodules, for example, infectious nodules, or nodules that are as a result of a previous infection. For example, nodules that are fibrotic in nature, don't change. Perhaps a patient has some viral infection that can cause nodules that are inflammatory. Those tend to resolve spontaneously. Patients who have bacterial infections, they get antibiotics, sometimes the nodules disappear. The hard part is trying to know what's what, especially in a tuberculous endemic region, because a lot of the time, even patients with TB will respond to broad-spectrum antibiotics for a short period of time and to a certain extent. It doesn't mean the TB gets cured. It just means they feel a little bit better. And that's why, at least in our setup, we tend to be a little more aggressive even on nodules because of the diagnosis rate for tuberculosis. We're actually publishing our data, which will be ready probably on the first maybe 20 to 40 radial probe cases that we've done, just so that we can show the kind of diagnosis that we get. A large number of our diagnoses tend to be infectious. In fact, we had a young lady who had a nodule, and it was a resistant bacteria, and that was based on the culture that we took out of the nodule. So we're a little, in the West, they tend to stratify the patients more based on malignancy risk, but in the West, the tuberculosis prevalence is much lower. We don't have prediction models yet designed for African or low-income countries. So we tend to be a little more aggressive because we have found from our experience that when we biopsy these nodules, even if they're not malignant, we find, for example, fungal infections, tuberculosis, some kind of resistant bacteria, and it helps in changing the treatment of the patient, especially when we know that the complication rates are very low.
Okay, Dr. Kagima, hi, and good to see you. I don't know if you can add anything about the cost in Kenyatta.
Hi, Navid. Yes, we do.
Hi, Jackie.
We do the procedures in Kenyatta National Hospital. We can balloon, and it's covered by SHA. We can, what else did he talk about? We have EBUS, and it's also covered by SHA. So for those who, SHA is able to cover everything. So most of our patients come, so long as they have SHA, they don't even need to add a single coin on top. So we've done enough ballooning. We've done a couple of ballooning, but of course, Navid has done a lot more than us. We've done a few EBUSes. Navid's center has done a lot more than us, but we collaborate a lot. If there's a patient in their center who cannot afford, they bring to Kenyatta and we're able to do. So we are a team, really.
Yeah, absolutely.
The patients presenting to you
fact,
with...
we spent a lot of time doing cases in Kenyatta. And we do this because we want to help the patient. So the aim is just to help the patient from developing a severe complication.
Okay, thank you. So what I was saying for the clinicians in the house, the post-TB patients that you see presenting with difficulty in breathing, the hemoptysis, if you have done all you can, please get to know where you can refer them for further help. You could be dealing with a case of tracheal stenosis and the other complications that Doc has talked about. So that brings us to the end of our Symposium 6B. And I see it's time for us to take a break for tea. But before you go, you can agree with me, it wasn't so easy. So please appreciate me for being able to ride this with you. Okay, so thank you also for your patience and listening through. I know we had challenges, but you were able to navigate through. And we are Kenyans. That is Kenyans for us. We really find solutions in everything, and we move on. So thank you so much to our online listeners. We really appreciate. So let's break for tea to save on time. I don't know if we can take like 20 minutes so that we are here at 11:05. Thank you.
He holds an MSc in epidemiology from the London School of Hygiene and Tropical Medicine and is currently a PhD candidate in infectious disease and tropical medicine. Dr. Gidua concurrently serves as a principal investigator, leading a research from University of Washington supported study investigating on post-TB lung disease in children. This innovative research examines clinical, structural lung function and biomarker changes following TB disease. A critically underexplored area in pediatric TB care. As part of this groundbreaking work, she has pioneered the use of oscillometry in pediatric post-TB lung disease assessment, collaborating with investigators from University of Washington, Tulane University, and Cambridge. Having received specialized training in oscillometry from the Red Cross War Memorial Children's Hospital in Cape Town and the Pan-African Thoracic Society, Dr. Gidua has driven the training and certification of 16 staff across different cadre in oscillometry within Cambridge, building local capacity in this advanced lung function assessment technique in East Africa. She also serves as sub-investigator for pediatric TB diagnostic research, examining novel non-sputum-based diagnostic methods, as well as multiple clinical trials involving a wide scope of diseases, as well as the laboratory led under the mentorship of Prof. Fidelis Duba. Driven by deep passion for improving child health outcome, Dr. Gidua has dedicated a research career to addressing critical gaps in pediatric TB care, with particular emphasis on post-TB lung disease, an often overlooked consequence of childhood TB that can have a lifelong implication for respiratory health. Dr. Gidua's work has been presented at prestigious local and international conferences, including International Post-TB Lung Disease Conference, the Union World Conference, and the European Society for Pediatric Infectious Disease. She is a recipient of some prestigious competitive grant and award, and is a selected member of the University of Washington Early Stage Investigator Group, where she receives structured mentorship from established investigator in TB and HIV research. So let's welcome Dr. Gidua. She has passion for peds, you can see. Karibu sana daktari. The second speaker for this session will be Dr. Lucy Kinjaro. Dr. Lucy is a research scientist and a medical doctor at the Cambridge Center for Respiratory Disease Research. Our research interests focus on TB with experience in coordinating multiple clinical trials and investigating post-TB lung disease in adults. She is currently pursuing a master's degree in public health. Dr. Kinjaro is passionate about advancing TB research and capacity building in respiratory health and benefits from mentorship under Prof. Fidelis Duba. And also Jeffrey and Dr. Joy Gidua. Karibu sana, Dr. Lucy. Let's give a hand of applause. Thank you, Daktari. Then we have our third speaker for the day, Dr. Mahmoud Abdulaziz Mahmoud, who is a physician pulmonologist with master's degree in internal medicine and fellowship in pulmonary and tuberculosis from Alexandria University. He is a member of Respiratory Society of Kenya, Pan-African Thoracic Society, American Thoracic Society, and European Respiratory Society. He is also an interventional pulmonology with experience in bronchoscopy, medical thoracoscopy, and ultrasound-guided chest procedures. He also has certificate for training in critical care and sleep medicine. Let's welcome Dr. Abdulaziz. Karibu sana, Daktari. Our fourth speaker is Eric Ouma, who is a respiratory therapist. He holds MSc Respiratory Medicine, University of Chester, BSc Physiotherapy, Moy University. He has experience in respiratory physiotherapy from University Hospital, Dorset, England. Expatriate respiratory physiotherapist, and also head of Department Vista Services and senior physiotherapist, AVA Medicare. Let's welcome Eric Ouma. Our last presenter for this session is Dr. Brenda Nyambura Mungai, who is a seasoned global health expert with PhD in global health and over 19 years of experience in advancing TB, HIV, health system program across Africa. She has led multi-million-dollar USAID projects, served as Director of TB and Lung Health at Center for Health Solution, Kenya, and contributed as a TB expert on the Global Fund Technical Review Panel 2019 to 2024. Brenda is recognized for her leadership in deploying digital innovations such as AI-enabled X-ray screening, designing strategic guidance, and strengthening national TB programs. She's currently leads research uptake in UK AID-funded LIGHT Consortium under the African Institute for Development Policy, AFIDEP. Karibu, Dr. Brenda. Give them a very big applause. Thank you so much. I think we are ready for the first session.
All right, so good morning, everyone. Thank you for that kind introduction. And so today we'll be having a dual representation of our study, and that is from me, Joy Gidua, and from Dr. Lucy Kijaro, and we'll be speaking on post-TB lung disease, and this is in both adults and children. So I'm just waiting for the slides. And just to note that the work is a collaboration between KEMRI CRDR, Tulane University, University of Washington, University of Nairobi, and Kenyatta National Hospital. So in terms of the background, I think we've heard quite a bit about the burden of TB in this forum, globally and in Kenya as a country. And what we have seen that is quite encouraging is the improved incidence and improved mortality rates. But what we are missing from this is an actual map of the outcomes after TB treatment. So what really happens and where in the world does it really happen and what's the burden? So post-TB lung disease has, so in terms of TB, we've already seen that 10.8 million, there are 10.8 million cases of TB with 1.25 million deaths. And what we've seen from literature is half of the persons suffering from pulmonary TB actually develop post-TB lung disease. And that means globally that's about 4.8 million incident PTLD cases. And in, okay, all right. I hope I was audible. So, and in Kenya, that would potentially mean, from the statistics that we've been hearing, that would potentially mean 50,000 cases per year. So just emphasizing more in children, and why are we looking at children is because they're really neglected. So in terms of the burden, we found that children contributed to 12% of the total TB cases reported, and 16% of the TB mortalities that have been reported. And what we currently know is that a lot of the children are actually not identified, about 50% if we were to approximate this. And we have seen that when they receive treatment, the outcomes are really good, 91% and over in the drug-sensitive TB and over 80% in the multi-drug resistant TB. So just going into the definition of post-TB lung disease, which will be our focus of the talk today, and it's defined as evidence of chronic respiratory abnormality with or without symptoms attributable at least in part to previous TB. So we have found quite a bit of gaps in the knowledge in PTLD. We have very few prospective studies that have been conducted. A lot of them are spanning only up to 1 year, many of them being cross-sectional. So just giving you a snapshot of what is happening at various time points. And what remains unknown is the temporal progression, the risk factors for PTLD in both adults and children. So children are known to be particularly vulnerable to TB and TB-related damage. Yet we do know the long-term respiratory consequences in the pediatric population. We don't know whether post-TB lung disease would actually affect their development. So currently there's been a lot of talk on post-TB lung disease. But what we do not have is standardized evidence-based guidelines existing for post-TB monitoring and management. And in children, a lot of the data has been extrapolated from adults. So just getting into the immunopathology, and I won't dive too deep into this because it's been talked about previously. But just focusing on post-TB lung disease, so we know when the mycobacterium enters the lungs, the alveoli try to engulf this bacteria. And what happens beyond this is a cascade of immune responses. So there's the immune responses that are divided into two, the innate immunity, and there's the adaptive immunity. So the innate immunity from this would really involve the type 1 interferon gamma, the TNF, the interleukin beta, and the MMPs. And while the adaptive immunity would really be focusing on the T cells producing the interferon gamma and the TGF beta. So what all this means is that there's inflammatory responses that are going on. There's also anti-inflammatory and pro-fibrotic processes that are going on from all these mediators that I've mentioned. And the paradox is, while all these mediators are trying to curb replication of bacteria, they are also causing further damage to the lung. So there's airway narrowing going on, there's tissue damage from the pro-fibrotic mediators, and this highly results in what we see, or what we are commonly referring to as the phenotypes obstructive or restrictive disease. And with obstructive disease, this is where there's airway narrowing, and the restrictive disease is where there's parenchymal damage, the fibrosis that we are seeing, the bronchiectasis, and what have you. So we designed a longitudinal cohort study, and this is over 24 months. And our population was mainly adults over 18 years of age with pulmonary TB. And the children that we included for post-TB lung disease particularly are under 18 years of age. A lot of them were enrolled with presumptive TB, and so with or without HIV in both populations. So we followed these populations up over a period of time, and we conducted quite comprehensive assessments from the clinical to the radiological to the lung function and laboratory. So you could be familiar with a lot of this, with these assessments. So just getting into the specific aims, and particularly in the adults, we sought to determine host characteristics and circulating plasma biomarkers associated with pulmonary function decline and PTLD over 2 years or follow-up in Kenyan adults with or without HIV. So really, who develops PTLD and what are the risk factors? And then we went on to define the true spectrum of post-TB lung disease manifestations in children and try and develop a comprehensive classification system for pediatric PTLD phenotypes. And I'll tell you why we did this shortly. So as I mentioned the assessments, I'll just narrow down into the spirometry and oscillometry, which a lot of you may not be very familiar with. And so for spirometry, this is a basic lung function assessment, and it measures how hard and how fast you can blow out air. So with this, there's parameters that are involved that would indicate either abnormal or normal lung function. For abnormal, we have obstruction, and this is basically narrowed airways. You can think of it as trying to breathe out through a straw. So that's an obstructive pattern, and mainly in asthma, and yes, mainly in asthma. So for the restrictive patterns, so this is where we find there is reduced lung volume. And getting into oscillometry, so oscillometry is pretty novel, and it's pretty critical in terms of measuring PTLD, especially in children. And children are unable to perform spirometry just because of the maneuvers that are involved. So oscillometry's technique involves just breathing out normally, in and out. This is tidal volume, and it will give you a picture of what's going on in terms of the lung function. So I think at this point, I will invite Dr. Lucy Kijaro to just give us the adult PTLD report.
Thank you, Dr. Joy. So I'll briefly take us through the adult PTLD report, and then she'll resume with the pediatric PTLD reports. So the slides are not, okay. So what we have here is a bar graph. We've managed to do more than 900 spirometries for our participants. And this bar graph basically highlights the different time points that we've done these spirometries. And what is notable is that there's a significant number of participants who continue to have persistent impaired lung function. We further did interim analysis for 254 participants at month 12 because we wanted to answer the questions whether there are baseline characteristics that predict abnormal lung function 6 months after treatment completion. So when you look at this table, we have baseline participant characteristics and compared to abnormal lung function, which is PTLD in this case. And the ones that we found were related to PTLD was a lower BMI, a lower MUSC, cavitation on chest X-ray at baseline, and increased involvement of chest X-ray quadrants and a shorter time to culture conversion. Additionally, at month 12, we reviewed their symptoms, and those who had persistent symptoms, we were able to see that there was association with PTLD. So when we look at the PTLD subgroups, we have obstruction and restriction, and the characteristics that we noted was we noted a lower MUAC was associated with both obstruction and restriction, and also a lower cough peak flow was mostly associated with obstruction, and a higher CRP was associated with restriction. So this means we can use nutritional and inflammatory markers, plus simple bedside measures like cough peak flow to identify TB patients who are at risk of PTLD. We also note that a worse nutritional status, radiological disease burden, and symptom persistence are associated with PTLD. When you look at the two abnormalities, restrictive pattern and obstructive pattern, for restrictive pattern, involvement across the chest quadrant was highly linked with a high risk of developing restrictive pattern PTLD. while for obstruction we had a history of prior TB, involvement of chest X-ray quadrants, and lower cough peak flow was associated with obstruction. Another thing that we managed to do was we did CT scans for these participants, and out of 110, and this is in the adult group, we noticed that only 4 were considered normal by the radiologist. And so that is actually a very significant finding, that as much as we might not pick everything on chest X-ray, when you do further detailed investigation, you notice that more people are actually affected. And the common abnormalities that were noticed was traction bronchiectasis, micronodules, lobar or segmental collapse, emphysema, cyst, and pleural disease. So I'll hand over back to
we found that 30% of our children (24 months), and for age, higher age or increasing age was associated with PTLD at 24 months, but not at 12 months. And for BMI, this was, and MUAC, this was contrary to the results we had in the adults. So a higher BMI, a higher MUAC was actually associated with the risk of PTLD at 24 months. So with the binary approach, yes, it gives us good epidemiologic data. We are able to see the current burden, but then now what do we do with the definition of PTLD? How do we manage these patients? So how do we provide precision care when binary classification actually obscures clinical reality? And from this, I'm just showing you 3 different children, 3 different presentations, and 3 different types of management. And currently what we are doing is a one-size-fits-all in terms of management. So what our solution was is replace the binary thinking with component-specific analysis. So going into the evolution analysis, what we found is for symptoms and respiratory abnormalities, there was great improvement over time from 12 to 24 months, but there were still children who had persistent pathology on the chest X-ray or residual clinical symptoms as well. What we found that was interesting is for the abnormal spirometry, children with abnormal spirometry, they had persistent lung dysfunction. This is about 25% at 12 months and 24% at 24 months. The hidden disease, and this is for oscillometry that is not naturally conducted in our clinical settings. So oscillometry was able to detect 47% of the children with abnormalities at 12 months, and 38% also presented with abnormal oscillometry at 24 months. And this is an an important point because this was undetected small airway disease. So we, using the components, we defined into 4 distinct clinical phenotypes, and this was either normal recovery, respiratory dominant, structural damage, and mixed pattern. And just for definition, for normal recovery, this is as per clinical structure. So normal recovery will be defined as having a normal radiology and having normal, resolved clinical symptoms. And this is what is currently happening because we don't have a lot of other of the investigations available. So what is promising is that a lot of the children had actually recovered based on this. And looking at the respiratory dominance, we found up to 11 to 20% over the 2 time points, having just respiratory symptoms with normal imaging. Structural damage, that's chest x-rays that were abnormal with minimal to no symptoms, identified 11 to 12% of the children over the 2 time points, and those that had mixed pattern identified 2 to 7%. So mixed pattern is both structural and symptoms. So even when they've been identified as having normally recovered per se by symptoms and radiologic abnormalities, by performing objective lung functions, we were able to identify 24% more with abnormal spirometry in the normal recovery group and 43% with abnormal oscillometry still in the same group, telling us that by discharging these patients under normal recovery, we might be doing them some injustice. So just looking at the comparison between normal oscillometry and spirometry. So we had 21% of the children with normal spirometry and abnormal oscillometry, and then again 14% with abnormal spirometry and normal oscillometry. And what the key point here is that 36% of the children would have been misclassified by just doing 1 lung function. So what does this all mean? So we are trying to move, while complementing the existing systems, we're also trying to move from the one-size-fits-all care and getting into more of the targeted interventions. So who do we treat? What do we treat? When do we treat them? How long do we follow them up? Do we have these protocols existing currently? And so what we actually do need is standardized protocols with highly clearly stipulated algorithms that would guide the clinicians on what, who, when, and where to treat. And then treatment approaches that have been currently proposed have been extrapolated from COPD and asthma protocols. So do we have age-appropriate modifications for bronchodilator therapy? How long, when do we start it? And a lot of other questions around this. Preventative care, this is evidence-based, and so vaccinations, smoking cessation, and smoke exposure prevention is still quite highly valid. So what we are saying is, or advocating for, so PTLD services need integration into TB programs with dedicated adult and pediatric pathways. So just a highlight of what's happening at Kemri CRDR. It's become potential center for excellence for spirometry and oscillometry, having certified staff for these 2 tests, and also an increasing number of people trained in DLCO. So what's next? We have clinical decision-making gaps, as we've seen. We actually require algorithms that will guide the clinicians on the steps to take in terms of identifying and treating these individuals. We require pulmonary rehabilitation protocols that are age-specific. We require systematic screening implementation and just health system integration. So I would like to acknowledge a lot of people. You can see a lot of people have contributed to making this work. I think in particular, those that are in the room are Prof. Videlis Nduba, Professor Elizabeth Obimbo. I would also like to acknowledge Dr. Jane Ongango, and from all these others that are mentioned here. So thank you.
Let's give them a very good clap. Thank you. Thank you so much. That was post-TB lung disease in children and adults emerging study finding. You'll keep your question. We'll go to the next session that will cover COPD and bronchitis care in resource-limited setting, innovation and gaps by Dr. Abdulaziz. Let's clap for him as he comes to the podium. Karim.
Thank you very much for this opportunity to present the COPD. Thank you. So I have no actual potential conflict of interest in this presentation. My outline of presentation will be simple, just to see disease burden and the risk factors, especially in our setup, COPD phenotypes, pathophysiology, what are the gaps and challenges that we are facing, and what updates in terms of GOLD guidelines 2025, and of course management of comorbidities in COPD patients, bronchoscopic interventions in brief, and what are the innovations and the novel pharmacotherapy that we have. So as we know, COPD is quite a heterogeneous disease. It's not a disease that presents in all patients similarly. Patients have persistent of these symptoms, coughing, wheezing, difficulty in breathing, and indeed they already have structural abnormalities in terms of the airway and the alveoli, what we call bronchitis and emphysema. And of course there is usually an insult or an irritant, either smoke or biomass or post-infections. Indeed, it results to significant airflow limitation. So why I underline airflow limitation is that it's not airflow obstruction, it's actually airflow limitation, and this will be seen in the pathophysiology of the obstruction of the airflow limitation. So in terms of disease burden, we all know it's quite high prevalence. It's the third leading global cause of death. Sixth global deaths by COPD. And you can imagine most of those deaths occur in low middle income countries, more than 90%. So in a nutshell, we really have to up our game in terms of disseminating the guidelines, creating awareness of this disease. Most people in the rural areas are aware of asthma. They can tell you PUMU and all that, but when you mention COPD, it's quite vague for them. So there's a lot of need for sensitization in terms of the disease itself and what are the risks. This publication done in UK, CPRD, actually showed the major cause of COPD patients, major cause of death is actually the disease itself. And it was more than even cardiovascular risks, infections, or even malignancy. So actually treating the disease in a holistic way is the will really help to reduce the mortality. So what are the gaps and challenges in our setup? Indeed, we have a lot of challenges. We all mentioned yesterday in terms of availability of spirometries and other diagnostic tools like CT scan and all that. We have challenges in terms of training of healthcare workers. We have challenges in terms of costs of inhaler and even the availability of those inhalers. We also have challenge in terms of accessibility of vaccines. You can imagine you might be in a major town, and if you ask most of the level 5 hospitals, do we have these vaccines, pneumococcal vaccine, influenza vaccine, COVID vaccine? Most of them they don't have. So the patients are forced to go to the private sector, and it's still costly. We don't have actually trained most of the trained personnel in pulmonary rehabilitation. We have a physiotherapy department, but if you interrogate thoroughly, they are not really well trained on pulmonary rehabilitation. And I'm happy that the next speaker will be venturing on that. Oxygen therapy, availability of concentrators, or even how much does a concentrator cost, up to 80,000-90,000. So we can see we have these challenges across board, both in rural areas and also urban areas. And we really have to come up with solutions. And part of the solutions is to follow the API's mnemonic, whereby our solution should be affordable, practicable, cost-effective, acceptable, safe, and equitable. So part of the solution is actually training, like doing thorough training of our healthcare workers, both in level 3, level 4, in terms of diagnosis of COPD, performing spirometries, awareness in terms of health talks and primary prevention, encouraging community health care workers on terms of follow-up of these patients, and even teaching patients on the risk factors. So all these interventions are quite needed urgently. This was a study that done in East Africa, showed actually most of the international guidelines were not really addressing the different issues in COPD in low middle income countries. We could have challenges in terms of case findings. We could have challenges in terms of reporting, challenges in terms of disease education. So the need for our own local guidelines in terms of COPD management with addressing our local challenges will be really forthcoming. So the risk factors, as you know, the most important risk factor is household air pollution, and you have both indoor and outdoor air pollution. So all these risk factors need to be addressed. Of note, post-TB and HIV indeed is a big menace in terms of the cause of COPD. We have malnutrition, we have childhood respiratory infections, and of course secondhand smoking. So this etiotypes is just to highlight the major etiologies and classify diseases based on the etiology. For example, if the patient was more of a smoker, we would address in terms of the cessation of smoking and the reduction of urge, and of course the other parameters. This is just in terms of the etiology. So disease phenotypes is quite crucial in COPD, as the previous speaker has mentioned that it's not one size fit all. The more we see variety of phenotypes, we see patients who are frequent exacerbators, who will require much close follow-up. Others will require inhaled corticosteroids, while others will not. We have asthma COPD phenotype, which will have eosinophilia and maybe even a high pheno amount. And in terms of disease phenotypes, we all need to categorize our COPD patients on phenotyping so that we can give the right treatment individualized. We have inflammatory phenotype, and we have mentioned eosinophilic type and neutrophilic. The neutrophilic is actually the COPD one. And of course, digging deep in the genotype, understanding the disease much better, it's actually loss of telomerase caps, which actually prevents oxidation and reactive oxidative species, which in essence, if this mechanism is lost, we have cellular senescence leading to lung aging and emphysema. So these concepts on the genotype would actually help in terms of understanding the disease better and maybe tapping up on the genomics of COPD. Of course, we are mentioning treatable traits in COPD and not one size fit all. Indeed, there are patients, COPD patients who come with multi problems, for example, comorbidities. So you get COPD with comorbidities and, for example, depression. So a holistic approach in terms of treating our patients is quite crucial, and developing phenotypes and treatable traits would really matter. Just on the pathogenesis, touching on the pathogenesis, for every disease, it's quite crucial to understand what is the molecular components driving the disease. And actually, the chronic inflammation pathway in terms of neutrophils, macrophages, and CD8 cells would actually increase the imbalance of protease and antiprotease. For example, we have the antiprotease alpha-1 antitrypsin protection will be less compared to with more proteases like neutrophil metalloproteinase, neutrophil elastase, all these causing endothelial damage and causing emphysema. So actually, oxidative stress we mentioned, and of course disease exacerbation. For every exacerbation is actually worsening of the disease because of the amplification of inflammatory response. As you can see, this was a paper shown for every patient who gets exacerbation, there is a significant decline in the lung function and thereby increasing the mortality. And part of it is actually to prevent these exacerbations by all pharmacological and non-pharmacological ways. So just touching in the understanding why emphysema and of course bronchitis forms, indeed there is loss of the recoil because of the damage of the endothelium by the metalloproteases, and this loses the recoil, also causes tethering, and in a nutshell causing airway resistance and flow limitation. So these patients have actually a vicious cycle. They tend to have hyperinflation and a lot of air trapping, becoming more dyspneic, becoming less active, and becoming, more less active, more dyspneic. And indeed, there is quite a crucial role for pulmonary rehabilitation in these patients. And of course, restoring their mental, in terms of mental exhaustion, anxiety, and depression, because of they keep feeling dyspneic every time, and all this should be addressed. Of course, we all mentioned that for any COPD patient, she has to get a spirometry done, and we mentioned that an FEV1 of FVC of less than 0.7 will be actually diagnosed after positive exposure with positive symptoms and signs. But crucial to mention is the new guidelines are actually showing that the 2025 gold guidelines actually you might not need to do a post-bronchodilator. Otherwise, most of them, once you have a low FEV1 and FVC in the pre-bronchodilator, already that patient has COPD. Of course, we have the preserved ratio, which they really need to be monitored and treated, whereby they still have a 0.7 and above ratio of FEV1, FVC, but still actually have a low FEV1. Sometimes later repeat spirometry is required, but these patients should be treated. As you know, the gold guidelines reclassified to ABE assessment tool, whereby class A and B will be less exacerbators, and class A would have less symptom and sign, and class B will be more symptoms. So we have this MMRC and CAT tools which we use in terms of categorizing our disease, and we will see in the next slide that this will help in terms of the pharmacotherapy of disease. So for group A, we'll need a bronchial dilator. Group B will require a LABA-LAMA combination. And group E will require LABA-LAMA. And if eosinophilia of more than 300, then we will introduce a LABA-LAMA ICS. So we are pushing to get a triple inhaler therapy in the country. This will really help in terms of management of the group E patients in COPD. Of course, this would basically, it's more of a disease category. There are patients who are frequent exacerbators, there are patients who are more dyspneic, and this is a flowchart which you can still get in the GOLD guidelines. This slide was crucial because we are seeing so many COPD patients put on ICS, and some patients are actually frequent risk of infections, and they're still on ICS. So we prefer really to focus ICS in disease phenotype, eosinophilic phenotype, or patients with asthma COPD overlap, or patients with frequent exacerbations or previous hospital admissions. Those will require ICS compared to others. Indeed, management is a holistic approach. It involves both pharmacological and non-pharmacological treatment, and we are going to see how pulmonary rehabilitation does quite well in terms of improving the dyspnea, improving exercise capacity, and actually reducing progression of the disease. Indeed, vaccination is important, and management of comorbidities. For treatment of exacerbation, really, I just put this slide to just show you that actually patients can present in different ways, and really there are patients who are quite getting frequent viral infections, and you know that's the main cause of exacerbation. But indeed, such patients, if they were to possibly be followed up in terms of boost the immunity, boost the basically the antioxidants, and even given vaccines, we might prevent most of these exacerbations. Of course, we have phenotype of patients with multiple of comorbidities. Of note is cardiovascular comorbidities, acute coronary syndrome, lung infections, lung cancer. COPD is a risk factor for lung cancer. They usually have muscle dysfunction and muscle weakness, hence the role of pulmonary rehabilitation. Of course, bronchoscopic methods, we mentioned, the previous speakers mentioned on interventional pulmonology. We are really pushing this domain in terms of COPD, and we are trying as much as we can to start these procedures. As of note, we are started on coils, putting coils and one-way valve, what we call the fire valve. Bulectomy, the surgeons are already doing it, but we can also do sealants in terms of COPD. The other ones are still in the pipeline for us. Indeed, innovations is crucial for any disease processes, and AI is really coming strong. We are using AI in terms of volumetric CT scans to quantify the amount of emphysema and even to decide which lobe to intervene bronchoscopically. We are also using AI in terms of analyzing patients' data and predicting risk of exacerbations. So telemedicine will be crucial because, as you see, there's a huge gap in rural areas and other low-level facilities, and we can do teleconferencing and telemedicine to guide and even what we call to create awareness of disease. We have stem cell therapy, which we are contemplating in terms of putting lung progenitor cells to improve the alveoli function or rejuvenate the alveoli, therefore helping on the dyspnea and the disease process. Lung microbiome is quite studied in terms of the what we call dysbiosis, the good microbiome being less than the bad microbiome. Hence, maybe in the near future you will have an inhaler which will be releasing microflora. Bronchoscopic advancements, we mentioned about the valves and the target lung denervation. So we have smart inhalers. These are, they have sensors and Bluetooth technology that can track patients' medication use, thereby relaying the information in the application. This will really help the doctor in terms of adherence of the medication, proper inhaler use, and other effectiveness of therapy. We have novel pharmacological treatments which have just been approved 2025. We have ensifentrine, which is actually a nebulized phosphodiesterase 3 and 4, which really has been shown in the study to improve the lung function and the dyspnea. Dupilumab, there is a role for biologic, but of course, depending on the phenotype, what we call the asthma COPD phenotype or the eosinophilic type, which still most of our patients are actually neutrophilic, so still there is a gap in terms of biologics. We are praying that we get more biologics that will work in terms of COPD. This was the enhanced trial 1 and 2, showing indeed that ensifentrine would actually reduce the risk, the percentage exacerbation compared to placebo. So apart from improving symptoms, ensifentrine also reduced the rate of exacerbation and improved the lung function with a confidence interval of 95% and a p-value of less than 0.001. Then we have the trial of Notus and Boreas trial, which will actually, we mentioned about eosinophilic type COPD, which there is a role of dupilumab. So most of these biologics are add-on. They are not solely medication of their own. They are add-on medications, and actually these are the last, in terms of the part of the last interventions. We have mepolizumab and benralizumab. They are all IL-5 pathway. Of course, still disease phenotype will be eosinophilic type. We have IL-33, which works both for type 2 and non-type 2, which the trials are still not fully approved, but we are still waiting. Indeed, precision medicine through biomarkers is quite crucial because the disease itself is heterogeneous. We have seen different biomarkers like interleukin 8, interleukin 6, CCL8. All these biomarkers, eosinophils and all that, are actually to guide us what will be the proper medication for these different heterogeneous presentations. Thank you very much.
Please, let's give Dr. a very good clap. Thank you so much. That was very intense. Our next presenter will talk about the role of pulmonary rehabilitation in chronic lung disease management. Let's welcome Mr. Eric Ouma.
Good afternoon. Thank you for this opportunity to present. So I'm going to talk about the role of pulmonary rehabilitation in management of chronic respiratory diseases. I think here in Kenya, pulmonary rehabilitation, I know most presenters have talked about it, but it's not something that has been happening. So let's see how pulmonary rehabilitation is helping our patients. So generally, pulmonary rehabilitation is a multidisciplinary approach in management of chronic respiratory diseases So it has two components. There is exercise training and education part of it. So the exercise training part of it is aerobic and strengthening exercises. And then education part of it is psychological support, education on inhalers, traveling, oxygen education. And also the most important part of it is education on how to recognize exacerbation and how to also recognize the triggers and avoid. Because normally, these patients living with the chronic respiratory diseases, especially COPD, asthma, and the rest, they normally have exacerbation, and some of this exacerbation is linked to a trigger. So if these patients are able to identify the trigger and manage it, that will help them to not get frequent exacerbations. And so there have been some studies that have been done looking at the benefits of pulmonary rehabilitation, and it was comparing pulmonary rehabilitation and the inhalers. So we have 3 components. So it was comparing exercise capacity, dyspnea, and quality of life. And as you can see, pulmonary rehabilitation had more benefit in all the 3 components. And if you look at the exercise capacity, you can see pulmonary rehabilitation had more benefit compared to the 3 inhalers that were used. And the gap that exists is what we call pharmaceutical gap, that you cannot get in the medication or in the inhalers. And then when you look at the quality of life, pulmonary rehabilitation provided provided more benefit than what was considered minimally clinically important difference compared to the 2 inhalers that were used. And also the same applies to dyspnea. So you can see pulmonary rehabilitation is very, very crucial in management of chronic respiratory diseases. And so there's some studies that were also done. So there's a meta-analysis that was done by McKenzie in 2015, looking at the benefits of pulmonary rehabilitation with about 65 randomized control trials and just below 4,000 patients. And as you can see, the conclusion was that pulmonary rehabilitation improved health-related quality of life, functional and maximal exercise capacity, dyspnea, and also emotional and sense control. But most importantly, the conclusion was that pulmonary rehabilitation is the cornerstone management of COPD, and it is a fundamental, not just an optional extra. And also further, they concluded that there was no more further randomized control trials needed to prove that actually pulmonary rehabilitation is the cornerstone in management of COPD. There was also another study done by Puhan in 2016 looking at pulmonary rehabilitation for the patients that were admitted due to acute exacerbation of COPD. So it had about 20 studies and also about just below 1,500 participants. And as you can see, it concluded that pulmonary rehabilitation reduces admissions, improves health quality of life, and also improves the exercise capacity. And so this was a study that was done in US looking at hospital readmissions. So it was comparing pulmonary rehabilitation, but this was a virtual pulmonary rehabilitation and looking at the standard care. So the standard care here is the normal treatment that our patients undergone, like you give them the bronchodilators and the rest. And it had 2 components. So the first one was all cause of readmissions, and then the second one was admission due to exacerbation of COPD. And as you can see in both the 2 studies, the patients that were undergoing pulmonary rehabilitation had lower chances of readmission compared to the patients that were receiving standard care. So when do you start, or when can you initiate pulmonary rehabilitation? So this is another study that was also done in the US looking at when to start pulmonary rehabilitation. And it was comparing the patients that undergone pulmonary rehabilitation or started pulmonary rehabilitation from day 0 after discharge to within 90 days, and also the patients that did not receive pulmonary or didn't start pulmonary rehabilitation within the 90 days. So this is yellow, or I'm bad in colors. Yes, so this curve here is the ones that didn't start pulmonary rehabilitation within 90 days. And then the lower curve is the patients that started pulmonary rehabilitation within the 90 days. And as you can see, the more the delay, the more the mortality. So the patients that started pulmonary rehabilitation within 90 days had lower chances of mortality within 1 year compared to the patients that didn't start pulmonary rehabilitation within 90 days after discharge from the facility. So which patients can benefit from pulmonary rehabilitation? So we have all patients suffering from chronic respiratory diseases. Initially, pulmonary rehabilitation was designed for patients who had COPD. However, as people did a lot of research, they realized that actually this program is working for all patients suffering from chronic respiratory diseases. However, a disclaimer that I will want to put here is, if a patient is suffering from lung cancer, you are not supposed to refer them to do pulmonary rehabilitation if they are on the last stage of the cancer. So they will not benefit from pulmonary rehabilitation. But all the other cases, they will benefit from pulmonary rehabilitation. So before a patient comes for pulmonary rehabilitation, we normally do initial assessment to look if they are eligible for pulmonary rehabilitation or not. So the first eligibility criteria is that they are they should be optimally managed medically before they come for pulmonary rehabilitation. And then the second thing is we are supposed to assess them based on the MRC score. So if a patient has COPD, they should be scoring between 2 and 5. And if the patient is having other respiratory diseases like TB and the rest, interstitial lung disease and the rest, then they should have an MRC of score of 5 and above. And 5 and above here, of 3 to 5, sorry. So for the COPD, for the ones that I've managed, and this is something that I also wanted to highlight, most of the patients that are referred for pulmonary rehabilitation are late referral. So the most that I've dealt with after walking about 100 meters. In fact, I would say all cases that I've rehabilitated here, they barely walk 50 meters. So that seems that is more than the 4th grade in terms of MRC score. So you can see that it's kind of an injustice we are doing to our patients because we are not referring them at the right time. We wait until the disease really progresses so badly is when we remember, oh, there's pulmonary rehabilitation that they can benefit from. And then, so there's also disease-specific eligibility criteria. So if a patient is suffering from bronchiectasis, their airway clearance should be managed properly before they start pulmonary rehabilitation. And if they are admitted due to exacerbation of COPD, then they are supposed to be referred for pulmonary rehabilitation at the point of discharge. So you don't wait until for some time to refer them. And also, if the patient is suffering from pulmonary hypertension, in addition to COPD or bronchiectasis or other chronic respiratory diseases, then they should not have any change in their drug or therapy within 2 months or the last 2 months, and also they should not have any syncope or arrhythmias within the last 2 months. So there is, as we know, pulmonary rehabilitation is beneficial to patients. There is contraindications to pulmonary rehabilitation. The first one is a patient with unstable cardiac disease. So if a patient has hypertension, unstable arrhythmias, and triple A of more than 5.5, they are not supposed to be referred for pulmonary rehabilitation. However, if, sorry, yes, however, once this has been managed, if this has been managed properly, that patient can come for pulmonary rehabilitation. The second contraindication is a patient with a neurological condition and also severe arthritis. They are not supposed to come for pulmonary rehabilitation. Remember, pulmonary rehabilitation is majorly exercise. So if this exercise is going to trigger a lot of pain, that might not be beneficial to the patient. So we normally really weigh the benefit versus the adverse events of the pulmonary rehabilitation in this case. And then if the patient, as we said, if it is a terminal phase of the illness, they're not supposed to come for rehabilitation because there's no benefit that this patient is going to get. And then the last one, if a patient is not able to follow command properly, then pulmonary rehabilitation might not be beneficial to them. And so the component of initial assessment, so it should be high quality in-person multi-system assessment. So we not just assess their respiratory condition or the dyspnea, activity level and the rest, but we also assess their psychological well-being. We assess their nutritional status, and nutritional status is very, very important for these patients, and also the other needs that they might have, like oxygen need and the rest. And then if you are to do a virtual pulmonary rehabilitation, then you can do telephone questionnaire. However, in-person exercise capacity must be done before you prescribe any pulmonary rehabilitation program for this patient. Then you should have assessment protocol, and then the person carrying out pulmonary rehabilitation should be well-trained and competent in pulmonary rehabilitation so that delivers what benefits the patient. So part of the purpose of doing, or the benefits of doing initial assessment, is to explore patients' understanding of pulmonary rehabilitation and address any concerns that they might have, and also assess for contraindications for pulmonary rehabilitation. But also, initial assessment also help us to gauge, once the patient completes the program, we are also able to gauge whether the patient has benefited from this pulmonary rehabilitation or the patient needs to go for a second round for pulmonary rehabilitation. And also, of course, to set goals. So goals are very important because they are things that this patient wants to do. For example, if somebody was doing, let's say, manual job, has suffered from COPD or TB, that has affected their lungs, so the lung volume has reduced. So when they come for pulmonary rehabilitation, what is most important to them? Do they want to go back to the activities that they were doing? And will the pulmonary rehabilitation help them to go back to the activities that they were doing? So setting goals is very, very important. And the other purpose is also to look for if the patient will need other support. For example, if the patient presents with unstable cardiac diseases, then we need to refer them for management before they start pulmonary rehabilitation. And also look if the patient will need long-term oxygen use, then we need also to refer this patient where they can get oxygen so that that optimizes the outcome. And then the others that I've spoke about. This is just to look at what the patient will need, the support and everything. I think it's not that much important. So the objectively, if you are going to do initial assessment, then you're supposed to look at cardiorespiratory observations like SpO2, heart rate, and BP. The body mass, the BMI is very important when these patients are coming for pulmonary rehabilitation. And also the other outcomes like breathlessness, health-related quality of life, and lower muscle strength is very important. So the lower muscle strength is important in patients suffering from COPD and also the patients suffering from TB. For the COPD, you know, if you're using corticosteroids, one of the side effects of corticosteroids is the weakness of muscles. And the most important muscles in the lower extremities that we are more concerned about are vastus medialis and vastus intermedius, the quadriceps muscles. So if you are able to work on the quadriceps muscles and strengthen them properly, then this patient's dyspnea and activity level will automatically go up. So there was a lot of theory. So now we go to the real-life pulmonary rehabilitation or pulmonary rehabilitation in real life. So there was a study, or there was audit done by British Thoracic Society in UK, looking at about 210 pulmonary rehabilitation services, and they had a questionnaire, and they were looking, they assessed the patients. So out of 100 or 80% of the patients that came for pulmonary rehabilitation said that pulmonary rehabilitation improved their exercise capacity. And about 74% said that pulmonary rehabilitation improved their health status. So you can see how beneficial this program is to the patients with chronic respiratory diseases. And also pulmonary rehabilitation in patients with interstitial lung disease. So as you can see, the patients that undergone pulmonary rehabilitation had improvement in 6-minute walk, of about 45 meters, which is more than what is minimally clinical importance difference when we are looking at a 6-minute walk, which is about 24 to 45 meters difference. So you can see the benefits of pulmonary rehabilitation in the other diseases like interstitial disease. So this is a study that was done, I think, in Kilimanjaro in Tanzania. So it was looking, so this is post-TB pulmonary rehabilitation, and it was done in the community, not center-based. And as you can see, the outcome was overwhelming. So this patient at baseline, their 6-minute walk was just about 420 meters. But at week 24, they were able to walk 460 meters, which is pretty normal to most of the population if you adjust age and gender. So it means that these patients were almost back to their normal 6-minute walk after the pulmonary rehabilitation. But also if you look at the St. George Respiratory Questionnaire, looking at the burden of pulmonary rehabilitation and the benefits, you can see there was the all scores in terms of symptoms, activity level, and impact. The scores were statistically significant, showing that these patients had a lot of benefit after pulmonary rehabilitation in TB, post-TB. A lot of theory as well, but this is practical. So this is a case that I did before I went for my master's. So I was rehabilitating a patient that had COPD, was discharged home with a portable ventilator. So initially, this patient we started on day 1 of discharge, but we were doing a rehabilitation with while the patient was on a ventilator through tracheostomy. So we did this for about 3 months, and the patient improved, weaned off the ventilator. Then later on, this patient was started on nighttime NIV because he was retaining CO2. So he wanted to flush that CO2 at night. And 3 weeks down the line, this patient was able to move around. Initially, I wasn't able to do MRC score because by then I didn't know about MRC. But later on, after I studied, I realized that this patient, his MRC score was actually at stage 4. So it was at the last stage of the COPD. This patient was given a prognosis of about 6 months, but with rehabilitation, he lived about 2 years. So you can see the benefit that this pulmonary rehabilitation added to this patient's life. The second case study, this is after I studied or after I finished my master's. So this is a recent case study. I did it like a month and a half ago here in Nairobi. So this is a patient that was referred for pulmonary rehabilitation, had TB. This is a post-TB patient. And when she came for pulmonary rehabilitation, when we did 6-minute walk, she was only able to walk about 45 meters. So you can see the severity of TB. And then, so we did initial assessment. So as I said, the patient only managed to walk 45 meters in 6-minute walk test, and the BOG scale was 5. So the walk was really, really tough for her. And the MRC was a score of 3, but I think I underestimated this. It looks like 4. And then the other scores were not as good. They were fair, and the St. George was about 47%, which is shows that the disease has progressed badly. And then I put this because this patient, when she came for pulmonary rehabilitation, she was coughing and producing a lot of mucus, and she had like this bottle she was coming with in the facility for rehabilitation. And always in the morning when she comes, after walking about 2-3 meters, she coughed, and she was able, the secretions and the sputum was somewhere here in the bottle. So she was emptying like twice when we were doing pulmonary rehabilitation. So you can see how bad her lungs were, and also the level of secretions. So the other things that we did for this patient, one of them was to refer to nutritionist for diet, And this was an international patient, so we made sure that the nutrition she was getting, the kind of food she was eating, were a little bit close to what she was eating at home, so to make it more palatable for her and enjoyable. Because as well, you know, for those who have traveled out of the country or even in a different community, getting used to that food and everything sometimes become hard, and even that makes you even the appetite to go down. So if you are able to eat what you are used to, it will make it more palatable and enjoyable. And also we did other support as well. So pulmonary rehabilitation that I'm currently conducting has about 10 domains. So the first session, when we were doing the first session, this patient only managed about 6 domains, and BOG scale was about 3, and the repetition was just 6. But as you can see, as the pulmonary rehabilitation progressed, BOG scale improved, so she was able to score 3. The domains had gone up to 8. However, the repetition really gone up from a baseline of 6 to now baseline of 25, and then now we introduced to 8, so she was able to do about 2.5 by the time we were doing the 4th session. So you can see the benefits or the improvement that this patient had. Then at the last session, we were not able to continue because this patient, when I was getting history, when she went to do, when she was diagnosed with TB in 2023, and she went to do chest X-ray, she had some burns on her skin that lasted about 3 to 4 weeks. So I suspected that this patient might have had radiation poisoning due to the burns that she had from the chest X-ray or the X-ray that she went to. And actually, this was confirmed when she came for the 5th session. She had all the signs of, and you know, one of the side effects of radiation poisoning is cancer. So she had signs of lung cancer, and when we sent her for further imaging and further assessment, she was found with lung cancer. However, I think this was something that was ongoing even by the time this patient came for rehabilitation. It's only that we were not able to pick it up at that time because the body was not like the body had not been strained enough so that we were able to pick this. But by the 5th session, that came up, and the patient was sent for assessment. The result came out, and now she's under treatment for lung cancer. And as you can see, remember when we were doing initial assessment, this patient was only able to walk 45 minutes or 45 meters in 6 minutes walk. 2 weeks after, or 2 weeks during rehabilitation, this patient was able to go up and down 2 flights of stairs. So you can see the benefits of pulmonary rehabilitation within a very, very short time. And we also documented everything. So I gave her a chart to document the activities that she was doing, the type of food she was eating, how many times she was eating, and also the other support. And you can see they were all well documented, and also even vomiting and cough, and also when she was going up and down stairs, the BOG scaling, I showed how to scale a BOG, and also to tell us how hard it was and or easy it was. Now, apart from pulmonary rehabilitation, there's something else that I wanted to highlight. So before I went for my master's, all the COPD patients that I had were being given this incentive spirometer. However, when I went to study, I realized that actually these patients don't need incentive spirometer. As you can see, it is well illustrated in these 2 diagrams. So the first diagram is a normal lung. The second diagram is a patient with COPD. You all know that COPD patients they don't have problem getting air in. Their problem is getting air out. So their lungs are always hyperinflamed. Hyperinflated. So if you give them incentive spirometer, you are doing harm to this patient because you are inflating. Remember, their lungs are already inflated. Now you are even inflating it higher. So it means you are doing a lot of injustice to this patient. So what is indicated for this patient is what we call the PEP and OPEP devices. And I'm happy to say that these are locally available currently as we speak. So I think from this session, we'll stop giving this patient incentive spirometer. we give them PEP and OPEP devices. Otherwise, thank you very much.
Thank you so much, Mr. Eric. Let's clap for him again. That was very informative. Sorry, our session is really taking a bit of time. We had one session yesterday that we didn't cover under care and treatment on person-centered, gender-responsive care in TB, insight from Light Consortium research across Nigeria, Uganda, Kenya, and Malawi. And I want to welcome Dr. Brenda to take us through. Karibu, let's welcome her.
So good afternoon all, and thank you for the insightful presentations. I've really learned just sitting here. So my slides, please. Oh, fantastic. Okay. Yes, so so I think my presentation will be in two parts, and as you heard, it was under the aspect of person-centered care, so care and treatment for TB. So we're switching back a little bit for that. And the outline of my presentation, I'll cover the background, I'll speak about some few findings from the Light Consortium and the implications. But as promised yesterday, I'll also be talking about TB in older populations. As you heard from our speakers yesterday, a lot of it was mentioned that, you know, in Nairobi, they've seen, you know, high numbers of older populations, and also IBAN talked about it in the national data. So I thought it wise to start with this WHO recently released guidance in 2025 of tuberculosis among populations at high risk and people in vulnerable populations, because part of my talk will actually be focusing on some of these vulnerable populations or high risk populations. As we know, TB can affect anyone. However, as Professor Chakaya told us yesterday, you know, structural, social, demographic determinants and health-related risk factors make some populations at higher risk of being infected with TB, falling ill when infected, and having poor outcomes when they develop TB, and unfortunately also having limited access to quality healthcare. And so as we try to get to the NTB strategy, it's getting clearer that we do need to identify individuals and populations at high risk for TB to offer effective planning among, you know, even in the TB programming and resource allocation. And also, how do we get person-centered, human rights-based TB services? And in that book, they do list a number of people that are at high risk, depending on various factors, but I'll speak about those with limited access. Among of those that they say they have limited access are men in settings where healthcare access is not tailored to their needs. And we had Charles here talking about, you know, his experience on TB. Children and adolescents, and we had Anne-Marie talk about that yesterday. And those at high risk, as we know, you know, younger children, the elderly, pregnant and postpartum women. Somebody in the audience actually gave an example yesterday. So allow me to talk about, the first session I'll talk about men, and then I'll talk about the older age groups. So as we know, you know, the global TB burden is indeed gendered, and we have that TB affects men disproportionately. And as you can see, this is a chart from the global TB report, and you know, the number of cases are higher, well, across all age groups except those children. You know, below 14 we don't see quite a big difference, but after that you start seeing the major difference in shifts between male and female. And why was Light focusing on gender and TB? And this is really because of the higher burden of TB that we know compared to women. And also there are, you know, higher rates of undesirable treatment outcome. Why is this? We think, biology, so men, just the sex factor seems to make them more at risk, but also their social community networks, living and working conditions. Generally, we think there's some masculine norms and masculinities that cause more problems, even as they get TB. As you'll see, even from screening, we probably screen them less. So the gap, the notification and prevalence gap in men is even higher than in women. So this cascade is just quickly illustrating the differences in male and female. As you can see, those so infected with MTB, you have higher rates in male. Those diagnosed, we actually end up diagnosing more females that have TB. Like if you compare those that were infected, okay, so the ones that actually then get TB infection and also are treated for TB, the gap, as I said, is higher in men. Even though we still find more men, we do need to find even a higher proportion of them. And that goes on across the cascade. For those who may not know, so Light Consortium was a 6-year consortium ending in March next year. And really, the goal was to support policy and practice in transforming gendered pathways to health for people affected by TB, and also improve overall health and well-being. It was working across various countries, as Mweni mentioned, and those are where I'm going to specifically say about some of the findings. And it was also looking across the TB care cascade from prevention, screening, all the way to post-TB lung disease. So what are some of the light findings and implications? And on this presentation, I've also put a link. So for those that may need to go and know more about light, you'll click that link on the first slide. Specifically in Nigeria, so they reviewed TB data on adults more than 15 years who accessed TB services in 14 Nigeria states. And what they noted is that although equal numbers of men and women visited health facilities, a higher proportion of women was screened for TB. So that's part of where we start losing the men. And then the testing gap, where women were less likely to be tested after being identified as presumptive TB. So here, you'll see this is sort of a little different from what we found in Kenya. But in terms of treatment, though some individuals diagnosed with TB, both men and women, were missed out on initiating treatments. And this looks like it was equal between the two sexes. So while treatment success rates were similar across genders, men tended to experience more negative treatment outcomes. And then co-infection rate in Nigeria was higher among men. So this work was actually done by Ebuka, who is now graduated with his PhD. And after using this data, he also looked at how can we get men? What community interventions then do we need to put in place to find more men? And so they went to the community, they had a lot of engagement to come up with some interventions that they could package together. And so what they found is that, one, this I think we kind of know, TB screening in places where men gather is important. You have to go to where they are at. And then the use of modern digital X-ray screening did screen more men, and I think even in the Kenyan data, we've seen that. And then TB awareness and creation and anti-stigma campaigns are important. But you specifically then need to figure out where will men get that information and then target those channels. So when we're developing and evaluating a gender-responsive TB intervention for communities, so they used a study, mixed methods, community-led approach, and I think AMREF are doing some CLM work. So I think, these are some of the things that we can incorporate even as we think about policy implications. And the intervention they used was male champions. I thought Charles was a very good male champion, for those who listened to him. Charles, nadhani kuna wenye watakuja kukutafuta as a champion kama hujakuwa bado. But yeah, male champions and mobile x-rays, as I said, were found to be feasible, acceptable, and effective in increasing TB knowledge and reducing stigma. Then the study in Uganda, Ignite, again by a PhD student, Jasper, showed that men in Uganda face significant barriers to TB care, contributing to 2/3 of those missing out on treatment. In this study specifically, then, they co-developed and tested gender-sensitive TB screening interventions at facility level. And I think a number of us have seen such stamps. We were using them at some point, Dr. Kathure. I don't know whether they're still at facilities, but they used this and information that was specifically targeting men. So male-friendly services. They also ensured that, in a way, men were fast-tracked when they came to the facility, but also they tried to have flexible timings. And so what they found is that they increased case notification by 51% among men and improved access. Through this, they still improved access for both men and women. Because I think when we think about gender, we're not saying now focus on men, forget about women, but I think it's ensuring that you're doing person-centered care to both of them. In Kenya, so RESOC is one of the partners of Light, and part of the work they've done, Rhoda talked about it yesterday, but there is also some work that they did looking at TB data and looking at adolescents and young adults, 15 to 24 years. That was for those between the 2017 and 2022 time period. Now, the screening data, again, we were trying to see throughout the cascade, you know, how do men compare to women? So unfortunately, the screening data was not disaggregated by sex at that level. So, you know, for that specific age group and also across the age groups. However, they noted that there were poorer outcomes in young adults, 20 to 24, compared to 15 to 19. And so part of the recommendation is to strengthen data systems to include gender and age disaggregation all across the cascade, and to also monitor that. And that is also looking also at among young people in Kenya. And I think for example, the childhood TB TWG, Professor Bimbo did ask that we should also be including adolescent data in that when we're looking at the cascades. And then part of the work that she talked about yesterday, so let me recap. For those who didn't hear, it was very exciting information, but qualitative interviews of adolescents and young adults who disengaged from care. You know, some is because they perceived actual health improvement, a number was side effects of the medication, and some were really, at that point, health system gaps. And then there were also some psychosocial and some economic reasons for stopping care. But when they also talked about their journey to diagnosis and treatment, there was delays in getting TB diagnosis, for some up to 2 years. They went from this pharmacy to another one before they went into a health system, and then they were still also forwarded to another facility now, finally, for treatment. And then, obviously, there were challenges, job loss, missing school, but they also noted that indeed there were some support systems that enabled them get good care, especially finally when they got the diagnosis of TB in the facilities that they were then told you can go take treatment from there. The healthcare workers there were well trained, and they knew and they did support them. So that's in Kenya. So we were looking at understanding and addressing barriers to TB care among adolescents and young adults. Also, and then we also had some work that AFIDEP was doing. That was looking at person-centered, rights-based, gender-responsive TB care in Nairobi County. And this was really a participatory qualitative study where we worked with health facilities to kind of try and understand from them, you know, are they offering person-centered care? What does person-centered care look like? Which are the vulnerable populations that they're making sure they are reaching out to? And so that participation, there was, you know, they picked a few action points of what they could do better in their facilities to offer person-centered care. And also actually just 2 weeks ago, we had a feedback session and to see what they were able to implement. For the ones, I'm going to talk about for the ones that picked that they will, you know, offer more person-centered services for men. Some of them have started flexible opening times. Baraka has started opening at 6:30 a.m. to offer treatment to those that need to collect medication before they go to for work. Obviously, it's for both male and female, especially the ones that do, you know, informal jobs, but also that, you know, they can't afford to really come during the day. Some of them actually talked about leaving medication at the maternity wards for flexible collection, because those are open 24 hours. So there were a myriad of interventions, which I think were great because we saw how context-specific person-centered care then would look like. And these are some of the workshops that occurred during the person-centered participatory research workshops. And then feedback was given to stakeholders, including the National TB Program. And finally, Malawi. So Malawi did 2 studies. They did one for Photo Voice. So Photo Voice was sort of getting men and people who've passed through, who've had TB and their experiences, and for them to document that in photos, you know, as they took the medication, you know, challenges that they faced, etc. And again, there's already a booklet published on this, but it did help young people have a voice and share from their eyes, you know, what they feel, you know, about, even you can see sometimes they've just taken a picture of the medication before they take, and it gives you a feeling of, you know, maybe the number of drugs that they had to take, or even as they walked to the health facility, their surroundings, etc. So this was a way to empower young people to tell their own stories and advocate for better care. And finally, there's a PhD student, again in Malawi, who's looking at sex differences in the risk of mycobacterium infection using IGRA and seeing, you know, is it comparable, men and women? And that's, so probably not too clear, but, you know, it is higher in males. So the rate of QFT positivity was higher in male. And even if you adjusted for risk factors, so, you know, positive HIV status had a lower odds ratio of, you know, getting a high QFT, but previous TB treatment, you know, was associated with high QFT, previous household TB contact, past and current drinking, alcohol drinking and smoking is also associated with high QFTs. So sex differences in predictors of MTB immunoreactivity suggest different exposures independent of age, HIV status, previous TB treatment and household contact. Men definitely are higher risk of having QFT positivity. And finally, I had said finally. Now, finally, there's some modeling work done by the London School under, again, the LIGHT Consortium. And putting all this together and also looking at what's the potential epidemiological impact of strategies to increase treatment coverage among men it actually has shown that if you target men and you get them, so we reduce that gap, you'll actually then increase treatment coverage. If you increase treatment coverage among men and address the structural risk factors, we could overall reduce the risk of TB incidents by 25%. So this is one of the strategies to actually achieve the NTB goals, that we must look at men and we must find them, treat them, ensure treatment completion, and even, treat them post-TB, the lung disease. So I think key implications on all those pieces of work is that national health information systems must be strengthened to do sex disaggregated data. I think Kenya is already leading in that, especially from treatment onwards. So I think it's the screening that we also need to, to work on. But we also need to sensitize front care health workers to support context-specific, person-centered interventions. Because even as a country, we have it in the guidelines. It does say that we should offer that. But how it is actually being offered needs a bit more thinking about at facility level, at county level, at sub-county level. And then we need to keep documenting these interventions. Even during the participatory work, there were some good already practices ongoing that we need to document and see whether they can be scalable. At national level, yes, apart from the health systems, is really advocate and raise awareness for gender disparities and response. And then we definitely need to promote multisectoral. I think Professor Chakaya already covered a lot of that yesterday, and engaging the affected community. Most of these studies were, were engaging the affected communities to come up with the solutions. Great. So allow me to talk about TB in older age groups in a few slides. So this is not work that Light had done, but I think because it came up a lot and we thought that this is an important area, so I'm going to cover that. And it does, this was, I think, a newspaper publication from a newspaper article in India. We cannot end TB if we leave the older people behind. And this is why. So even though globally, the higher age groups, and I'm sorry, oh yeah, that's better. Even though the higher age groups, that's more than 65 years old, does not show such a big difference here, you can see some regions, for example, the Western Pacific region, where Dr. Kagima has just come from, has, elderly population is higher, and we can see that TB in that population is higher than the rest of the age groups. And even from data from Dr. Jane and also Iban yesterday, they also said they're starting to see TB in higher age groups. And so this is why we are focusing on this. So TB in older adults is due to mostly reactivation of latent infection acquired decades later, and within that older age group is associated with higher TB incidence and mortality compared to younger adults, especially in some populations. But actually, even in Kenya, this was from the prevalence survey of 2015-2016, you can see the age groups 65 and above. This was the prevalence rates. They're actually high. So this is, the red is male and the blue is female. That's the prevalence, and this is the notification. And so you can see they also already have a prevalence notification gap. And this 60-33 is even higher than almost at this. In fact, for females, it's higher than the 25 to 34 age group, the 65 and above. So it is true that we, even as we think about person-centered care, we must start thinking about our older age groups. Why are we concerned? There's increased susceptibility in risk factors, so weakened immune system, reactivation, as I said, but also they have comorbidities and atypical presentation. While the clinical presentation, some of them may be similar, you then may have some non-specific, symptoms like fatigue, confusion, weight loss, but also that extrapulmonary TB and non-classic presentations could be higher. And then we also have the diagnostic delays. So if it's already there in the system, you can imagine how much more for older age groups. And yet they could have higher mortality and adverse reaction to medication. And of course, they're also taking probably some other medications. So that's already a higher pill burden. What do we need to do? We need to start thinking about TB in older adults, including how to detect them early, timely diagnosis, tailored treatment, and thinking about holistic care. I think Dr. Wagude showed that there was some screening with chest X-ray and AI for the older age groups. I think that's fine. What we though need to remember that there could be the sensitivity of especially the AI cutoffs for older age groups. It's not as sensitive because you'll pick other changes. So you need to do that, but that's already a good intervention to think about. But also your interpretation, you also need to take a bit of care in that. So we need person-centered approaches and thinking of where we can do active case finding even in those age groups, and really increased awareness among our healthcare workers. All right, so thank you very much.
Thank you so much, Dr. Brenda. Let's clap for her again. Yeah. So I hope we still remember our question for this session where we had care and also post-TB lung disease, COPD, innovation that are there, pulmonary rehabilitation. Then we picked yesterday's session, person-centered, gender, and TB. So we'll pick question very fast because of time. Yes, okay. John, assist me, please.
Thanks to all presenters. My question goes to Eric. That was a very exciting presentation. The first set of studies or evidence that you shared were not done in Kenya, and I was eager to hear what are the stories that are coming from the Kenyan situation, and I'm glad that you were able to give some testimonies of the patients that you have served and they have improved. However, since you kept saying before you went to school, you are not able to do this. So my question is, and also looking at the healthcare workers we have in here, maybe the bare minimum they have in their facility is a physiotherapist. Is this sufficient enough for them to refer the cases that they are seeing with the different conditions that you have highlighted to them, or then do they require to send these patients to you? I'm assuming you're based in Kenyatta. Yes, so, and maybe for the other counties, because we also have healthcare workers from Kiambu County, what's the bare minimum? Like, who is the easiest healthcare worker to solve these issues in areas where you do not have a specialist like you? Yeah, thank you.
All right. Thank you very much, presenters, for that presentation. Mine is also for Eric, and interestingly, it's aligned to what Rhoda has just asked. Hello, Eric. Yeah. I know we've met online. Eh? Yeah. So number one of the things we've noted through one of the projects we are currently implementing in Kiambu County is that pulmonary rehabilitation is a bit out of reach for many people. And the reason is because the specialists, that is the physiotherapists who can conduct it, are actually unavailable. So the question I have, and this is also in response to some input we received from a PTLD Symposium that was conducted for various African countries earlier this year in SA, we got feedback from countries such as Malawi, where they have been trained other cadres of staff to conduct pulmonary rehabilitation for their patients, and they had great results, with results even after 2 weeks of a PR program. And so the question I have for you, Eric, in this era of task shifting and noting that we do not have too many physiotherapists outside of Nairobi and the larger, referral facilities, and particularly in the public health system, what is a minimum, or what kind of, what elements of pulmonary rehabilitation can we cascade to other health workers in the public health system through training, and what elements must be the preserve of experts such as yourself? Thank you.
Good afternoon. Thank you to all the presenters. Mine is to the presentation on post-TB lung disease in children and adults. Given that abnormal spirometry and oscillometry remained high at 24 months, I think it was at 23% and 30% for the other one. So despite improvement in symptoms and chest X-ray findings, what does this suggest about the long-term risk of persistent lung dysfunction in children with PTLD, and how should follow-up care be structured to detect and manage hidden airway disease early? Thank you.
Go ahead. Okay. Thank you to the presenters. Also to Eric. I just wanted to find out also, what are you able to do for the children? I think what you mentioned was mostly adults. So what services are you able to do for a pediatric population? One of the things you had made as a contraindication was neurological diseases. A majority of our children actually do have neurological problems, the CP children, and the likes, and they really do need a lot of pulmonary rehabilitation. And then one more for Dr. Joy, PTLD in children. So it was interesting to see that there is actually small airway disease following TB disease. Did you manage to check if they had symptoms which were suggestive of the small airway disease, possibly prior to the TB, and was there any bronchodilator response after?
Good afternoon. My name is Mashauri. Mine is not a question, but rather a proposal. I work in, I'm a nurse in Kenyatta National Hospital. I work in a respiratory disease ward, adult. I chose to put this proposal in Symposium 7 because it's the symposium which dealt with post-TB lung disease, COPD, and bronchitis. And there is one complication which cut across, that is some of the patients, they become oxygen dependent. After the disease, the lung damage, they become oxygen dependent. Now, these patients have made their hospital, they have made hospital to be their home because of poverty. From the inception of the symposium, I think the common denominators of all the challenges was poverty. Now, the patient who cannot afford the oxygen concentrator machine, they have made hospital their home. And I was to propose, if RISOC, being the authority in respiratory diseases, can advocate for SHA to buy oxygen concentrator for this patient who are poor and cannot afford oxygen concentrator. And my argument is, number one, is that the cost of oxygen concentrator vis-a-vis keeping that patient in hospital, the cost of oxygen concentrator is way cheaper than keeping a patient in hospital. The cost of oxygen concentrator on average is 120. A very good concentrator can last between 18 months and 36 months, an average of 24 months. If you look at monthly cost of that oxygen concentrator is only 5,000. But medical gas in hospital, oxygen alone, the cost is between 8,000 and 10,000. And so keeping that patient in hospital is more way expensive than buying a concentrator so that they can manage, the patient can be integrated with the family at home. And some of them, they still reserve some productivity if they get the right oxygen concentrator. Like selling a shop, somebody can be on oxygen in a shop and he will be still productive. Number two of my argument that SHA should buy oxygen concentrator for this patient is I am comparing renal failure patient with the patient who have insufficient lung. These are all patients. They are all client for SHA. But SHA is paying for renal replacement therapy at a cost of average 10,000. So if SHA is paying 10,000, even if they just pay once a week, the cost of renal replacement therapy, that is hemodialysis, in a public hospital is 40,000 for a one patient. SHA is paying and is not buying oxygen concentrator for the lung insufficient patient. The last one of my argument, it is the law itself. The Constitution of Kenya 2012, Article 27, guarantees equality and freedom from discrimination. And so, we can argue with SHA to pay for the patient who are oxygen dependent, so that we can actualize this constitution which we so believe in it. I end my argument there, but let me give this small scenario. Advocacy role is not easy. We were here when renal patients were advocating for their payment with NHIF. It was noisy and it was messy. The patient, actually at one point they picket at in our parliament. The patient themselves went to parliament to picket to advocate for SHA to pay for them, not SHA, NHIF. And so it was agreed. Now I want you to imagine a patient who is oxygen dependent picketing at parliament. It is not even imaginable. Patient can't leave their bed in hospital to go and advocate. So, RESOC, being the authority, it's their only hope for them to advocate for this patient. I want to end my argument there. Thank you very much.
Thank you. We have the last question from Dr. Brenda.
All right, thanks. I have a question for Joy and Lucy. The BMI, why did you have, in your view, where was there a difference between adults and children, in that children who had high BMI were, are likely to have then PTLD, while on the adults it was the reverse? Thank you.
Thank you so much. I think because of time, we'll answer those few questions. We'll start with Mr. Eric, then Dr. Joy, and Lucy will go. Eric?
Thank you. I think before I answer the questions, I'll just want to respond to the last speaker. He was talking about patients that are oxygen dependent and cannot go home, and you need help with RESOC. I think before RESOC sets in, these patients that are oxygen dependent can actually be weaned off if they undergo pulmonary rehabilitation. So maybe the first step will be get this patient on pulmonary rehabilitation, wean them off oxygen, and the problem solved, the patient can go home. So that is maybe a discussion that you can pick up later once I'm done with the presentation. Now, the third question was on patients or children. So I will say that one of the contraindications to this to patients coming for pulmonary rehabilitation is patients that are not able to follow command. However, the patients with the CP and all other neurological conditions, as long as they can come with somebody that they know, because we know these people need to have someone that they know, and this person can instruct them properly to do what we are telling them to do, I think they can still benefit from pulmonary rehabilitation. So those are the few special cases that we can consider for pulmonary rehabilitation. And then in terms of RODA, if I was to respond to your question, I think generally physiotherapists are trained in broad, so it's a broad training ranging from respiratory to gynecological problems. So they might not be able to give this pulmonary rehabilitation program because this is now a little bit advanced program. However, we can have a chat and do some, I would say some training. This training can be done to some healthcare workers like nurses, physios, and the rest, and then we can cascade this down to even the other healthcare workers so that they can provide this pulmonary rehabilitation services. If you look at the slide where I presented a case, the post-TB lung disease in Tanzania, actually a lot of that work was done by community health workers in the community because that work was done in the community. So actually it can be done, it's just that those people need to be a little bit trained. So we can catch up after that. By the way, I don't work at Kenyatta, as you are saying. I'm still trying to find a place to work at. Currently, I'm working in the UK with an hospital called University Hospital Dorset. But also, I was fortunate enough to get a second job, still in the UK. But I think as I will try to emulate what Ivan said yesterday, we need to do what the rest of the world is doing currently. We don't have to do what they were doing in 1920s. So I was trying to say, after I studied and got a work in the UK and saw the benefits, I was like, I think my country will benefit more than in the UK. So that is where I am. I have 2 jobs, so you guys know what to do. Like I even saw Kemri, you highlighted very well that pulmonary rehabilitation is needed. A protocol for children is really, really needed. Now the ball is on your court. Yes, then I think that answers all the questions that were asked. Thank you very much.
Thank you so much. Dr. Joy and Lucy.
Thank you for the great questions. I did not capture the names of the people who asked the questions, but I just go straight into them. And I think the first one was on oscillometry and possibly what more can we do, oscillometry and spirometry, now that we have identified extra lung function disease, what then more can we advocate for? So the thing is, with a lot of the other tests, we were able to do sequential testing over multiple times. So we were able to see the trajectory of the symptoms, we were able to see the trajectory of possibly the radiology much more than the lung function, which we started much later. What I would advocate for is more objective lung function assessments with proper algorithms telling us when, at what time points are we, depending on the severity of the disease, because oscillometry could easily be capturing small airway disease earlier than all the other parameters. And so what we would like is to have optimized treatment before it gets worse. These children are still developing. If we leave them without, so for example, if it's an obstructive disease, then can we intervene? Can we give them the bronchodilators that they need? Can we taper that according to their needs? If they have restrictive patterns, then, or what we call impedance in oscillometry. So if they have that, then we agree, we actually acknowledge that this might not be treatable. They may be having permanent lung damage, but can we curb the extent of the damage over time? Yeah. So just having optimized lung function assessment, and then based on what we see in terms of severity, then at that point we intervene. So just looking at the other questions in terms of So in terms of the services that we were able to do, so you know that we were conducting a research study for over 24 months, and it's capped at 24 months. And a lot of these research studies are capped because of funding. And so then in terms of continuity of care, we were able to refer them to the pulmonologist. Of course, with our results, we're able to give them the results. We're able to refer them to the pulmonologist. And for some of these children, a lot of them I think were seen in KNH and Mbagathi hospitals. And for some of them, we've seen improvement over time with the interventions that they were able to get. So as a facility, as a research facility, the most we could do is just advocate for further specialized treatment. I'm not sure I had any other question from there, but I remember Brenda's question on BMI in adults, and so my thinking in terms of the differences. So it's more accurate. I would think it's more accurate in the adults because they are fully grown. Whatever damage that they have is there, but for the kids, they are still developing. So you may find that the ones who are malnourished, and a lot of our kids are below 8 years of age, may not be able to mount a good enough immune response. And so you'll find the other ones are able to mount a good immune response, and then they're able to form those inflammatory cytokines, all those mediators that we talked about, which eventually still end up damaging the lung further. So that's my thinking around that. I hope I didn't miss anyone's question, but thank you.
Thank you for the opportunity to respond to Mashauri. I work with Mashauri, so I understand where he's coming from. He basically manages a ward that a third of the people in that ward cannot go home because they are dependent on oxygen. So I feel his pain. And I understand that nephrologists have done a lot of things to make sure that their patients can work from home. And perhaps we do have a big role to play. But Mashauri, this is bigger than RESOC. I think if I look at that poster, we probably need a multidisciplinary team to be able to come up with a document and a proposal for the government. So RESOC alone cannot win. And I think we need to work with the National TB Program, CHAI, CHS, all of us come together, write a proposal, and see how far we can take. But I also want to comment that it's not just a concentrator. When you're giving a patient a concentrator, remember the concentrator will need electricity. So do we have electrical power connectivity? Secondly, they need to pay for the electricity. Then, and you know, all of us pay for electricity monthly, right? Can they afford? And then lastly, each machine needs a maintenance. So who is going to maintain these machines? So it's just not giving a patient the concentrator. It's about looking at the whole loop. The patient will need the machine charged, the patient will need the machine maintained, and they will need continuous power supply. And a lot of us where we stay, we sometimes get power failure. What happens? So the question is complicated. It's a really complicated question, but I think if we do a multidisciplinary team discussion, we probably will have answers. Lastly, Eric, please, we know that patients can do rehabilitation while on oxygen. Not everybody will be weaned off oxygen. And some will need the oxygen to actually be able to do the rehabilitation. So I think there is a role for everything, and it's cumulative. Thank you.
Thank you so much. I think, Prof. Bimbo, I can't say no.
Yeah, just thank you to all these wonderful people. You guys are doing wonderful work. I'm totally encouraged. I'm Professor Maleche Obimbo, a pediatric pulmonologist and professor at the School of Medicine. Just a few additional comments from the pediatric perspective. The first, there was a question about the small airway disease and what symptoms might they have. So we have research that have been done by pediatricians that have revealed that about up to a quarter of these children
a quarter to one-third will actually have shortness of breath. But if you ask the question to parent or child, they under-recognize it, they don't report it. And for many of them, they'll say, oh, hana shida ya kupumua. But when you put them through a quick 6-minute walk test or make them go up and down the stairs is when you begin, you'll pick up that this child has breathlessness. And I think that breathlessness is the symptom. Remember, most of us may not have access to these lung function tests, so your first pickup is that identifying the symptoms. So shortness of breath is a common symptom. It's even more common than the chronic cough and the persistent sputum. Children will not give out sputum, so the question to ask when you're doing a symptoms assessment after they finish TB is, does a child cough? Do they have a wet chest? Kuna kikohozi kwa kifua. And you find out as many as a quarter to one-third have got that chronic cough and that. So those are the symptoms that tell you this child's chest is still sick. And that's the so-called symptom phenotype that Joy talked about. You have the symptom phenotype, you have the structural abnormality phenotype, and then you have the lung function abnormality phenotype, which is very, very nicely displayed in that study that we have been doing in Kemri University and Kenyatta. The other, so I really stress symptoms because many kids you may not be able to do spirometry. The younger kids are the ones who get more TB, and they are completely neglected in this story. They are, you know that we have the highest prevalences in the younger kids under 5. And so your symptom recognition is very important. The other thing is for pulmonary rehabilitation for kids, you know, it's easy to do exercise with kids. It is really easy. And there are models in Malawi. It's been tried in Malawi, and they worked with the community, you know, to come up with innovative ways where you can get kids, teenagers, adults, and just simple, we love to dance in Africa. So just having a structural, do this for 15 minutes every day, dance, skip, play kati, the exercises for building respiratory muscle strength. One can devise fun things that don't require a lot of resources that actually make a difference. So I think innovating and developing a rehabilitation or an exercise program that works in our setting, that's culturally appropriate, and that's the direction we need to go. The final thing is it's really unclear why there's more small airway disease in kids, but remember, TB in the under 5 is largely lymph node based. And I think that it's because on the x-rays you'll often see the hilar lymphadenopathy, you'll see the peribronchial going down the bronchus, and those lymph nodes heal with scarring, and you can cause then scarring and a bit of stenosis, which was really talked about in the earlier morning talk by Dr. Naveed. And I think for kids, because it's predominantly hilar lymphadenopathy and peribronchial lymphadenopathy, the healing with scarring, possibly that is why we are seeing more of the small airway disease, which we're not picking on spirometry. Or if you do spirometry, you pick it on the FEF 2575. And there are emerging papers that are showing that it's the FEF 2575 that picks up a lot of the lung function impairment, and we pick it up on oscillometry. Yeah, so I think with kids, we can make a big difference with fun, locally appropriate ways of strengthening them after recovering from TB. Thank you. And thank you so much to everybody who spoke.
Thank you, Chaka. Prof.
This was an extremely exciting session, and thank you to Eric. That's the name? Yes. Sorry, I have, as I grow old, memory is fading very fast. But you gave a wonderful presentation. Now, what I haven't heard and what we probably won't hear is the experience this country already has with the implementation of programs for post-TB lung disease care, at least in adults. There's been 2 or 3 projects that have been carried out in this country, and I thought it's important that the group knows about this. First, we've had 2 rounds of implementation research funded by WHO TDR that have worked mainly in Nairobi, that have looked at assessment of people completing TB treatment at the end of treatment to see how many of those would qualify to be called having PTLD. The first objective was to say, can it be done by programs? And we saw that it could be done. And the second thing was what is the proportion of people who have this or the other. The second phase of that was assessing people at the beginning of treatment and at the end of treatment. And you will be surprised too, because it surprised me, I had it last week in Lusaka, a significant proportion of people who are completing TB treatment who are assessed at the beginning and referred for rehabilitation, not at the end of treatment, but immediately after that, as they start treatment for TB, everything else goes down, symptoms go away, 6-minute walking distance improves, depression improves, and so on and so forth. Look out for that paper in the coming 3 or so months. It will be published in the IJTLD Open, so look out for that paper. That was one project. The second project was funded by the Global Fund, and I believe Immaculate is here and others. And it did demonstrate that we could come together, define what pulmonary rehabilitation would look like. There was a group of physiotherapists who came together and put down a national guidelines for pulmonary rehabilitation. So we are moving, we're getting there. And final for me, the oxygen story is a big issue, and we should actually probably just sit down and say, how do we solve the oxygen problem in this country? And it's not going to be RISOC. We can't do it. We have to work with the national program and all stakeholders to be able to solve the long-term oxygen therapy problem. This is about long-term oxygen therapy. It's domiciliary oxygen. It's not oxygen at hospital level. Can I walk home with oxygen and have access to oxygen at home? That's a big thing that I think we will need to spend quite a bit of time to see how we solve it. Thank you.
No, thank you so much, our Prof. Let's give Prof. Obimbo and Prof. Chakaya a very good clap. Thank you so much. It has been interesting. We give our panelists a very good clap. Let's go. That was a very good session on PTLD and COPD and pulmonary rehabilitation. Thank you so much.
Kezia? Do it? Oh, yes. I want to, we'll hold a bit for lunch. We still have one session. I want to welcome the next chair, Drusilla, who will take us through. Karibu, Drew.
Thank you very much, Mweni. Let's give Mweni a round of applause. I request we stand up and stretch as we prepare for the next session. Please pick flowers on top. We pick flowers on top, at the side, at the bottom. Thank you. As mentioned, we beg for your patience for an hour or so that you go through the next session. The next session will be on health system strengthening, which is very timely given where we are as a country, where we are advancing the integration agenda. In this next session, we'll have 3 presenters. The first 2 will build on from where we have stopped as far as lung health is concerned. We'll get a presentation around asthma. We'll have the second one on lung health implementation research, and we'll be wrapping up that session with the findings from the drug resistance survey that has recently been concluded. Okay, so I'd like to invite the speakers up to the podium, starting with our first speaker. We will have Dr. Samuel Otido. As he comes, allow me to introduce him. Dr. Samuel Otido is an assistant clinical professor of pediatrics and fellowship director of the Pediatric Pulmonology Fellowship Program at Aga Khan University Hospital, Nairobi. He trained in pediatrics and child health at the University of Nairobi and later completed a fellowship in pediatric pulmonology at the University of Witwatersrand, South Africa. Dr. Otido has extensive experience in managing children with a wide range of respiratory conditions, including asthma, chronic lung disease, and complicated pneumonia. His research interests focus on pediatric asthma and the management of severe and complex pneumonia. He's largely engaged in postgraduate teaching, mentorship, and curriculum development, and is passionate about advancing child lung health in Africa through research, training, and collaboration. A round of applause to Dr. Otido. Our second speaker will be Philip Mushiri. Philip Mushiri is a program manager with Clinton Health Access Initiative, pharmacist by training, currently pursuing a master's in global health procurement and supply chain management, over 20 years in public health, has supported the optimization of ART regimens in the country, the introduction of PrEP in the country, and the introduction of shorter TPT regimens, 3HP. Has supported rollout of COVID-19 antigen testing and COVID-19 therapeutics. He has supported HIV and TB programs with rolling out supply chain IT solutions in support of the Logistics Management Information System. He is currently supporting the program to roll out the Integrated Lung Health Program under IPACT projects. A round of applause to Dr. Philip. Our third speaker will be Dr. Immaculate Ann Kathure. Dr. Immaculate is a medical doctor with specialization in public health and over 19 years experience, skilled in strategic planning, budgeting, policy development, monitoring, evaluation, project design, and impact assessment. Currently, as head of the National TB Program, Kenya, she's responsible for leadership and coordination of TB control activities, including strategic planning, policy development and dissemination, resource mobilization, monitoring, evaluation, and stakeholder coordination. She previously worked with USAID as project management specialist, deputy team leader, overseeing the planning and implementation of PMTCT and pediatric HIV activities, and as a National TB Program Officer where she oversaw care and treatment activities. A round of applause to Dr. Immaculate. Thank you very much and welcome our speakers. We're delighted to have you today. We'll start off with the first session, which is Asthma in Kenya, Improving Diagnosis, Treatment Access, and Patient Self-Management. Welcome, Dr. Otido.
Thank you for the kind introductions. So the theme for this session is mostly for health system strengthening. So we'd like to see how will we be able to strengthen, asthma care in children. So it will not be more of science, just how can we advocate for asthma care. So title is Asthma in Kenya, Improving Diagnosis, Treatment Access, and Patient Self-Management. And just by the show of hands, I know we're just about to go for lunch. How many of us work with children? Okay, that's a good number. All right, so I have no conflict of interest. I'd just like to ask, probably by show of hands, what we think about this case scenario. So a 3-year-old child with the first onset of wheezing, which was associated with a runny nose, and has just joined preschool and has no history of allergies, no atopy. Went to the emergency area, was given salbutamol, nebulized, and discharged with salbutamol inhaler. I know we are not all clinicians, but who thinks this is asthma? Okay, we shall see. Okay. Second case scenario, we have a 1-year-old, was an ex-prem baby, coughing and wheezing. These symptoms have been recurrent for a while now. Was born at 29 weeks, required CPAP, so some form of non-invasive ventilation. Currently on salbutamol, only inhaler. Asthma or no asthma? I know tuko na njaa, yeah? No asthma? Even my fellows? You okay? One hand. Slide has disappeared. All right. So along the talk, we shall see where we belong. A last one. 5-year-old girl, 5-week history. So this is a previously well girl. 5-week history of cough, no fevers, no wheezing. But because as doctors we have to do something, was given salbutamol inhaler. So the consistency of this cough, initially it was a dry one, then eventually it became productive, yellow sputum, and because again was a child, had used some salbutamol before. Asthma or no asthma? Somebody has said TB because it's a TB symposium. I like that, yeah. So we'll see as we just discuss how these children actually present differently. So just as a definition, asthma is heterogeneous. So one of my colleagues also describes COPD different. They manifest so different. In children is way, way different. One child will come with one thing, then the next child will come with a totally different thing, and they all have same diagnosis. And the airways are always chronically inflamed. So even if they are well, no symptoms, the airways are inflamed, just waiting for the triggers, and then you start having the wheezing and the coughing. So there's variable respiratory symptoms, which are also associated with variable expiratory airflow limitation. So unlike COPD, sometimes where you can have permanent constriction, so with asthma you tend to have more of reversibility. For the 2021 global burden of disease, it was mentioned that we had 260 million people, and the number keeps on rising. It was projected to be around 300 million with recent studies. For the Kenyan guidelines, we mentioned that it was around 7.5% of our all population, coming to around 4 million people. Estimated deaths to be 461, so that was in 2019, and higher in lower and middle income countries. So we don't have data again for the deaths that occur in Kenya. I think the only country that has data on the deaths was South Africa, and it was leading with 5 actually worldwide. So globally, for children, again, we don't have Kenyan data. 5 to 10% of the children have asthma. Worsening again in the low and middle income countries, we tend to underreport asthma. It is more common actually than we think, especially in the under 5-year-old. So remember those 2 case scenarios because they present so differently. Yeah, so there are many phenotypes for the small babies, and it's the leading cause of missed school days in school for children. Lots of ER visits and hospitalization. So lots and lots of burden. So this was just comparing the world, Kenya and the world. So you can see where we have symptoms of wheezing and so more of the prevalence. Old studies again. We have no recent studies just showing us what is our prevalence. First one, which I actually found on literature review, was done at urban and rural areas. So they were trying to compare what are the symptoms of asthma and wheezing. So this was part of what we call the ISAC study, international study of asthma and allergy in children. Second one from literature review, again, this was now looking at in a rural setup, Uasin Gishu district. So as much as we say it could be a problem of urban setting, this study also showed that it was actually on the rise in terms of the rural setting, which was in follow-up to actually the second one. This one was actually even mentioned yesterday with one of our speakers. What are the risk factors? And preterm birth was associated actually with asthma. Also recently, asthma symptoms comparison with spirometry and air pollution So these are two places. It was in an urban setup. So they looked at Buruburu, which was one of the places. It was meant to be an affluent area. And from the Mukuru slums, where the prevalence was 9.5 and 6.4 in Buruburu. So this was mostly attributed to the housing. Prof. Chakaya talked about, housing, affordable housing. So some of the things that can be sorted was actually from them. And they found out that children who were living in those settlements, the biofuel that were being used to cook was actually predisposing them more to having wheezing symptoms as compared to Buruburu, where it's assumed it's more of better housing. They're using most likely LPG for cooking. So this one we mentioned about the Isaac study, and then the Uasin Gishu study, which was now looking at 12 years and above. So basically, it could be upon us, maybe people in this room, to find out what's the latest, because some of these are actually very, very old data. Again, for those who like science, for pathogenesis, we do this because we also want to do targeted treatment. You have your allergen, which gets into your airways, and then this is the end product. So most of the medicines actually should be coming from here. And the newer medicines, like it was mentioned with the COPD group, are now targeting the biologics. So when does asthma start in children? So it may be very difficult to say. This paper was looking at those children who are exposed to RSV virus. So RSV virus basically can give you upper respiratory tract infections only. But if we have some interplay with genetic factors, if you have some interplay with also environmental factors, you may have problems. So if you look at this healthy baby, probably born term, gets exposed to RSV, like most children below 2 years. Some of them, majority, will actually just have like a runny nose, a cough, and disappears. But if there are some interplay with genetics and perinatal factors, so some kids will end up with bronchiolitis. So these are the children we tend to see either as outpatient, majority as inpatient. Most will recover. Some will end up having recurrent problems, recurrent wheezing. And those who have now history of allergies, those who are predisposed to allergies now end up having persistent symptoms and later on just develop asthma. So this was specifically for RSV. Half of those children end up now having those intermittent symptoms of asthma. So as clinicians, because this is part of health system strengthening, how are we able to, pick up these children who have cough and wheezing? Are we able to categorize them as asthma or not? So the first thing, basically, you must have high index of suspicion. If these children are coming with coughing, they are coming with wheezing, the small ones. The bigger children will tell you, my chest is feeling tight. I'm having a lot of pain when I'm doing exercises, or I cough a lot when I run. So those are already symptoms which are suggestive. And then if you are able to, prove that there is some variable expiratory airflow limitation, so you may have to do your spirometry. This again has been discussed from yesterday to today. Some of these things, we need to have them in our hospitals. One gentleman actually mentioned that SHA can actually pay this if it's like 300 bob. In private sector, what we've seen is the cost can range from 4,000 to almost 10,000 just for spirometry. But if we have, main hospitals, like our county hospitals having spirometers, these costs can actually come down. So it's not easy to, I like the statement of advocacy is not easy, yeah? But if we advocate for some of these things to come to our hospitals, we may have actually a spirometry being charged for 300 shilling. Where I trained, it was actually free for all the children who are coming to the clinic. So every child who used to come into the asthma clinic, They pass through the respiratory nurse, they do a spirometry, and then they come to see the clinician. So it can happen even in our setup, no matter how long it may take, but if we advocate, we may have some of these instruments in our hospitals. For the under 5, it may be very tricky because you need more of your clinical judgment. But now we have oscillometry. Somebody has just actually presented about oscillometry. This is the best tool now to use for the children who are under 5 because it can tell you about small airway disease, and this has actually been rightfully said. You can detect it earlier, and then you can do a follow-up. And majority of our parents actually just need that, that evidence. So if you tell a mom that your child is asthmatic, there's a lot of stigma about it. But if you're able to prove that this is where your child was, and this is where your child is now after bronchodilation, it may actually help. For small children, again, we may have lots and lots of phenotype, especially for the under 5s, where you're symptom-based or time trend-based. Some of them will just wheeze during a viral infection, like the first scenario that we had. No other problem. Every time they get a flu, they may start coughing and wheezing. Those, again, may have multi-trigger. So these are children who get flu infections, they wheeze, but they also have history of allergies with themselves. The transient wheezers, the persistent wheezers, the late onset wheezers all depend on the time their symptom starts, basically from age. This is GINA 2025. It is helping us to diagnose asthma way, way better. So they've made it even simpler for us to follow. So if you have a child who is under 5 with recurrent wheezing, so you need all these 3 categories for you to make a diagnosis for asthma in under 5. So recurrent wheezing is one of them, or if they had just one wheeze, but in between they have asthma-like symptoms. So these asthma-like symptoms are the children who are coughing at night. The parents will tell you every time they go to sleep, they are coughing. Before they wake up, they have a lot of coughing as well, and it's mostly dry cough. Or when they are playing with their friends, they are coughing again. Okay? They may not be wheezing, but just coughing. Or they are not even able to finish maybe a football match or a racing game. They are always tired. Something actually Prof. Bimbo even mentioned. The second category is where there is no alternative diagnosis. So here you're not suspecting TB, you're not suspecting bronchiolitis. There's no cystic fibrosis, only cardiac disease that can make us have cough or wheeze. So these one now you have to rule out clinically. Or if they come in respiratory distress, they are responding to salbutamol, okay? Either at home or in hospital setting, or if you have given them medication, inhaled steroids for 3 months. So if a child qualifies for 1, 2, 3, then it's very easy to make a diagnosis for children, even below 1 year of age. Again, we have Kenyan guidelines, so as much as, yes, we have international guidelines, I know people in this room contributed to this book. It's a very brilliant book. I enjoyed actually reading literature. It also gives us a flow diagram of a child who is coming with wheezing. It also mentions the clinical aspect, and where there's no spirometry, this is what to do, and then you come up with a diagnosis. So I'll not go through it. And sometimes you're stuck. So these kids who are coming with recurrent coughing and wheezing, there's also evidence that some of them may end up having asthma. So there's what we call the modified asthma predictive index. So if a child comes with recurrent wheezing, it will guide us and say, possibility that this particular child may end up having asthma or not. So again, if your child is coming with recurrent wheezing, one of it you have seen as a clinician, you only need one major sign. So if they have a parent who has asthma, more so we say if the mother has asthma,
probability of a child getting asthma is very, very high, even as much as 60%. If they have eczema, that's a major, major sign. And if they have sensitization to any allergen, so it could be the grass, it could be mold, that's one major sign. If they have recurrent wheezing and one of those, highly likely you're dealing with an allergy, with asthma. So we mentioned about spirometry. We need to advocate for it. It can be done even in smaller children, so long as you have a very patient technician, as low as 5 years. I know we do it for older kids, but a child who's 5 years with a very patient technician, you can be able to have it being done. Pheno in private hospitals costs around 6,000 to 7,000. Again, because we don't have it in so many places, you'll find that some of these costs will be very high. But if you have them in many, many places, these costs will come down. Yeah. So if we have pheno, which are high levels, ERS talks about 25. GINA guidelines put it actually at 35. So it's a mark of lung inflammation. So once you do this, it's a supportive test. So it's not really diagnostic for asthma, but we use it for phenotyping. Is it an allergic asthma or is it not an allergic asthma? And you can even use it to see if there's compliance in treatment. Again, cheap. Peak flows, these are actually supposed to be on your desk as you are seeing your patients. Very, very cheap. You can even have it as a patient. You can prescribe it and they go home with it and they keep on writing their peak levels. And when they come to the clinic, you can see the variability and you can make a diagnosis. Bronchial challenge tests, these are mostly for high-level hospitals, level 5, level 6, and the tertiary hospitals, because it has to be done in a place where resuscitation can be done. So you have to provoke the airways into bronchoconstrictions, and then you get to do the measurements. Other tests, even your hemogram can be suggestive. So if you have high eosinophil count, it's suggestive again for an allergic disease. You can do skin prick tests. You can do IgE levels. So again, here we're talking about level 5, level 6 hospitals. So what are the challenges we get in diagnosing asthma? So for children, like I said, it's really hard to do spirometry for them. They do struggle. And I said 5 years, but even a 10-year-old sometimes will even struggle to do this kind of tests. They are expensive. 10,000 is not for everybody. 4,000 again is not also for everyone, but we can advocate for them to be cheaper and cheaper as a society. And then oscillometry is the new kid on the block. So again, cutoff values are being investigated as we speak. So it's something that is very good now for research. And then health systems are different worldwide. So whatever the British are doing, whatever the Americans are doing, they're also using different cutoffs. They're using different algorithms when it comes to that. So it's still challenging for children. And money. So if we have money, we are able to buy all these things for diagnosis for children. Again, this came from the Kenya Asthma Management Guidelines. What we need to have in our hospitals. So for level 1 hospitals, if we do training for health community workers, where they can go into the community, they can pick up patients who have these symptoms for asthma. This has worked very well with the pneumonia program, where they are able to pick up children who have fast breathing and cough, and sometimes even given medications. So children are given high dose amoxicillin and possibly referred for care. So why can it not also happen for asthma? It's possible to tell, just to train health community workers to diagnose or to pick up these children. For level 2, 3, remember our president said, you walk into this hospital, it's free of charge, and you go back home. We need to have even peak flows for those hospitals. Level 5 and 6, we need to have spirometers to do the tests. We can have skin prick tests, we can do IgE levels. We are now expanding as a country. There are lots and lots of subspecialties now coming in. So even our allergy specialists, I know there are very few in the country, but with the trainings that are ongoing, we are expanding. We do have a pulmonology program at Aga Khan and training fellows. UN is also starting one soon. So again, that field is always expanding, and we need to be ready once all of us are on the field. So what can we do? Again, for advocacy, we encourage lots of training for doctors, even for nurses, clinicians. We need to have high index of suspicion for asthma. So this can come through CMEs, it can come through such forums like this, it can come through conferences, it can come through all those online meetings that we have. So the more we talk about it, the more we understand asthma, the more we are able to diagnose and to have more confidence in even having a diagnosis of a child who is 1 year old, and you can comfortably say this is asthma. You can have a screening tool in your offices where you can just tick boxes. Child with recurrent cough, recurrent wheezing, they have eczema, their parent has asthma, or they have allergy-like symptoms. So you can have those little papers and you just tick, and you're now screening these children for asthma. Be objective as much as possible. If you're able to do the tests, do it before we start treatment. You can use the local flowcharts like the one we've just displayed. If you're in doubt, you can do early referral. Most of us, we're actually readily available for any form of consult. What about treatment? So we advocate for treatment with inhaled corticosteroids. So there is no role for salbutamol only treatment for children or even for adults. So once you've made a diagnosis of asthma, you must be confident and you must even convince the parent that this particular medicine that I'm giving you is going to help with lung inflammation. There's a lot of stigma about use of inhaled steroids. Again, for children under 5, use your inhaled steroids, and we are avoiding salbutamol only treatment. If you have asthma, there's no role for bronchodilation only without addressing lung inflammation. And then the older children, almost similar like the adults, so you can use ICS for Motril, which is what now Gina advocates as MAT therapy. So what has Kenya done so far? We have our Respiratory Society of Kenya, which has helped with the guidelines, which are just recently, if I call it recently, maybe some 2-3 years ago, launched, and we can use it as a reference. We have a Kenya Essential Medical List, which also has a couple of medicines that we use. There's budesonide for Motril, there's ipratropium, there's montelukast. But it's good to have such a list, but are they really available in our hospitals? Back in the time when I was in the county hospital, we used to have only beclomethasone and salbutamol. But what happens to those children where that fails, where you need to step up treatment? So I'm hoping by now we have all the other medications. They can be listed, but they are not in our pharmacies. Reducing practice variation in children. So we must be all in the same page. How I treat my patients in Aga Khan should not be different to how you treat your patients in the county hospital. We should all be speaking the same language. So if we are doing ICS, we are all doing ICS. If we are using a spacer, we should all be using a spacer for children. So spacers are also very expensive, and they can go as high as even 5,000 and above. But you can have plastic ones, where it has been shown in many studies that is as effective as the commercially prepared one. Again, ensure availability of medicines. We spoke about having SHA. SHA is here. Prof. Chakaya said it's not going anywhere. So we have to see how can we lobby now for all these things to come through SHA. I'm actually surprised Dr. Jackie actually mentioned that SHA is paying for some of these expensive, which I thought actually are very expensive for this kind of high-level bronchoscopies and interventions. So if it is doing those high-level treatment, we can have some of these things that we are advocating for under SHA. Even if it was forced down our throats, we have to do something about it. So again, no role of cough syrups in children. There's a lot of stigma about inhalers. So a lot of teaching must go to specifically us as clinicians, that we shouldn't be giving cough syrups as a treatment for asthma. There is no role. In fact, it can even make the child more sick. Again, we use inhaled bronchodilators, inhaled steroids. We are not advocating for oral bronchodilators, so there are a lot of oral salbutamols in our shelves. We do not advocate for the use of it. The doses are so high that we end up having complications and side effects. Even if you are stranded somewhere, I think I have a friend who works in Turkana here. Peter is here in Turkana. I'm sure there's inhaled salbutamol, in Turkana. So we shouldn't be having such medications there. For patients, as much as we play our role, the parents must play their role as well. So we can't just be forcing things. There has to be a reciprocation from them. We do give individualized action plans. Like I mentioned, no asthma is the same. One child will not have the same treatment like the other. We need to educate our parents about the myths of asthma. It is not their fault. We need to talk about the treatment. We need to talk about, my child, they usually complain was my child will be addicted to inhalers. And that's usually not the case. So once you address the myths, you'll be having less and less of asthma attacks. Adherence to medication, and then early referrals to the hospitals if their home care is not working. So my big take-home message is let's confirm our diagnosis. I've spoken a lot about using spirometers, but your clinical judgment still number one, especially for the smaller children. Let's lobby for diagnostics as much as possible to be in our hospitals. We go with the current trends. The asthma that was being treated many years ago, it's not the same way how we treat it now. So we should be using current trends for asthma, and that includes inhaled steroids and stopping oral bronchodilators. And then we should be having individualized action plans for all children. Thank you, everyone.
Thank you very much, Dr. Tido, for that comprehensive information on asthma and reminding us the incidence is higher than we think. A round of applause to Dr. Tido. Our second presenter will be taking us through the lung health implementation research. Welcome, Dr. Philip.
Good afternoon. Good afternoon. So I hope you still have the energy to listen to more stuff. And I will take you through on behalf of Dr. Ibrahim, who is not available from the program. So I will do that on his behalf. So, So in terms of the lung health and what the program haven't managed to do, and probably you can go to the next one. And I want to, I know this is a slide that we have all looked at, and and we have a lot concentrated on what need to be done in regards to to TB, and we can be able to demonstrate in terms of the impact that we have had over the years in terms of management for TB, and we have seen reduction in mortality looking at from 2015 to now, and also even incidences of TB in the country. And with that, still looking at our program, it's a TB and lung health program, but the L for some time have remained a bit silent. But we hope now with what is happening currently, we'll be able to activate that. Looking at our strategic plan is that we want to reduce the burden of chronic health conditions by 20%, and this comparing to 2015, and that's what is anchoring lung health work at the program. And why do we have to do this? Looking at the burden of chronic conditions in the country, and data that have been reported through, also through KDHIS, it shows about 1% for men and women, age 15. With the subnational studies reported prevalence of up to even 21.7%. And generally, as a country, we don't have good data in terms of the way we are saying for TB, that we can actually be able to say for TB, we have about 124,000 cases that are being reported every year. But now for asthma, COPD, and even PTLD now, we can be able to tell to what extent is that burden in our country. And the data that is being reported through KHIS, it's still not very adequate, and we need to look at that. We are on some of the conditions that we are able to report, like pneumonia, which is one of the leading causes of death for children. We can be able to see that, but now for the others, we are not able to do that. So there are some other study in Kenya, Ethiopia, and Sudan. Proportion of patients with respiratory symptoms attending outpatient clinic with asthma, almost accounting for about 26%, chronic bronchitis 25%, COPD 8%, and bronchitis is about 5%. And we need to look at this. And I think Kenya had already been engaged in this through the BOLD study. And some of the risk factors that we are seeing is about 11% of our men actually the bit of smoking that we can see as opposed to women, which is about 1%. So half of Kenyan household, we are still using biofuel, including charcoal. Even when you look at our rural areas, mothers are using firewood, and that is posing a high risk for respiratory and chronic respiratory conditions. We still have our environment right now. Kenya is being ranked about, I think, the second most polluted cities in the world. So we are likely to be growing some of these conditions in the country. And we hope that with activating the lung health program within the program, then we should be able to improve this. And looking at our own data, that 2021 to 2023, is that our respiratory conditions or symptoms that are being reported within our outpatient setup is about, sorry. So which is about 39% of the cases that are reported in our outpatient. So that means in terms of classification of the various conditions for the lung, then we need to have a very elaborate program to have a differentiated diagnosis and even screening to ensure that we are able to classify our patient well and provide appropriate treatment. So we have rolled out X-ray. So for patients who probably they have taken an X-ray and they're told perhaps you don't have TB, so they end up to a great extent also celebrating So while still the patients have come to the hospital with what is ailing them, we are not able to provide that differential diagnosis, and these are one of the areas that we have to think about. How do we provide that differential diagnosis and ensure that we actually give the patients the right therapy and intervene in the right way? So looking at our own data, this is going beyond TB. So we are now adopting AI. And when you look at the data for July to December 2024, you can actually see there is significant cases of non-TB. And we have to look at how do we, to a great extent, have a differentiated pathway that will ensure that we are able to classify for patients who have TB, they actually initiated on TB, and we can do molecular tests and link them to treatment. For those others, are we able to link them to the right path? Those ones who require spirometry, probably we need to have that. So we need to think about beyond TB as we get or we introduce new tool into the space. Looking at what are ailing our system currently, is that lack of an integrated lung health training curriculum that have not been was not there. 41% of our TB cases are clinically diagnosed, and remember, still some of the symptoms mimicking each other, and we need to provide that differentiated diagnosis. And I remember when we are looking at the mortality data for 2021, we actually saw a lot of comorbidities between TB and asthma, COPD, and even the lung cancer. And if we are not able to differentiate conclusively in terms of what is ailing the patient, some are actually being put on TB treatment and perhaps they are not having TB. Insufficient access to lung health screening and diagnostic tools. Generally for TB, we can see that we have done a good job in terms of that, but for these other conditions that is not there, that have not been there, but we hope that we as a country we are going forward with that. These lung health services are not linked with the TB services. So when we need to be able to have that linkage, that we change even the culture that we have been having, that when we get into the chest clinic or TB clinic, we're only thinking about TB. If one don't get or don't find out that the patient have TB, they send them for other things. Suboptimal differentiated diagnosis pathway for lung health, I think I have mentioned that. Suboptimal knowledge of healthcare workers in terms of management. Our M&E have not been robust enough to be able to capture these conditions, and we can be able to classify our patients well in terms of even the gender, age groups and all that, to help us do programming and even aiding decision making. So suboptimal mapping and linkage collaboration of donor and government effort toward addressing lung health service delivery that largely had been low, but I think now where we are in a better place. So what are we looking at? So there's a baseline assessment of lung health services that have already been conducted, and we'll be able to take you through some of the outcome or the findings of SARA. Public coordination, bringing all the stakeholders together, that as a country we are able to move, capacity building of healthcare workers, adoption of new technology, which include now the chest X-ray or digital X-rays with the AI. There's spirometers, and even there are now new, even more tools that are coming in, like the digital stethoscope, which we can be able to utilize to be able even to classify further, even to the coughs that we are actually getting. There is a lot of advocacy that is required, even at the community level, both even within the government structure to ensure that it's actually also supported. There's monitoring and evaluation that which need to be expanded. We already have a tool that the program are utilizing, which is TBU, and we may need to incorporate some of these other indicators to help us track these other conditions. There's operational research that is required, even when we are utilizing digital X-ray with the AI, at least for TB, we're able to see the efficiencies. We can be able to see the efficiencies. Can we be able to do the same even for these other conditions, that we can see the efficiencies? We can talk about the yield that we are referring to in the TB side. And with that, I think we hope that as we do this, we are able to improve the efficiencies. Sustainable financing and resource mobilization, which I also have been mentioned. There is also opportunities with the SHA, and what can we be able to do with that to package what is required. We already, there are some partners who are now in the space. There is CHAI with the impact project that is meant to cover about 18 counties, 3 from in the first phase, which is up to January the coming year. There is also FIND, there is CHS, and we with this space trying to organize, and the program is doing bringing everyone together so that we can move forward as a country with one strategy. So let me go to the baseline assessment that was done in about seven counties to see what exists and the systems issues that we need to focus on to ensure that we're able to offer an integrated lung health program in the country. As essentially, the objective was to assess the availability and readiness of our health facilities, to identify capacity gaps, determine the most appropriate interventions to build the country capacity to implement lung health interventions. And with this, we had also some specific objectives, looking at whether the guidance are available within the system, commodities are available, what kind of financing is happening at the facility level in terms of supporting the service delivery. The other one is to assess service availability for lung health conditions. That is in the counties that that were visited in 2024. That is that was November and December last year, to review the current practice on screening, evaluate and managing clients presenting with respiratory condition at the different levels of the care, and we are able to look at that, and to conduct stakeholders analysis for lung health services, just to ensure that we don't leave anyone behind who can be able to offer any support or any input to the rolling out of this. And how was it done? It was a systematic approach, so looking at secondary data analysis, looking at what is available in the country, which was mainly data review. Then we looked at data correction at facilities in those seven counties. A tool was developed to help in data correction, and a comprehensive assessment of the key building blocks of the health system was actually done. And what did we find out? In terms of governance, availability of political commitment in various policy documents was seen to be there, including the primary health documents that are available, including PCN and all those. You could see there are some things that are indicated that we could be able to ride on to continue building on that. Lack of updated integrated national lung health guidance, largely because there are new developments that have come into place that require to be adjusted, and ensure that we actually do we are providing the standard based on the guidance that are out there. Lack of structured program to provide comprehensive lung health services, and I think this is one of the things, and the program is doing to ensure that we actually even have a TWG that can be sitting together and reviewing the implementation in the country, and even to guide the way we do have for TB, that we can actually also be able to support that for these other conditions. The other gap area that was looked at was the human resource for health, and we realized there are a bit of gaps, and as you can see, there are key cadres that were found to be inadequate. Like if you look at the radiologists in these counties, they represent like 1%. Yeah? And if we expect them to be able to report all the X-rays or the scans that are being done in counties, then it will be a challenge. So we have to think about task shifting. The other one, which is not here, even the pulmonologist. If you look at the distribution of pulmonologists in the country, very, very few. And I understand even the ones that are available in the country, we are probably have about 40 pulmonologists, and we expect to support all this. And most of those are actually in the private sector, and most of those also in terms of in terms of their age, some of those are also advanced, actually like half of them, so they're above actually 60. So we have a challenge there, and we have to think about how do we collaborate with the academia to increase some of this pool of experts, continue having technical assistance, even mentorship to healthcare workers to be able to identify these conditions, and utilize existing e-learning platforms to continue supporting our healthcare workers and building their capacity. Service delivery, key finding is about 9% of facilities that were looked at had spirometry services. So you can see it's very, very, very low, and most of them were actually in Nairobi. And you can see the cost ranging from 300 to 15,000, and this is out of reach to many patients. We also seeing that even the most basic tools like pulse oximetry were not available in about 25% of our facilities. When you look at the level in level 4 and 6, at least for those ones, most of them have pulsometers, but the level 3 and 2 indicated there are very, very few of those ones. So, and what the program is looking at is at equipping primary care and referral facilities with spirometers, picrometers, pulsometers, nebulizers, and necessary consumables that will sustain delivery of services, and we are able to pick these conditions even early at the primary health facilities. Standardize care and train healthcare workers on the packages of services for lung conditions, because we know with the level of facilities that we have, there is what each level of facility can be able to offer, and that is now that have been defined to help each level be able to do what they can do at that level. So these health information systems, we already have, like for asthma, the data, we do have data that is being reported in KHIS, but when you look at the COPD, PTLD, we don't have country data, and this is one of the areas that we have to provide. Looking at the distribution of what the facilities are using, there are those ones who are using EMRs, there are those ones who are using manual register and all that, and looking at the what is happening with the digital superhighway that is being rolled out in the country, we have to think about how do we bring all this together, including interoperability between systems to ensure we collect enough data to help us do programming and planning. Health products and technologies, it's also a major gap availability for steroids and other medications. We are not generally not available. Look at also spirometers, only available in 16 out of the 2,201 facilities that were assessed, and most of those were actually in the private sector. So we have to think about how do we support the public sector to have these tools. Pulse oximeters, as I had mentioned, they're also in very few facilities. They're available in majority of the level 4 and above, but when it comes to lower facilities, they are unevenly distributed. Peak flows only available in about 6%. And it's a very, very simple tool, very, very cheap, about 2,600, where each facility can actually be able to have that. So it's very cheap tool that we can be able to utilize, but it's not available. Then we also have facilities, about 38% of facilities are having X-ray machines, some manual or analog, some digital, that we can be able to utilize and ensure that we are not missing anyone. So there is integrated reporting system for TB medicine, which we have to think about. how our patients, how do they access medicine? Are they actually even available, and what kind of medicine is actually available? Because as we have seen from previously the previous presentation, we are finding facilities who have even frano, some of those very old one practice that have been that are still. The patients still go to the to some facilities asking for frano. We know what is the issues that are there with the frano, so which we have to be able to change even the public awareness probably. Integrate reporting tools, so we have to think about our supply chain systems to make sure that the drugs becomes available to those who need them, we have already seen that most of the products actually included in the essential medicine list, but they are not available. So we also looked at the infrastructure. And some, most of the facilities to a great extent, some achieve the required standard, some are not yet there. And even some of the basic things that to allow for the disability-friendly facilities, then we found that being an issue. So what do we recommending collaborate with the relevant stakeholders to expand the availability even of oxygen, as it has been mentioned, is a challenge. Advocate for health facilities to improve access for persons with disabilities in terms of the infrastructure. Even when they are putting up the infrastructure, they also have to think about the disabilities. Strengthen the administrative measures, such as even cough etiquette, and even providing enough waiting base to ensure that we meet the IPC standards. Health financing is also an issue as you look at what is even provided for by SHA. It's about 900 bob, and that should be covering even the cost of X-ray. And when you look at the cost of X-ray, currently about 600, 500 bob. So you realize if you are to add utilization of spirometry, then we may not be able to do that, and we have to do some advocacy in terms of that. The recommendation that we have is conduct resource mapping and expenditure tracking for efficient funding models that the country need to adopt to look at the private sector, what the private sector can be able to do, and for private sector mainly we know probably ensuring that they have the capacity, and for the patients who go there, they are patients who are willing and able to pay. So if they are able to pay the services that are being provided in an optimal manner, then that will be a good way to consider and look at what SHA package can be able to do or adjusted to ensure it covers everything. So I think because time is moving quite fast, so in terms of the establishment of the SARA, that is actually already done, we could say, and what the program is looking at is the gaps that have been identified to be used now as a case for case investment to see the areas that need to be adjusted. We are looking at to determine the burden of disease in the country for COPD, how the modeling will be done, and with that we hope that in the next 1-2 years, then we should be able to have burden estimates for these conditions in the country. The review of the guidance have already been done now, awaiting launch. So and we hope that with that now dissemination of the same now to healthcare workers to be able to provide the services that are required. The M&E component, adjusting like the TB to ensure that it captures the indicators for these lung conditions, then that's already ongoing and is complete. And the other part is to ensure that there is also interoperability between TB with other system to ensure that the data that we require as a program, we are able to have that. We also looking at how we roll out as an integration, looking at both the TB and the lung conditions, and we hope with this that we should be able to increase case detection for TB and the rest of the other conditions, and that's the work that will be happening. So we also have research studies that will be conducted. One of them is looking at evaluating the digital X-ray with AI as an initial screening tool, and how to see how efficient is it, how can we be able to leverage that to ensure that we have efficiencies, even the way we utilize our cartridges in the country. Validation of children, the recommendation that we have is utilization of AI for adults, but for children, we don't have a lot of information, and that's one of the areas that the program is looking at. So the other one is the use of digital stethoscope to be able to differentiate the different coughs that patient presents with, to see if it's TB, can we be able to characterize the type of cough using a stethoscope with an AI, and with that, or asthma or the other conditions, then we can be able to adopt some of these tools to help us to identify this. So this is just a data for the 3 counties, looking at facilities that have digital X-ray, that have spirometry, peak flow meter, and all that, and it indicates if there is opportunities for optimization and ensuring that we are able to classify our patients well. So I think I will stop at that point for the interest of time, and thank you.
Thank you very much. Thank you very much, Dr. Philip, for outlining the comprehensive lung health spectrum in the country. What are the key gaps, results from the baseline survey, and where we are in terms of implementation? Can we all do like this? Both hands, please, so that we get our hands out of our devices. Yes, we are all alert. So we'll invite our third speaker, who will be taking us through the results of the drug resistance survey. Karibu sana, daktari.
Good afternoon, everybody. Hey, okay. Now, clearly, I need to do better because either the room is half asleep or very hungry. And since I'm standing between you and lunch, I want to try my best to see if I can fit within 15 minutes so that people can get out and buy something. So I'll be taking us through the findings of the prevalence survey. But before I start, coming from the ministry, it's always good to give a rejoinder on some of the asks and some of the commitments and the things that we are doing, and I'll just take a minute for that. So one of the very interesting conversations that I've had this morning, and one of the things that we really are keenly going to pursue, is the issue of having oxygen concentrators for use at individual level as part of post-TB and chronic lung disease management. I know we already have done a lot as a ministry to ensure oxygen is available in our facilities, and that is a conversation that we will be actually taking up. And since you're already having negotiations with the SHA task force to review the benefits package for TB, leprosy, and lung health, the good feedback that we have received is that is something we need to include. Now, the other thing that, and it's a bit unfortunate, Prof. Bimbo has left, and it's one of the things that we'll be following up with her office, is looking at pulmonary rehabilitation for children. And since you're already doing a lung health program, incorporating that as part of our protocol, as you've heard, there's a bit of operations research that will be going into that, and then just making sure that we're also able to take care of the children. I'm glad to report that, and I'm happy to see people are reading the guidelines. I just want to let us know there is a 2025 version that will be coming out soon. Look out for it. And just to let you know that even for the data, now we are having lung health data, and it's actually age and sex differentiated. So we'll be able to know chronic lung conditions presentation from birth all the way throughout the life course. Now, equipping facilities, that has repeatedly come up, and I'm really happy to report that one of the strategic initiatives the program is undertaking through the support of our donors is to make sure that at least as many primary healthcare facilities have a peak flow meter, and most of our sub-county and county referral hospitals have a spirometer. And the conversations with the SHA benefits package is to make sure that those costs are actually included there. So just to let us know that there is quite some work going on in the lung health space, and we are looking and counting on all your support. Sometimes we call on some of us to participate in these discussions. Please show up, please support us, and let us move that agenda forward. Now, moving swiftly to the presentation, I'll be taking us through the findings of the survey. Just to mention that, of course, TB is a big public health threat and a second leading cause of death by a single infectious agent. But why is that important? For us as a country, we have over time transitioned from one of those countries that are high burden for drug-resistant TB. But we still remain a priority country for TB, and as treatment regimens are evolving, we are keenly monitoring the situation because the risk of emergence of new resistance patterns is very high. Just yesterday, we were talking about the possibility of incorporating some of our second-line treatment options as first-line treatment or first line of defense. What that means that then there poses a risk of emergence of new drug resistance, and something that we are keenly monitoring to ensure that we're able to take care of it. How are we doing that? We are undertaking routine surveillance for drug-resistant TB. Right now, it's limited to high-risk groups, but just to mention that we're incorporating up to and including use of genome sequencing to be able to have very targeted surveillance going on. Now, we have a lot of factors associated with mortality, especially for our DRTB patients, but the worst and the most critical, and the one that we all have a chance to play a part in, is late diagnosis or late presentation. So usually the delay is at two levels. At our level as a clinician, so the patient comes and it takes us a long time to pick that this patient has a resistant form of TB, or the patient stays within the community and takes a very long time before they come into the health system. So during the survey development, we know that there is a high risk of morbidity and mortality as a result of drug resistance, and also catastrophic costs as a result of the burden of drug-resistant TB. And the other challenge that we face is that not all our patients access molecular diagnostic tests. So it means we are very quick to diagnose TB, and just yesterday again in this particular space, I had a conversation with one of us that was very happy that we have TB Lung. And they were saying, Dr. Can we push more of this? But why do you insist that every time we do a TB Lung and we know it's TB, can't we just treat? And I was telling them, but what are you treating? We know you're treating TB, but is it drug sensitive or is it drug resistant? So a lot of conversations, and we realize some of these things are not out there, and one of the things that we're trying to strengthen. Then we also know that surveillance coverage for DRTB for some of those treatment drugs was suboptimal, and some of it was not known. So we did not know what circulating strains we have. We have changed our treatment. We've currently moved from 18 months to 6 months of treatment for DRTB. And we also have wide use of anti-TB drugs, up to and including treatment of cows. I know, wale wako na ng'ombe, you know, we use rifampicin to treat brucellosis, yes. So you can imagine the risk factors are coming from many places. So as part of our justification, of course, I mentioned that there is increasing access to molecular diagnostics. However, we need to be able to differentiate what are these DST patterns that we are seeing and how are they evolving. Then we are also seeing the emergence of new molecules. How is that impacting our resistant pattern? And then we are also looking to scale up drug-resistant TB preventive therapy. And for us to be able to do that, we would want to see how the resistance pattern is actually looking like in the community. And then the availability of resistance patterns, especially for the newer molecules, remains elusive. So what did we do? We came up with a few survey objectives, of course, to estimate the prevalence, but then the first and second line, compare the phenotypic and the genotypic resistant testing approaches, and in there with through genome sequencing. Then we are also able to map the genetic characteristics. What is it that makes certain strains of TB more virulent or more prone to developing drug resistance? And then what are those sociodemographic and clinical correlations that drive the drug-resistant TB, and also looking at the variability of resistance among the co-infected patients. So of course, I'll not belabor the methodology. We were looking at new and previously treated patients. That's the definition of what they were. And all bacteriologically confirmed new and previously treated patients were actually enrolled in the study, but the study was divided into two parts. We had the main study that was just looking at all our TB infected patients, but we're also having a subset where we were looking at the TB HIV subpopulation because we wanted to see, does drug-resistant TB vary by comorbidity or not? And if it does, using genome sequencing to see, are there genetic subvariations in that as well? So this was just the patient recruitment pathway, who was eligible, who was not eligible, and how we were able to collect the samples. We were collecting 2 samples, 1 spot and 1 after taking the patient history and the consent. Then out of the 2,931 enrolled patients, I would want to report that, yes, we managed to complete the survey. And out of those, we managed to submit 2,655 samples for testing, most of which were actually tested, and we'll be seeing how the results for that came out. Now, for those that were tested, of course, we were using GeneXpert and first-line LPA. And then for those that had any form of resistance, we then went ahead to undertake genome sequencing. So that is we also had concentrated smears, of course, looking at what the outcome for the various testing modalities was like. Now, what was the level of detection? And this is where now the conversation gets interesting, is that MTB was detected with trace results at 19.6% of health facilities compared to 2.5% at the National TB Reference Lab, meaning that most of our peripheral facilities were picking trace results more than the rate at which we're picking it at our national level. And the question that begs, this is what we always say, every study has the main outcomes and the sub-outcomes, is what is happening during the process of sample referral and sample transmission. Then the level of detection at health facilities for GeneXperts, we may not have had details, but new enrollment by type of test is available. Now, the other thing that we did look at is the enrollment assay for those whose MTB was not detected at NTRL by any method. These are patients who in the periphery, we looked at them, we wanted to find out if indeed the field reported them as not having MTB. But the field reported them as having TB in one form or the other, but when the results came back to NTRL, we actually went ahead to pick TB. And one of the things that we discovered is that at the end of the day, we could account for each and every one of those patients. And the 113 patients, and I'm not sure, I don't know which part of this is the pointer. Yes. Are we together? We can see the light? Yes. So we had 113 who initially were picked in the field, but then ultimately when they came to NTRL, they were not picked, and this is the number. And we can see that majority of them in the field had been picked by GeneXpert, but then when eventually they came to NTRL, those particular results were, there was a variance in the results. Now, we looked at the first-line LPA testing, and out of those that were confirmed, we had 2,337 samples that were also confirmed by LPA. And both were tested for rifampicin and isoniazid resistance. We had more isoniazid resistance than rifampicin. But what does that tell us? And this takes me back to one of the objectives of the survey, that even as we're introducing new molecules, the question we need to always keep at the back of our mind is these new molecules that we're introducing, how are they going to affect the resistance pattern? So if today I have a patient that already has primary resistance to isoniazid, it means if I don't do my best to treat them correctly and ensure adherence during the intensive phase, when we move to continuation phase, I'm basically treating this patient with rifampicin only, which exacerbates the risk of drug resistance. So the survey actually just helps to affirm the need to ensure that we do very well when it comes to testing our patients. Sorry. Just to make sure that we are on the same page. Okay. Then the other finding that we had is looking at the patients who we had 241 MTB that were not detected by second-line LPA, but then we also had 2,100 2,217 that were confirmed by second-line LPA, and we went ahead and did the resistance pattern for our second-line molecules. You can see one of the things that we picked was fluoroquinolones, and that takes us back to clinical practice. Where do we use our fluoroquinolones? We're treating UTIs, otitis. What else are we treating? Everything and anything, GI, everything. You just, fluoxacin, moxie, and everything else. So you can imagine the repercussion and the ripple effect of that when it comes to some of these critical molecules that we are using for treatment of critical diseases. So we did have one that was resistant to fluoroquinolones. Now, when we look at the ones that, if you look at the combined resistance between rifampicin, isoniazid, and fluoroquinolone, of course, that tells you we had one potential pre-XDR patient. This is just a summary of the resistance pattern for the three. Now, when we look at our phenotypic testing, we used both MIGIT and LJ cultures. We had culture growth in 2,200 MIGIT cultures, and we had 2,009 culture growth under LJ, and that is the breakdown of the cultures and how they went ahead and grew. Of course, we had a bit of contamination, which was not above the expected levels for any reference lab. Now, when we look at the combined culture results, we had a total of 2,600 samples, of which 2,294 had growth either by MIGIT or LJ. And out of this, we were able to detect MTB in 2,200, which means that our ability to detect TB by culture was very good. And one of the things that I would really at this point laud the TB reference lab, that despite all the challenges they faced, they were able to detect that. But that also gives us confidence in our sample referral system. Why do I say that? The only way a culture can turn positive is if that sample remains viable from when it was collected from the field till when it made it to the reference lab. So what do we do as clinicians? What's the message for each one of us here? When you have a patient, do not be afraid to collect the sample, but please let us work together to make sure it makes it on time, because only then can the culture be useful. Now, when we look at the culture growth or recovery by smear status, amongst those that did not grow, 50% were considered smear negative, while 5% were smear positive, and 28% were scanty, meaning that the number of bacilli or the bacilli load may have been very minimal and could also have been dealing with dead bacilli. Remember, microscopy is not able to differentiate. Now, when you look at your phenotypic DST summary, once we had our cultures, we went ahead and did DST. Of course, we did DST for most of our molecules, your rifampicin, isoniazid, level, and other group A molecules. Of course, we had resistance to across the board, but of note, we still had resistance being noticed if you look for your quinolones and other molecules. What does that tell us? That we need to carefully think around the use of some of these molecules that are shared when it comes to the risk of developing drug-resistant TB. Secondly, it just means that every time we have a patient with suspected TB in front of us, doing drug susceptibility testing becomes a very critical step, because we cannot just assume that all TB is drug sensitive. Okay. Then we also had extra DST based on the LPA, and I'll not belabor this. What we are saying is that we went ahead and did our first line, and that was the outcome. We had a good number of resistant samples for across most of the first-line medicines. Not necessarily the same patient, not necessarily the same person. I think that's the second level of analysis, but just telling us that there occurs amongst our patients primary resistance to some of our first-line molecules. Then when we look across the board, we now are looking at all the other second-line molecules. Again, as I mentioned earlier, we are now seeing resistance based off of the culture results. So again, a summary on our DRTB, DST, LP, and Gene Expert, meaning that these are the number of patients that we were able to identify as having some form of resistance across most of our treatment categories, irrespective of the method that was used to identify drug resistance. I'm trying to keep to my time, so forgive me if I'm moving very fast. The slides will be shared, and then if you have questions, we can always follow up. So I would want to mention one patient, of course, that we are saying that, yes, we had their sample, they were subjected to testing, both the drug sensitivity testing. They had rifampicin resistance, but then when we did the quinolone profile, we had a missing fluoroquinolone profile, but that's because the MTB content for that patient was very low, and therefore whereas we had the expert picking drug resistance, we had no culture growth, and therefore that is the reason why, in case you look at the results and find that one patient, it was not that they were missed, but because of the dynamics around the culture and the bacilli load. Now, when it comes to analysis, as we're evaluating the burden of drug-resistant TB in Kenya, we agreed that those 113 patients, remember, the ones that had no MTB detected by any reason at NTRL, despite the field findings, we decided to drop them. Doesn't mean we will not talk about them, but we did not use them in the final burden estimation. Now, when we look at our TBRR, and this is the main slide, we are looking at what is the risk of, what is the burden of drug-resistant TB, and we are comparing our new patients and our previously treated patients. Of course, there is the crude analysis where we are saying the burden, the incidence is about 0.36 for new and the 3.2 for retreatment. But when you factor in all the other factors, correct for the errors, we are saying Kenya has a 0.37% burden of DRTB among newly diagnosed TB patients, which is way lower than what we had before, and we have 3.35 among our previously treated patients, meaning that as a country we can confirm that the burden of DRTB is not as significant as we thought it would be. But does it mean we go to sleep? No, for two reasons. One, we've changed our treatment regimens. So we're expecting and observing to see how does that affect the drug-resistant pattern. And even as we are trying to introduce second-line molecules as first-line treatment, we are keenly monitoring just to make sure that we are able to factor that in. Now, the other risk factors that we looked at was the HIV, the gender, whether the patient was a previously treated patient or not. We had the BMI, those were the -1, -2. We had the history of TB preventive therapy, smoking, and alcohol. All these factors were considered not to have had a significant impact as direct risk factors by themselves for drug-resistant TB. However, we are not saying they cannot contribute and they cannot exacerbate, but if you isolate them in and of themselves, they are not independent. They did not have statistical significance. Now, when we look at isoniazid resistance, we are saying that for both isoniazid resistance and for patients who are living with HIV as well, which is of interest because we give all of them TPT, we are saying that it is approaching statistically significant levels. What does that mean for us as clinicians? Do we stop giving TPT? No. The question we will ask our patients is, when they get TPT, are they actually adherent? Are they taking it throughout their course of TPT? And the next question we ask ourselves is, will this change as we're introducing shorter TB preventive therapy regimens? Remember, we're introducing the 3HP. Some countries have even moved to 1 month of treatment. And we're asking ourselves, as we are doing the shorter regimens, how is this going to be affected? And that is why for us, using genome sequencing for surveillance becomes very critical, just to monitor how that is going across. Now, this is just a comparison of concordance of the rifampicin results across the various assays that were used. I have a feeling it may not be very clear, so I will quickly jump. I don't know how many minutes I still have. 5. You forgot to look at the time. All right. So when we look at our genotypic versus our phenotypic DST, there was very good concordance across the board, even looking at the resistance patterns. And if we are considering our phenotypic as our gold standard, then from our survey, our sensitivity was 87% and our specificity was 99%, meaning that if we consider you to have TB using our genotypic or phenotypic, then for phenotypic, then it's most likely that you'll be having TB. Now, when we look at the prevalence by type, remember we mentioned that pre-XDR and XDR were not identified because of that one patient that was a potential pre-XDR and we did not have culture growth and therefore we did not consider them. But looking at these resistance patterns, we are saying that for patients who have isoniazid resistance but no RR resistance, the prevalence is actually comparable among new and retreatment patients. What does that mean? There is primary resistance within the population. And that is something that we need to keep at the back of our minds. Remember the cow story, the one I have told you that we're using rifampicin and some of our anti-TB drugs for all sorts of things. So you can imagine if we already have isoniazid, primary isoniazid resistance, and then we abuse our rifampicin, what happens? It means that when patients acquire TB, the risk of actually developing drug-resistant forms is very high. And the other area that we're looking at now is zoonotic TB, because it's in the spirit of One Health is just to make sure that whatever is happening to humans is not being impacted by the kind of organisms or microbes that we're transmitting across the species. Now, what are the programmatic implications for this one? We will be strengthening the communication of data, of course, between the facilities and the reference lab. We are integrating this real-time data flow to make sure that our results get to us on time, so that then this good work we are doing at NTRL to be able to pick DRTB, can it help the clinicians start treatment almost immediately? And then we are also seeking to strengthen screening and rapid diagnostics and specifically molecular testing so that we can be able to detect drug-resistant TB. We'll be updating our diagnostic algorithms, also using our routine data for surveillance. But on the flip side, the implication of a not very high prevalence of DRTB means the resources that are going to be available for Kenya are going to be fewer. So it means we will have to tighten our belts. Despite having new regimens, despite having a risk for new developing or new emerging resistance patterns, we have to tighten our bets. So every opportunity we have to use the little resources effectively. Now, you know, I can't stand here without talking about money. We will have to make sure that we use them. Now, we realize there is a big knowledge gap among our clinicians, something that we will be looking at. Of course, we had some challenges of turnover of staff during the survey. And some of the facilities, of course, took a long time to get their estimated burdens. But then we were able to continue supporting them using technology and virtual opportunities to continue training and sensitizations. Now, with that, I would want to stop there and hope I managed to not stay too long.
Thank you very much, Dr. Kathuri. Another round of applause. I know our sugar levels are low, but allow us to get some reactions from the team. 3 quick ones. Anguva had mentioned there was a question online. Probably we can start there, and then we have Kezia. Okay.
Thanks to all the 3 presenters. My questions go to Dr. Kathuri. So yesterday, and I'm sure you know about this, Dr. Jane Ongango told us that the burden for TB in Nairobi is going up, the prevalence survey that they did. And now today, I think better news that DRTB burden is going down for the country. I'm just trying to compare the 2 findings and asking myself, are there things that maybe we are doing better as far as DRTB management and programming is concerned, that can be applied now to also ensure that the burden for DSTB, or is it just by chance that the DRTB burden seems to be going down? And then you also mentioned that there are factors that we expected maybe to show some association of the resistant pattern they were not significantly associated with the resistance of drug-resistant things like HIV status, previous treatment, things like, I think you mentioned a list of them. My question is, were you able to specifically look at these factors by specific type of resistance? That is among the isoniazid resistant group, among the R, the R and H, to see if maybe the association will differ by resistant pattern. And then the last question is, you mentioned that the prevalence of DR among the new seems to have gone down, but you didn't mention, so for the one among retreatment, is that high or low compared to previous DRS that have been done in the country? Thank you.
Thank you all presenters. I have 2 online questions I've been monitoring. First question goes to Dr. Sam. They are saying that you did not tell us that all the 3 scenarios were asthma or they were not asthma. They were very observant. And then the other online question is coming to Dr. Kadura. It's just a concern that they've been doing culture follow-up for the DRTB clients, but there are some results that since April the results have not been streaming in. So what might be the problem? Because the samples were collected and they were delivered to NTRL. Thank you.
My question is to Dr. Otido. First of all, thank you to all presenters, amazing presentations. As far as health system strengthening is concerned, and leadership and governance specifically, what can we do as far as regulating the availability of oral bronchodilators, because they seem to be easily available to the public? Thank you.
We'll allow the speakers to take the questions.
Thank you. Thank you for the observant participants. I thought probably we were reading in between the lines, but the first patient was a 3-year-old who had just started wheezing after getting a viral infection since joining school. And they have no history of having any allergies. So remember, wheezing is an abnormal symptom, yeah? And it's also an abnormal sign when we get to hear it. So it's a reaction that is already happening inside the lungs. So we put them as suspected, yeah? If they were slightly younger periods, below 2 years, usually it's a straightforward bronchiolitis, but on an older child, it's already a red flag, yeah? So those are a suspected asthma, and on follow-up, they have to be on follow-up. The second one was a preterm. Lots of evidence have been done, like the paper I shared. Ex-preterm already had instrumentation at birth where they received non-invasive ventilation, has always been a recurrent wheezing baby. Even in that young age, that child is already on the asthma spectrum and should be treated with inhaled corticosteroids and on follow-up again. Remember, they're always evolving. The lungs are still maturing. They get better with time if they have any other risk factors. The third one was more infective. Yeah, so that child who was with yellow sputum, with a chronic cough, we treat them as protracted bacterial bronchitis, and they just need high-dose amoxicillin for approximately 2 weeks. For health system strengthening in terms of use of oral bronchodilators, yes, it's not the current trend. I would like to push it to government. I didn't know I was sitting with government, but we shouldn't be having them. So the poison board should actually look into it.
they should be actually be prescription medications. They should not be over the counter. So if you ask me, the Poisons Board should actually just possibly remove them, unless maybe the adult physicians have a role for them. For children, we don't really advocate.
Maybe I will chime in still on the part of the regulation for the bronchodilators. I think probably the program working with the Pharmacy and Poisons Board, I think that will be the best way to go, and try to replicate like what is happening with the antibiotic stewardship. Look at, can we be able to do the same thing with the use of some of these products? At the same time, also there's a lot of public education that need to happen, because if the demand is coming from the patients themselves, then that means even trying to address that issue will take a bit of time. But I think with a lot of advocacy, a lot of public awareness, then I think that perhaps we'll be able to help with the appropriate or rational use of drugs.
All right. Okay. So, all right. So it's called technology. So I'll start by responding to Rhoda. And I like your question about TB prevalence for drug sensitive versus DRTB, and whether there is anything we're doing better for DRTB. Actually, the fact that the DRTB burden is going down or is less tells you that despite a very high burden of or transmission for drug-sensitive TB, the program is doing a great job to make sure that those patients do not contribute to a larger pool of drug resistance. So if anything, it's the other way around. It's a sign of success. So something that we'd want to continue upholding. Now, when it comes to the risk factors, did we review by type of resistance pattern? Of course, the numbers are small, but nothing stops us from doing a secondary analysis, because what we presented was the primary analysis, the preliminary analysis. We just finished our analytics, the first phase, but a lot of analysis is going to go on beyond this first primary analysis. And just to correct, it does not mean those factors are no longer risk factors, but from the prevalence survey, they were not directly associated with a higher risk of having drug-resistant TB. It doesn't mean that they still don't remain risk factors. They are risk factors, but when we looked at the numbers and the statistics, there was no statistical significance. But I always say we don't treat the data, we treat the patients. Then the other thing that you had asked is about whether it had reduced across the board for previously treated and new, and the answer is yes. We saw a reduction in both categories. One of the things that we will be doing is, as we're sharing the slides, we'll incorporate what the previous rates were, so that then we can be able to see how that reduction has gone on. It doesn't mean that we're out of the woods yet. Just means that financially we are one of those countries where DRTB is not considered a big problem. Now, I do hear the question on delays of culture results, and yes, as you saw in one of my recommendations, some of the action points and the lessons we learned during DRS is that we needed to improve our relay of data from the TB reference lab to our facilities. That system has actually just been worked on. We are now trying to deploy it so that ultimately these results can arrive real time to our clinicians. What are some of the hindrances or the challenges that are affecting that? You find most of facilities give us the clinician's individual email. So if that clinician is not in the facility, they're off duty, or for some reason they've moved, it takes a very long time for anybody to discover that they went to their personal email. What are we encouraging? Facilities to have facility-specific email addresses that can be accessed by more than one clinician to allow people to be able to have access, of course, with the requisite guidelines and guidance around patient confidentiality. The other thing that we're also doing is, as we are integrating and improving our TB surveillance system, we want to see how those results can also be relayed back using that system. Now, to chime into the bronchodilator conversation, and I heard they always say everything that doesn't work, they throw it to government. But anyway, that is what the government is meant to protect the people. Of course, there are conversations around regulating the use of oral bronchodilators. but a rate limiting step is the stigma around the use of inhalers. So the reason people tend to turn to the oral tablets, there is a misconception among the population that when you use an inhaler, you'll be addicted to it, or you are very sick, or you're very badly off. Unfortunately, one of the areas that has received the least support for all programmatic areas is communications and awareness creation. What we are doing is not tapping, we have realized the power of the social media. One of the things I learned the other day is if, for example, a car gets lost somewhere in Western Kenya, by the time it reaches Nairobi, the cops are waiting for it because people have been tracking that car from wherever till where it has reached. Now, that is the power of social media. And for us, leveraging social media is one of the strategies we are using moving forward, because we have realized we cannot continue sitting and saying we don't have investments for communication. And since we know a lot of people are accessing some of these platforms, then we want to be able to push as much of our communication there as possible. The other thing that we are trying to leverage on is to leverage on the existing fora where these young people, I don't want to call them Gen Zs, but they are, where they're sitting, engaging, and collaborating, so that then we leverage on their technical capabilities to help drum up awareness, even among the caregivers, so that then when children or patients are sick, the oral tablets do not become their recourse. But then it's work in progress and something that we are closely trying to work on amidst the limited resources.
Thank you very much. I'd invite our presenters to come here so that we can appreciate them together. So let's give them a standing ovation so that we are able to stretch as we stand. And we give them 321 claps. Let us start. 3, 2, 1. Thank you. Thank you very much, our presenters. We appreciate you. Okay. So we are breaking for lunch. Before we break for lunch, kindly, if you hear your name, you're supposed to pass by the registration desk. Gladys Cheruto, Brian Kafwa, Namai Peter, Phoebe Oyeko, Mary Karioki, Valentine Oro, Lynette Gwengi, Emmanuel Busera, Cecilia Muiva, Sharon Olwande, John Washira, Tommy Frank, Caroline M. Mukaria, Radak Sami, George Kebaso, Christopher Antika, Josephat Oduor, Joseph Mukoko, Jane Mathai, Elizabeth Karaka, Yuka Beth Baraka, and Valerie Arua. So it's exactly 3:10, and we still have 2 sessions left. Could I request we have 30 minutes? 30 minutes for lunch, so that we are settled. Okay, so please let's be back by then.
Biostatistics and research methodology, health program planning, and scientific writing. She focuses on using science to explain and find solutions to real-world public health problems across continents. Our third speaker is our Dr. Maribeth Maritim. She is a consultant physician and infectious disease in tropical and travel medicine specialist who is currently working as a senior lecturer in the Department of Clinical Medicine and Therapeutics in the University of Nairobi, Faculty of Health Sciences. She has a 16 years clinical experience in the case management of tropical and infectious disease at the KNH and Bagathi County Hospital, and has trained, supervised, and mentored several postgraduate and undergraduate students in the area of expertise. She is undertaking research and healthcare capacity building on advanced HIV disease and opportunistic infection. She is currently serving in several national advisory and technical committees within the Ministry of Health in Kenya, including HIV Guideline Review Committee and co-chairing the NASCOP Advanced HIV Disease Working Group. She is a member of several professional organizations, including KMA, Kenya Association of Physicians, HIV Clinicians Society of Kenya, Infectious Disease Society of Kenya, among others. Let us welcome them with a proud of clapping. Thank you, welcome. Let's start with you. Biostatistics and research methodology, health program planning, and scientific writing. She focuses on using science to explain and find solutions to real-world public health problems across continents. Our third speaker is Prasad Paraj. I'm only going to give you 15 minutes because we are short of time. Please, thank you and welcome.
Hello. Okay. Good afternoon, everyone. I hope I don't make it too boring for you guys. Quick introduction about myself. My name is Prashant. So I come from this organization called Vadvani AI Global. So we are based out of India. So we are just going global very recently. So we want to take the solutions from India, like the open source solution that we made in India, and take it to the global south for implementation in healthcare, education, and agriculture. So we primarily work to build AI solutions in the field of agriculture, healthcare, and education. We work very closely with the ministries, respective governments, where we develop and deploy these solutions alongside with the government, not as a separate entity. And we make sure that the solutions that we build are aligned towards the national guidelines, let it be in public health or in agriculture or in education implementation. As in today's conference, I want to share you 3 different use cases that we developed and implemented in India. Starting with a screening solution called Cough Against TB, which is basically a screening tool to identify presumptive tuberculosis. So this basically uses cough sounds and reported symptoms of subjects to identify if that particular person has presumptive TB or not. So this was developed on a data set which we collected across India. So we had around 100,000 data points and the ground truth, I mean chest x-ray or CBNet or sputum microscopy results for those subjects across India, out of which 25,000 data set was used to develop the model. The model has a sensitivity of 90% and a specificity of around 70%. So it just requires a simple mobile phone where the healthcare staff visits a particular subject and then screens that particular person. And it is also used in health facilities where the health staff used to screen the person who's visiting the center in order to take the screening of the respective persons. And we are also planning to get it as a self-screening tool so that it is integrated into patient-facing applications where people sitting at home itself can self-screen themselves for TB, and the screened people are then in turn referred to confirmatory diagnostic testing. When we implemented this solution, we faced a lot of challenges in terms of internet connectivity. So what we have done is that we have created the model in such a manner it works in offline mode itself. You can do maximum 200 to 300 screenings whenever the field staff goes to a remote, hilly or tribal areas where they do the screening. And once they get to an area where there is internet, the data records gets auto-synced to the database, so they don't need to worry about it. So it is very important to design at scale when you have inclusive designs for healthcare solutions. And another thing with respect to this solution is that if we have ground truth for other different respiratory diseases, we can develop this particular AI-based model for asthma or other respiratory diseases. So currently it is there for TB. And moving to the next solution, which is in the diagnostic phase, which is called line probe assay. Line probe assay is a solution which is used to detect resistance of first line and second line TB drugs. So the problem initially faced by the labs is that labs spend a lot of time in terms of interpreting the results and then entering the results back to the national portal, the diagnostic module portal. Similar to TB in India, we have this platform called Nikshay where both the microbiologists and lab technicians had to enter the results. So the turnaround time for line probe assay tests was around 25 days actually. The problem is that it takes a lot of time of microbiologists, and also patients are waiting for the results. Drug sensitive patients could be DRTB patient, drug resistant patients, so they need to be put into right medical regimen. And second problem is that some of them patients were getting wrongly interpreted actually. So they might end up getting wrong medication regimens. So that was also one of the reasons why we wanted to develop this solution. So this solution is a very simple solution. Once the strips are processed after microbiological process, these strips are struck in this sheet, and they just have to take a photo of the sheet or scan the sheet which is connected to the system, and the AI reads the inference and shows the results. And one thing to remember over here is that there is a myth around AI that AI is going to replace clinicians and people in healthcare or in whichever domain, which is not the case actually. AI is just going to act as an aid or to help them make better decisions. So over here also, the microbiologist has the final right to decide if the result shown by the AI interpretation is right or wrong. They can change the result from sensitive to resistant or resistant to sensitive, so that the final decision taken by the microbiologist is being submitted to the final portal. Previously, they used to take around 2 to 2.5 hours time in terms of doing the interpretation and data entry to the diagnostic portal. Now the entire process batch is around 20 to 25 minutes, so we are able to save that much time and also bring down the turnaround time for labs to update the patient results back to the central server actually. So that is about this solution. So this solution is a computer vision based process automation solution which helps in the healthcare staff in saving administrative time actually. So AI plays a very important role in digitization of these things actually. So if there are any forms which is being manually entered by healthcare staff, and the healthcare staffs are also asked to report it to the national platform, people can think about building OCR, object characterization recognition tools to fasten the process of data updation into the respective portal. So this particular solution acts as an example over there. And the final solution which I want to cover is about prediction of adverse TB outcome. So over here, adverse TB outcome refers to loss to follow-up and mortality. Although loss to follow-up seems to be only 5% and mortality is around 4%, it is very important to address loss to follow-up because these are the people who end up being drug-resistant TB cases or carrier of TB in the community. So they are not touched because it could be due to multiple reasons. The patient might have stigma towards TB, or they would not have availability to TB drugs actually, and they would have taken medication for some time and then they would have stopped it due to adverse drug reactions, etc. So these patients would end up being drug-resistant TB, which is even more difficult to treat compared to drug-sensitive TB. So it is very important to address both these adverse outcomes at a very early stage of catching a TB patient. So what we did is that based on the historical data set that we had, we developed just a predictive model which flags a TB patient has high risk or low risk for adverse outcome at the time of treatment initiation itself, so that healthcare staffs give intensified interventions for high-risk patients and give normal interventions for low-risk patients. So the reason behind is that like even the healthcare staffs, the field staffs are overburdened with the kind of TB cases that they need to cater to. So these interventions needs to be designed or planned in such a manner that we put their resource to at its best actually. So what kind of interventions we provided is that like instead of following up a TB patient once a month, for high-risk patients we designed an intervention, they will be followed up once a week. And in case of that particular patient is a comorbidity patients, like if they have HIV, we make sure that they are initiated on their ART status and their CD4 count is updated once in 4 weeks. So these type of interventions were set and they were accurately monitored. And we deployed this across 16 different states in India. And we did a comparative study where we saw a 27% relative decline in adverse outcome compared to the places where it was implemented and where it was not implemented. And this particular solution is now being adapted inside the national platform itself, so that all the TB patients who will be notified inside the NICSHADE National TB platform in India will be categorized for it. And the interventions across India is also being defined by the Central TB Division alongside with WHO, so that they can give better differentiated care for high-risk patients who are being flagged by this AI model. And to again say that like the most important thing when it comes to digital interventions or AI is that we need to design alongside with the existing guidelines actually. So all the three solutions which I presented right now, they don't stand as an individual application or a web portal or a web link, nothing of that sort. All these were designed, and these designed solutions are integrated into India's national TB platform. So this is very important. We should not have too much dose for the healthcare staff to use multiple different applications or digital tools for them to use actually. You need to design as simple as possible to help address the problems which they face in their respective fields. And we are also looking forward to work with the National TB Leprosy Program over here, looking to replicate the same type of solutions that we had in India over here. Really looking forward for it. Thank you.
Let's appreciate him again. Thank you, sir. The next speaker is an online speaker called Dr. Sambul Hashmin, and GPH manager EPICON. Let's put there. It's an online. Are we ready to connect? Because I think he's in online. Thank you for that wonderful presentation and the importance of doing an AI, and that we are getting more studies and more positive, and they are profitable. I hope we can embrace that even to our country, so long as we have a lot of support. Thank you. Are we ready for the next one?
Hello, good afternoon.
Hello.
Can you hear me?
Can you hear? Thank you.
Can you hear me well?
We can see your presentation.
I'm having some network issues now. I think it was earlier quite well, but now the audio was a bit choppy. So I'm not sure if you can hear me well.
Hello, we can hear your voice. We are ready to hear.
Okay.
You can
Okay,
continue.
perfect. I will start.
Okay, thank
Good
you.
afternoon, everyone. My name is Sumbul Hashmi. I work as a global public health manager with EPCON, and my presentation is focused on insights from EPCON's TB modeling work. Can you go to the next slide, please? Yep, so I will briefly cover introduction to EPCON and mainly focus on what have we learned with our TB modeling approach across different countries. So briefly touching upon data quality, spatial mapping, digital tool linkages, and change management. Next slide, please. So about EPCON, EPCON is a health impact company originating in South Africa, and we typically quantify disease risk at population level and more specifically at very granular village or community level. And the outputs we generate, or the TB modeling outputs we generate, they are used by local stakeholders and implementing partners for overall planning of their disease control programs and planning of local targeted community-based interventions. Next slide, please. So our approach is driven by local contextual information and the relevant proxies of contextual data. So we try to combine many different risk factors which are known to be associated with a particular disease in question, starting from socio-demographic information on age, gender, literacy, and other indicators of nutritional indicators, indicators of access to healthcare, like travel time to healthcare facility, access to road networks, access to clean water, sanitation, basic services. So anything and everything which describes the context of a geographical region and is relevant for the disease we are modeling. And it can depend on whether if it is TB, HIV, we of course change the risk factors that are included. Next slide, please. So this schema here represents very simply how everything comes together and how we are able to form a closed loop. So putting it very simply, we combine all the socio-demographic information and all the programmatic data, notification data, combine it together. We train a Bayesian inference model. We generate TB predictive outputs in the sense where are the high and the low risk regions, and the outputs are communicated on a digital dashboard and a geo portal or a mapping portal. These outputs are utilized by the local implementing partners to plan their routine interventions and M&E activities. The data which is generated by their intervention is coming back to the system and feeding back into our data set. So the data is again updated, the model is updated, and we continuously train the whole system and the loop to have an incrementally learning platform which is capable of running live. Next slide, please. And apart from TB, we also work in other infectious diseases like HIV, malaria, also support some research programs on Lassa fever, Ebola, and general health inequity across countries. Next slide, please. We have been working with Nigeria, Philippines, South Africa, Pakistan for many years, more recently for Uganda, also recently started collaborating with Kenya, did some small projects in Central African Republic, India, and many other countries. So next slide, please. And in this part of the presentation, I want to share what we have majorly learned from our experience of TB modeling across these countries. So the first thing is related to data quality. And in a lot of these countries, we find that the TB programmatic data or the notification data is often aggregated to large administrative units like provinces or LGAs or wards, which probably has its own advantages and it is relevant for national level planning, but it is less less intuitive, and it is less useful for someone who's trying to plan local community-based interventions. And what I'm trying to show in these images here is an example from the Philippines. So the first of all, the country is divided into multiple islands, regions. We have the provinces. The first image that you see, the municipalities and the barangays. The next image that you see at the bottom. Barangays are really very small and granular admin units in the Philippines. And the best part we found, which was very interesting in the Philippines, was that every notified client of TB is really mapped to this barangay level. So they specifically know where exactly a client is coming from and what kind of context the person is coming from. So although this kind of disaggregated data was very helpful for us performing our TB modeling exercise, and we don't find this in a lot of other countries, of course, but it is something which worked really well and is really very helpful if someone is trying to do TB modeling and trying to find subtle differences between geographical regions, between high and low burden areas. Next slide, please. Another important aspect that we need when we do this TB predictive modeling is we try to do these spatial mapping, which is highly dependent on geolocated data. And this geolocated information is often not part of a lot of TB programs, routine programmatic data collection, and which doesn't really, it's a challenge that we always face in a lot of countries. But we have now tried to find ways using Google APIs that we can automate the process of spatial mapping all the programmatic data. And then we are able to use that programmatic data, which is already mapped. And then we estimate the risk, communicate the priority sites or the hotspots with the local community intervention implementing partners. And then they are able to use it for their routine programs. One of the examples that I've shown here is from an HIV intervention that we were supporting in Nigeria, where we were trying to map risk of HIV across the country, and then they had to focus on adolescent girls and young women. So there we were really trying to do this spatial mapping aspect and trying to mobilize the community health workers on the ground utilizing this approach. In the next slide, please. Another example from Nigeria again, where we were supporting the TB Lung 3 program. And this was a program focused on finding undiagnosed TB in the community. And we found that when they were using the model recommended hotspot locations for case finding interventions, the yield were 1.75 times higher as compared to when they were not using the model recommendations. So this is a very good example of how the model performs on the ground and how it helps to improve the impact of interventions. Next slide, please. And the next aspect that we want to talk about is real-time updates. So like I mentioned earlier, we try to complete a closed loop which runs in real time. And this has worked really well in terms of we are continuously able to pull data from national platforms, generate automatic recommendations for the teams on the ground. They receive these recommendations. They are able to mobilize their teams on the ground, plan their interventions, feed the data back into the system, and we are continuously learning from what is happening on the ground in their interventions and across and against a backdrop of contextual conditions. And next slide, please. And the whole thing has supported us really well in Pakistan. It's an example where we were supporting Mercy Corps to drive their mobile chest X-ray screening vans. There were some 40 vans that they were driving across the country to screen clients to find undiagnosed TB in the community. And they found that when the vans were being driven following the model recommendations, their yield was almost 100% higher as compared to before, when they were not using model recommendations and following conventional approaches to follow only the notification data. Next slide, please. And the last aspect of my presentation is related to change management, which is we try to collaborate very closely with the local implementing partners and the local stakeholders to make sure that there is smooth integration with their systems, that their concerns and questions related to movement of data, transfer of data, and data sharing, all of that are taken care of, and that we are able to build that confidence with the teams on the ground. Bringing a new technology is not easy to implement in a new region, and it comes with its own set of challenges. But we have been trying to work very closely with the local implementing partners to make sure that they understand where their data is going, how is it going to help them, and how it is going to help them improve their outcomes. So I think it's one of the very important aspects of bringing in a new technology on the ground, and it is an important aspect of impact generation. Next slide, please. And then just briefly summarizing the added value we bring together with this TB modeling exercise across the countries is that we support optimizing of case finding interventions and supporting the micro planning on the ground at really the implementation partner level, and also at program managerial level, and also supporting the routine M&E processes, interventions, and trying to really making sense of data that is being generated in the country, and learning from the local contextual information at the highest resolution possible, and supporting the overall implementation of specific targeted interventions that we are able to bring about the desired change or affect the impact positively. Next slide, please. I think that was the end. Yeah, thank you so much for your patience. If you have any questions, I'm available.
Thank you, Doctor. Thank you for that insight for the AI and what you are doing with EPCON. Our questions will come later. Let's hear the last speaker for this session, Dr. Maritim.
Good afternoon, everybody. Can you hear? I feel like the mic is not working. Oh, this one is working now. I think it was off. So I'm just waiting for my slides to come on. And I want to take this opportunity to thank the symposium organizers for giving me an opportunity to speak. So I'll be speaking about advanced HIV disease and implications of TB and lung health services. And I was actually attending the symposium from yesterday, but virtually. So I'm able to create the linkages with what I heard yesterday and even this morning. So I have no conflicts of interest, and I'm co-chair of the Advanced HIV Disease Subcommittee within NASCOP, and some of the slides I'll be presenting is really from the effort of the entire team. So we'll go through this outline. We'll just have a quick introduction to discuss what is advanced HIV disease. Then we'll look at AHDK in Kenya, where we are as of now, and then focus on implications for TB and lung health services. And I think the key essence or the key word is integration of all these services together, and we've already incorporated that even as we designed the advanced HIV disease program. So when you look at advanced HIV disease, this is actually a new name for an old disease. This is really, advanced HIV disease is a name that is given to patients who are having AIDS. And we know that in this country, we've had antiretroviral therapy for more than 20 years now. So along the way, we actually had advanced HIV disease sort of neglected because we focused on the UN AIDS global targets of 95, 95, 95. And when you look at those missed 5%, those are the ones that largely contribute to advanced HIV disease. So this is a publication in the New England Journal of Medicine by Nathan Ford and colleagues looking at why advanced HIV disease should be given much more emphasis now. And when we look at our even HIV treatment guidelines, when we focused on test and start, and also on focusing on really testing and putting people on ART, and then around that time, there was the emphasis on using CD4 as a tool for monitoring patients, and this is, I think, where we lost the sight on these patients who end up developing advanced HIV disease. So this is actually the definition of advanced HIV disease. We have two definitions, one focusing on children less than 5 years, and another definition for children older than 5 years, adolescents, and adults. So for children who are less than 5 years, if they have HIV and they're not yet stable on ART, they will be considered as having advanced HIV disease. And this is because they have higher rates of mortality. So there needs to be a lot of emphasis in terms of identifying these children and making sure they're on ART. For children older than 5 years, adolescents and adults, we define AHD using two categories, using a CD4 cell count of less than 200 cells per millimeter cubed, or using WHO stage 3 or stage 4 illnesses. So WHO staging is still relevant in this day and age. Who are the individuals in whom we look for advanced HIV disease? We look in three categories of clients or people living with HIV. We look for advanced HIV disease in those presenting newly to care at the point of initial presentation. We also look for AHD in those returning to care after a period of treatment interruption. And these are the clients we are likely to meet in the inpatient settings. A lot of clients who come to our facilities would come, and we as healthcare workers, we get the feeling that they are newly presenting to care. But after a few days in the ward, we actually find out that they had been diagnosed before. They had even been on some form of treatment, they interrupted treatment, and now they're coming because of some serious opportunistic infection. The third category of people in whom we look for advanced HIV disease are clients on ART who have experienced treatment failure. And this is defined by a viral load more than 1,000 copies. So the first category is easy. If they come to the outpatient, we are likely to pick them. The second category are people we follow in our comprehensive care clinics, in whom we are actually monitoring their viral load, and we can see that their viral loads are higher than 1,000 for a defined period of time. The second category is the one that is very hard to identify, because when patients interrupt their treatment, currently we are not able to see where they are in care. I like the presentation by my colleague. We should be able to predict where these clients are, because if we predict, we can intervene and prevent a poor outcome. Poor outcome means progression to advanced HIV disease or even mortality. So we need to be looking for these patients who've interrupted the treatment, and I think that's where we can leverage AI to be able to help us see in the healthcare system where these clients. So I put this slide, it's too busy, but it's focusing, just reminding us on what are the conditions that are in WHO stage 3 and stage 4, but more relevant for this audience, when you look at pulmonary TB, it appears in WHO stage 3. When you look at extrapulmonary TB, it would appear in WHO stage 4. So TB is an important disease. When you look at other respiratory OIs, you're looking at pneumonia, recurrent pneumonias, recurrent severe bacterial pneumonia, more than 2 episodes within a year, is a WHO stage 4 illness. That would appear within the respiratory system, so it's still relevant for this audience. When you look at pneumocystis jirovecii, again, it would appear as a stage 4 illness. So a lot of respiratory conditions are presenting, and they are actually AHDs. And this is more important, particularly at the National Hospital Kenyatta, where we actually have a pulmonology ward. So in that ward, actually, it's hosting a lot of our AHD patients, because when they're sick, they're either coming with TB, they're coming with PCP, they're coming even with pulmonary Kaposi sarcoma. So that's, if you're looking at a low-hanging fruit where to identify AHD patients, that's where you'd find them in the respiratory ward. Again, for children, when you're looking at children, most children, when they have HIV, they're likely to present with serious OIs, including even TB. Some would present with malnutrition. Some would present with recurrent bacterial pneumonia, despite even receiving vaccination. So again, looking at AHD, it's really an important thing for the people in the audience who are listening in, including the ones who are listening virtually. Why we need to identify advanced HIV disease is that majority of deaths of hospitalized adults with AHD are caused by opportunistic infections. And when you look at this pie chart, TB is a leading cause of mortality, contributing to more than 35% of AHD-related deaths, followed closely by cryptococcal meningitis. And we are focusing a lot of our efforts in the AHD subcommittee in terms of mitigating the deaths due to cryptococcal meningitis and toxo. PCP is important, and severe bacterial infections, which can be invasive bacterial infections due to strep pneumo, which can be meningitis as well as even pneumonia. So when we look at TB and PCP, more than 50% of the mortality is actually things that we can be able to prevent and we can be able to treat. But we need to identify these patients who have advanced HIV disease. And I shall revisit this slide when you're looking at the focus. So within the subcommittee and within NASCOP, we've created this package of care. And this package of care has actually been in all the guidelines from as far back as 2014. Even when the time when we de-emphasized CD4 testing, again, we had a standard package of care for newly initiated patients presenting with newly diagnosed HIV. So this is a package of care for clients with advanced HIV disease. The entry point being CD4 testing. When you look at WHO staging, it's likely to miss a large proportion of patients. So CD4 is a preferred way of identifying advanced HIV disease. And I was glad in the IAS meeting in Rwanda this year, WHO pronounced itself back on emphasizing the role of CD4 testing. And we have methods that you can be able to identify or measure CD4 even outside of the standard lab-based methods, and we'll mention the new method that we've introduced in country for rollout. And then once the other part of the package is preventive therapy, including cotrimoxazole prophylaxis. So good old Septrin is able to prevent a number of opportunistic infections, including pneumocystis, pneumonia, toxoplasma, even bacterial, strep pneumonia, even TB. It has a role in preventing TB in patients who are living with HIV. Then the major component, again, is TB screening and interventions following the cascade. So you screen for TB. If you find TB, you treat TB. And I know you've talked about TB a lot yesterday. And we're looking at screening for TB based on different diagnostic methods. You can use the expert. You have to send an appropriate sample for the focus where you suspect the TB could be. So that if it's meningeal TB, you're sending CSF sample. So you have to send an appropriate sample. TB urinary lamp is an important tool in people living with HIV, particularly because it's able to pick up TB that it may not tell you exactly where the focus is, but you're able to make a decision and intervene when you have a positive TB lamp in that patient. And then for people who screen where you're able to exclude TB, then you can put them on TB preventive therapy. We also screen for cryptococcal meningitis and cryptococcal disease, basically using blood Crag test and give preemptive fluconazole therapy. If we find cryptococcal meningitis, then we give treatment for cryptococcal meningitis, including even secondary prophylaxis. And then we have to initiate rapid ART. And this is important because you are able to change the course of that patient, but with a caveat. For certain infections like meningeal disease, for both TB as well as cryptococcal disease, we want to delay the ART initiation. But for most of the other OIs, actually we encourage initiation of or reinitiation of the ART, particularly for our clients who had interrupted treatment. Then adherence support is very, very important. So just to summarize, we need to identify advanced HIV disease, and that's where your CD4 count comes into play. We screen for the various opportunistic infections, and we offer preventive therapy. We diagnose and treat OIs if they are present, and then we initiate or reinitiate ART if they had been interrupted. So this is the algorithm for children. We call it the STOP AIDS, where you're screening for the leading OIs. And actually, for the pie chart that I showed for adult patients, when you look at children, cryptococcal meningitis is less significant. So we have TB contributing there, severe bacterial infections, contribution of pneumocystis, and then malnutrition carries a bigger chunk in the pediatric population. So less contribution by cryptococcal meningitis. So you're focusing on screening, and you still screen for TB and cryptococcal meningitis, but this is in children who are older than 10 years, but you have to screen for things like malnutrition. And I was glad to hear about yesterday's presentation on using, considering preventing TB, using food to prevent TB infection. So I think it's a low-hanging fruit because we see the same, even in our adults who have TB, they're really malnourished, and food in that case is actually therapeutic. So we just need to see how to scale up that intervention and be able to reap the benefits. And then we treat the OIs again, you optimize and then prevent. So that's the acronym, STOP AIDS. So where are we with AHD in Kenya? And these are slides that we started having this discussion almost 3 years ago. And I'll be showing you where we've reached so far. So at that time, the challenges we were grappling with was reliability and access to CD4 testing and OI diagnosis. And we needed to be able to access a lot of point-of-care diagnostic tests for both TB and cryptococcal disease, which are the leading causes of mortality, as we had seen earlier. We also needed to map the screening, prophylaxis, and treatment, and be able to design a hub and spoke model, and be able to really define the levels of care for hub and spoke. And this is slightly different from the primary healthcare hub and spoke model, and I'll be showing you what have we designated as the hubs for advanced HIV disease care. We needed to establish AHD treatment centers of excellence, and these are the hubs. And this was mainly to target critically ill and unwell patients, particularly patients who have serious OIs like tuberculous meningitis, cryptococcal meningitis, because often these require to be admitted. A lot of our HIV care has been largely ambulatory, but for the advanced HIV disease, they're likely to present in the inpatient setting. So we needed a safety net to be able to take care of these patients who are likely to die. And we needed the support of physicians, pediatricians, clinicians, basically to take care of these complex, critically unwell patients through training and capacity building initiatives. Because when you look at, this is where we still struggle. Often our ambulatory care is provided by our colleagues, the clinical officers, who largely run the comprehensive care clinics. When patients fall sick and they go to the inpatient, they land in the hands of consultants, pediatricians, physicians. Then in the ward round, you'll find the physician saying, call CCC. This is a patient who's gasping, very sick, and we're asking for the CCC person to come and see this patient. Often you find that patients who have HIV, the consultant will just say, call CCC, like there's not so much input in that patient. So this is one thing we are trying to work around, and I had an opportunity to present at the physicians conference, and I know there was also a team that presented in the pediatric conference earlier on in the year in April. And this is an ongoing discussion because we really want to build capacity in our specialists to be able to own that space and to be able to care for these patients, because these patients are the ones who are likely to die. So that when you're making the decision to call CCC, you're asking the CCC to bring you the extra dolutegravir because you've already known that there's a drug-drug interaction and you just want to top up the dolutegravir. So you're asking for a specific thing, but you don't want to let the clinician come and struggle with that complicated patient in the ward. And I think we are already reaping some fruits from those initiatives. We needed also to secure reliable access to OI commodities, including newer and safer products and even regimens. We needed to develop clinical protocols, guidelines, and SOPs and job aids to be used in the inpatient and outpatient settings, and then to train and empower multidisciplinary teams of healthcare workers on AHD care. And this is part of what I'm doing now, training and sensitizing, creating awareness. But more importantly, also linking outpatient and inpatient so that this patient has a continuum of care, and particularly the people who work in the inpatient setting have to stand in that space, because already we have very good care in the outpatient, and in the inpatient, we have to still say, call CCC. That's what we're trying to change. So that linkage is more important, particularly now with the funding decline, where we know that we have to integrate. We have no choice but to integrate our services. So I think it's a blessing in disguise, and we have to own that space. And then we needed to develop and track AHD indicators, particularly monitoring and evaluation, including mortalities. And I was glad to hear a discussion around TB mortalities, and that discussion again has to come even in HIV, because often you find that even in a lot of death certificates, you'll not find HIV listed it will be like a patient died of crypto. Then you have to infer that they had crypto in the setting of HIV. So again, how do we, are we able to track the mortalities? Because if you're able to track the mortalities and actually show that they're higher mortalities, it has an impact on programming. So this is just the hub and spoke model. I don't want to spend too much time. But basically, the hub is a center of excellence. Now we've designated the county referral hospitals as the hubs, and then the spokes are the rest of the facilities that will be able to bring the clients there. So for the hub, they have to have the capacity to be able to diagnose those serious OIs and to be able to care for those patients. And once the patient is stable, they can be sent back to the spoke to receive continuing care, because some of the treatments are 6 months for cryptococcal. We treat for more than a year. So you have to be able to have that linkage between hub and spoke. And the reason why we designated the hubs to be the county referral hospital, this is where you're likely to have the highest level of expertise. You're likely to have the laboratory diagnostic tests that you require, and these are listed in this slide, basically highlighting what are the diagnostic requirements, what are the treatment and prophylactic requirements on this column, and then even adherence support. So this loop has to be completed. And we realize this, particularly for cryptococcal meningitis. We use cryptococcal meningitis to be the disease that was helping us to designate the hubs. Management of cryptococcal meningitis requires that you do therapeutic lumbar punctures. A lot of lower level facilities may not be having that expertise to do a lot of lumbar punctures. So we wanted the capability and the skill set to be able to support this care for these seriously ill patients. So this is now where we have reached so far. And basically for advanced HIV, so I'm going through each of the problem areas I'd already talked about, and we can see whatever I'll be speaking to, we can leverage, because already some of the TB and lung health services already are being rolled out nationally, some at primary healthcare level, but some even at level 4 and level 5 facilities. Because towards the end, when I'm wrapping up, I'm just having 1 or 2 slides, thinking through what are the implications for advanced HIV disease together with the TB and lung health. So in terms of testing sites, we needed to identify advanced HIV disease. You need the CD4 testing. So what we realized is that we had machines or conventional CD4 testing machines, but some of them were even phased out. And particularly when there was a de-emphasis of CD4 testing, a lot of manufacturers actually moved out of that space and moved on to other things. And they wrote to WHO and told them that they're pulling out their equipment. And by the time, I think there was a lot of advocacy from the communities of people living with HIV/AIDS to try and reverse that, it was already too late. So we reached a point where there was a crisis. There were very few CD4 conventional machines in the market, even for implementing partners that were willing to buy. There was none in the market, and even for the manufacturers, they said they're stopping to manufacture the CD4 kits. So that, and particularly what contributed to this is that at that time, UNITAID and WHO were focusing on point of care CD4 testing, and we currently have now a number available, and that really made the people who make the conventional CD4 testing equipment not to invest too much in this. But I'm glad to report that for our country now, we'll be having a hybrid system where we have the conventional machines that are still available and the kits are available together with the point of care, what you're calling the lateral flow CD4 assays. One of them is VisiTect, and that's the one that was piloted and will be implemented actually. We're just waiting for training of the lab personnel so that it can be rolled out. And it will be available, particularly in a lot of the spokes, because it's a point of care test where facilities have fewer patients, they can actually adopt the VisiTect. And then the conventional machines, which have a higher capacity, can then be left at the hubs. So there's a planned rollout from September, and we are developing a CD4 dashboard to be able to help us monitor and even track and enable us to even quantify and forecast the commodities. So this is just a map showing the hubs and centers of excellence. And just to summarize, all the county referral hospitals are designated as centers of excellence. And so far, we have ongoing training to build capacity in those centers of excellence. And a lot of facilities or counties in the Nyanza and Western region already have their centers of excellence activated. Nairobi already, Coast General, and I think in the next slide, this is just illustrating. We had 5 model centers of excellence, and they've already all since been activated. So we have identified a total of 170 hubs or centers of excellence. We've developed a 3-day training, and we've trained close to 200, 120 county TOTs, and close to now 1,500 healthcare workers have been trained on that curriculum. And we've activated 24 county referral hospitals. So it's just about 50% of the country, with a focus mainly on the high burden counties. We have 5 model county centers of excellence: Naivasha, Mbagathi, Mombasa, Kericho, and GOTRH, and these are already activated and receiving patients. We have job aids that have been finalized, and we supported 47 counties to have county-led technical assistance, and there's actually one that's planned for the week of 7th to 10th of October. We've also activated regional technical working groups, and they're already discussing AHD cases, and we have an implementation plan and OI manual that are being finalized and will be ready for rollout. So these are just some photos when we visited some of the counties for TA. This was early in the year, in February, when we visited a number of counties just to see. And actually what we found out from that visit, a lot of healthcare workers had the same challenges that we had outlined, where patients would have AHD in the wards, their CCC is told to go and review those patients, the patients die, or patients are diagnosed with cryptococcal meningitis, and they miss out in terms of all the things that need to be done for the patients, and we had high mortalities. And we actually found in some of the counties, the intern doctors were really struggling with these complicated patients without really much help in terms of expertise, in terms of what to do for them. And that really highlighted a gap in terms of maybe pre-service training, where people are not exposed even when they're in undergraduate training, and now when they're in internship, they don't know what to do with these patients. This is the 2 documents we've talked about. The OI manual, which we are updating. The last manual was developed and published in 2008. So we're working on this, and it should actually be ready to be launched in October. Then we have the implementation guidance, again, that's covering several years, just providing a way forward for how to manage advanced HIV disease in the country. I put this here just to reflect. When you're looking at the implications for TB and lung health services, look at TB contributing 35% of the HIV-related mortality. Look at PCP contributing 15%. Look at severe bacterial infections and other. So actually, close to 70% of AHD mortality is driven by infections that we can do something about it. These patients come to the TB clinic, to the inpatient setting, to the CCC, and I know we spent a lot of days in the last one day focusing a lot on TB, looking at post-TB lung disease. In fact, in this slide, I've not even included histoplasmosis and other fungal infections, which we are not able to diagnose currently, and they could be contributing to some of this mortality. So it's really timely that we're having this discussion, and more importantly, that we need to be looking, when you have patients, if you have specialized wards like in our hospital, Kenyatta, where you have a whole pulmonology ward, for patients who come admitted, we need to do targeted testing to identify the HIV patients, because likely those patients are coming with serious respiratory OIs, ranging from PCP, TB. I've not even included pulmonary KS, because we are seeing a resurgence of Kaposi sarcoma. In the presentations, I could hear a lot of, we don't have data, we don't have data. We're actually actively collecting the data, and one of our postgraduate students is actually looking at AHD burden currently in Kenyatta and Mbagathi Hospital, and will be documenting a 30-day outcome, whether the patients actually leave the hospital or succumb to the illness. And we're looking forward to that particular data set to be able to inform. And I think one of the things, because I was listening to the discussion around the oxygen in the morning and advocacy, one of the things we were fortunate to be involved in is really the advocacy for advanced HIV disease to come back into the discussion, because a lot of the big funders did not really have this focus on advanced HIV disease, because the thinking was that if you focus on 95, 95, 95, you've really achieved the highest, without thinking of what about the patients who fall through the cracks. So it really took a lot of advocacy, a lot of meetings, and I was fortunate to join a lot of people who are already advocating in the global space, organizations that are already advocating for access to cryptococcal meningitis treatment. And one of the success of that advocacy was really inclusion for Global Fund to include advanced HIV. For each country application, they had to include advanced HIV in that application. So advocacy, a lot of the times as healthcare workers, we should not give up on advocacy because our patients do not have a voice, and sometimes they do not have an opportunity to be in those spaces, and we can be that voice for them. So when we look at TB and lung health services, improving screening and testing, and targeted testing in our inpatient setting, particularly for patients presenting with pulmonary diseases, we need to offer them HIV tests. And more importantly, a lot of testing is not happening in the private sector because often in the private setting, you feel like you're offending your patient when you even think that they may be having HIV. So we really need to move away from that feeling that you're offending your patient and be able to offer them a HIV test because you can be able to offer them other interventions after the HIV test. We need to provide that linkage between outpatient and inpatient setting for both TB and HIV, and then linkages between programs. And we are working so closely with the TB program in this design of the advanced HIV disease because TB is the biggest chunk for AHD in our setting. So we are strengthening that integration. And then teamwork within the AHD, teams of centers of excellence, and we are using the hub and spoke model, but more importantly, to really facilitate the referrals because some patients are too sick to be cared for in lower level facilities and would benefit from being referred to the higher level facility. And then strengthening monitoring and evaluation for AHD, including reporting for both the AHD itself, the indicators, as well as even mortality indicators. And then the care of these complex patients requires teamwork. And already you're doing a lot of teamwork within the lung health space. So we need to see that teamwork together so that we can strengthen HIV. So in conclusion, we've looked at the status of where we are with AHD care in Kenya, and then looked at the implications for the TB and lung health services, focusing on integration and teamwork. Thank you so much.
Thank you, Dr. Martin, for that good presentation and even to know where we are in advanced HIV disease. Can we give her applause? Another applause. Thank you. I want to start with questions, if there are any questions that can be brought.
Thank you very much, presenters, for those amazing presentations. Mine is for Dr. Maritim. Thank you very much for joining us. I know it was at short notice. Thank you. We appreciate you for making time. I make several observations from your presentation, and the first, and I think one that I believe has settled in for all of us, is that up to 70% of all mortalities among our AHD patients are related to TB and lung diseases. And I think for me, that's a major area for all of us to reflect on. But the question I have is in relation to the centers of excellence that we have set within the counties, and also just to find out whether we are aligning those with the ones that the NTP is also prioritizing, because I know those are also county level facilities, but more importantly, to what extent are they completely aligned so that then we can benefit from the capacities that we are building among the health workers in the centers of excellence that are supporting our AHD patients and those that are supporting our sickest TB patients. And then lastly, I think you said it very well that now AHD is becoming a major area of focus, especially for the funders. And I have to acknowledge that, at least in my view, most of the ones that we are relating with are feeling that we do need to prioritize AHD, ensuring we build capacity among our health workers because of the fact that there's still a lot of TB that is being missed within our HIV, our persons living with HIV. There are still a lot of patients who go through the, HIV clinics, and then they're diagnosed too late when their outcomes are likely to be very poor. So just some reflections. And thanks again for coming. Yeah.
Thank you so much to our three presenters for today afternoon. I have a question for Dr. Maritim. You have talked about the definition of AHD being WHO clinical stage 3 and 4 of the disease. And our recent, from the analysis I've done, or from the TB data, that's TB data that we are generating from our facilities, I analyzed data from 2 facilities and realized that it shows that more people who are already living with HIV are being diagnosed with TB. So I don't know whether you will call that AHD, and what could be driving the increase. For example, one of the facilities, when I analyzed the June data, and I discussed this with our CTLC Mweni and Grace Kwamboka, in June we had 6 patients who were diagnosed with TB, and in July in one facility we had 9. Thank you.
Thank you to our afternoon presenters. My question goes to Dr. Marybeth. I'll start with a comment. We envision that in the near future, we should be very soon, we'll have full integration, and our HIV patients will be seen in outpatient clinics, and CCC will just be one of the special clinics, and they'll be able to wait together with other patients and be seen by clinicians that are seeing other patients, because we will have capacity build them fully and not depend on only CCC clinicians. I hope this will be soon because of integration and the transition that are ongoing. Now my question is, have we seen any changes in the prevalence of AHD due to integration? Thank you.
Thank you very much for all the presenters. It was great, and it's like we were speaking the same language in terms of the TB side. We have Center of Excellence, and it's like we are talking about integration in books or in meetings, but when it comes to actualization, at some point there is a missing link. I think we need to have a bigger conversation so that we all understand what this integration means. Is it in books? Is it in services? Is it in products? I think that's something that should be discussed very well in the country. My question goes to Balraj. Thank you very much for providing insight on the new AI that has that can predict. I don't know if I saw you presenting in terms of the cost, because every new solution that comes, we need also to compare it to what is in the market in terms of the cost implication, so that if a country we are pushing to adapt it, then we know that the cost is going to be favorable for the country. Thank you.
Good evening, and thank you to all the 3 presenters. My question is to Dr. Maritim, and it's, how can HIV TB programs improve TB screening, prophylaxis, and ART initiation to manage TB-related immune reconstitution, inflammatory syndrome, IRS or IRIS, as we know it, and protect lung health in AHD patients? Thank you.
Maybe one more.
Thank you so much to all the presenters. I'm happy, Dr. Nkirote, you've mentioned the issue of integration. I think that was also my other question in terms of the synergy between the TB program and the HIV program. Then my question to you, Dr. Marybeth, is the screening, because many a times we've said the quality of screening in the CCC is a major problem. And looking at the country, I know is currently working on a policy document, the TB HIV acceleration plan, that is aimed towards ending TB. So WHO has recommended use of more sensitive tools when it comes to TB screening, and that's among them the use of digital chest X-ray with AI. So what what role do we have with that in terms of doing the WHO symptom screening plus use of digital chest X-ray with AI for screening? Thank you.
Thank you, Tiff. Seems like Daktari, most of the questions are yours.
Thank you for those many questions. It means you are awake. And so let me start with the first question around the centers of excellence for TB and lung disease and the focus. So I think in one of our AHD meetings, it was mentioned that there are TB centers of excellence. And even I think that's the first time I heard around the card system for TB diagnosis. But it's good because we are still finalizing this. We've designated the county referral hospitals as centers of excellence. And I don't know for the TB program, what are your centers of excellence? Is it the county referral hospitals or even some of the sub-county hospitals as well? So I think that's a question. And I think we should look at synchrony because our centers of excellence are defined by, and you saw in my presentation, it's where you can replace or preposition resources to take care of the sickest patients who are likely to die. So when you're looking at the sickest patients, they're likely to be the TB patient or even the cryptococcal disease patient or pneumocystis patient. So we need to see that we are able to, because you don't have infinite resources, if we can be able to overlay and have the centers of excellence, because even you are targeting the same healthcare workers, you'll still need the consultants in those specific areas. So I think we can work, strengthen our relationship and work together so that we optimize those centers of excellence and we have more overlap and synchrony so that it makes a lot of sense. But also, we had envisioned a situation because we tasked the counties to identify where their centers of excellence or the hubs would be, but the number that they came up with was so unrealistic. We had almost 3,000 centers of excellence, which could not work. So because we had also limited funding, we then said, why can't we start with the county referral hospital? Because even you might need people to come and benchmark and see. So it's easier for people within a county to come and benchmark within their county referral hospital. And I think as we get more resources, then we can spread out within the county. Because also we need to be cognizant that people don't have to travel too far to be able to reach that center of excellence that they can get care. And then I like that the funders and the people who are funding your program are also focusing AHD, and particularly TB as an AHD driver, so that you can be able to minimize, or actually these are preventable deaths we are talking about. So we need to actually stop all these preventable deaths. And then I like the question and the observation, because you're using data, you're analyzing your data and you're noticing a trend, and you are actually asking yourself what is possibly explaining the trend that you've noticed. And I think when we look at TB, and I really grapple, and I'm looking to find out the information, because when you look at like New York had an outbreak of TB those days, and they were able to get rid of the TB. And I wonder, we really struggle with TB. We should even be, I don't know, we should have gotten rid of all the TB, and we need to look at it. What is it that will work? And to me, I think it sounds like at some point we might have to just bite the bullet and treat everyone. You reset everyone like they don't have any bacilli, then you start afresh. Because it means like we are really struggling with interventions and we are not winning this war. So just to come back to your question, if you look at TB, when you have, and it's just like any other infectious disease, when you have an infection and you're not able to break the cycle of transmission, then you can have a high number of infectious people, and that can drive that infection. And I think the drug shortages that we faced last year are actually, we are having those consequences now. What that means is that we had people who had TB, they were not treated, and therefore they were transmitting the TB. And that means for an infectious disease that's very transmissible, when you have a high infectious burden within a certain population, then the transmission is faster. And I think we just need to see, I like the AI tools, because if we use the AI tools and map the hotspots, then it means we need to focus on those hotspots, because it can really help us to focus and say, what is it that we can do? Can we even have like an area where you treat people and see what is the effect of that particular treatment, especially if you have shorter regimens that are safer, then you can say maybe you can try treatment as prevention. But those are just hypothetical thoughts. But I think leveraging AI will be an important game changer. And I like that. Just keep monitoring the trend. But even for those cases you identify, then you have to do contact management and even search for other cases around those contacts so that you're able to break that cycle of transmission. When it comes to the question around full integration, I think there was a question around full integration and the impact of this integration with AHD. And in full integration, it's envisioned that HIV patients will be seen just like in an MOPC with other patients. And I think some facilities are trying it out. I don't know whether there's been a national rollout, and we need to see what will be the impact of that. Because even for AHD, the trainings that we're having facility-based training, and we are training a wide array of healthcare workers within the facility, both inpatient and outpatient, so that we can build capacity for that AHD. And I think when we have a critical mass, then it might bear fruits. The only challenge, we don't have currently a way of tracking our AHD indicators. We are using the National Data Warehouse, and when we analyze, we do a cascade where you're looking at the people who are identified based on CD4 testing and all that. So the uptake is still very low, but we hope that more people can have the uptake. So we are grappling with two situations where even creating the awareness, having the CD4 count, and then having the healthcare workers use the CD4 and then report it, because you don't currently have a CD4 dashboard, which would automatically report for us some of this data. So we are grappling with where, even for the M&E, we don't currently have an electronic system that's able to capture the data from, for example, the inpatient. You might have some data coming in from the CCC, but it's not 100% within the facility. So we don't want to miss any cases, and we are working really closely to try and get the data M&E indicators and even start now reporting on the indicators. So I may not be able to answer your questions whether integration is bearing fruits yet, but maybe I think it's one of the things I can take up to the committee so that we are able to even see with the things that are being done at program level within NASCOP as integration, what is the impact on AHD. And then there's a comment. I think, Steve, you made a comment, but I think I might have forgotten your comment. Oh, yeah, it was around the centers of excellence for TB. And I think I've spoken to it so that we are able to overlay and avoid a lot of duplication, because then we'll spread thin, but focus on synergy so that we're able to maximize on the results from both investment by the TB program together even with the HIV program. And then I think there was a question about TB and IRIS, TB, HIV, and IRIS. So when we look at IRIS, it's slightly different and may not necessarily result in post-TB lung disease per se. When you talk of IRIS, it's an acute inflammation because of pre-existing pathogens where your immunity is now awake and is able to fight those pathogens. It hardly results in chronic sequelae per se, and it may be a different mechanism. I know you spent a lot of time in the morning talking about post-TB lung disease, but IRIS may not necessarily translate to post-TB lung disease, because we even know that patients who are immunocompetent, a number of them have post-TB lung disease, even in the absence of HIV. So I think the integration will be important, and in our curriculum, we actually focus on IRIS and how to mitigate the IRIS, but in terms of the chronic sequelae, it may not really lead to post-TB lung disease. And also, because we anticipate, what we train the healthcare workers is to anticipate IRIS. And that's why even in terms of timing of the treatment, for some conditions like TBM, we now have the evidence that you want to delay your ART initiation. For pulmonary TB, you can be able to start almost concurrently, but anticipate the IRIS, and then based on the level of IRIS, you can be able to give different interventions to mitigate the IRIS with a good outcome. And then in terms of the synergy between the programs, TB and HIV acceleration and uptake of screening, again, I think we've seen, I was able to hear the benefits of the screening, but more importantly, I think this was around the discussion that in CCC, the screening is suboptimal. And we've actually noted this ourselves, because you can find you had all the evidence there. A patient was losing weight, because in CCC you are able to track the weight. But a clinician will just ask the 4 symptoms and say no, no, no. And then the patient dies of TB or is diagnosed with TB 1 month later. So it means they are mechanically filling the checklist, but not emotionally invested in that checklist. So I think that provides an opportunity for using more sensitive interventions, and I think that can be a low-hanging fruit, particularly for identification of TB, where you're not only using the symptom screen, but symptom screen together with a diagnostic test like the digital chest X-ray and AI as predictive tools. So I think I've answered most of the questions, but thank you. Those are very good and useful questions to enrich the discussion. Thank you.
So the question regarding the cost of the AI solution. So I didn't find time to explain the operating model of how we co-design or co-develop the solutions. So the thing is that we work with the respective ministries or with the respective board actually. So of course there is cost for development of the models and hosting the model inside Amazon or Azure, etc. Once the solution is ready, we try our best to make sure that the model works on offline mode also, and make sure that the solution is made open source, and as a digital public good, we transfer the ownership to the respective ministry or to the technical team who manage the solution. So if you take the cough as an example, so it was less than 1 rupee per screening actually. So it's like hardly you can do 100 screenings for less than $1 actually with respect to cough. Whereas the other solutions, it's just integrated into the existing solutions. Like in India, it is called Nikshay, whereas in Kenya, if you are making any solutions, these solutions will not sit alone separately, and there will be a separate commercial aspects for it. These will be integrated into TIBU, which is the existing platform. And as it is made open source, it becomes easier for other countries also to take that, adapt it, and contextualize it using the data for their respective regions and can use it for their use. So that's how it can be taken up. Thank you.
Thank you very much. Let's appreciate the speakers. Let's appreciate well. Thank you very much. We have learned a lot, and especially if we can embrace the AI as the tool of diagnosing TB, I think it will be better rather than delay. Thank you very much, Dr. Maritim, for that powerful presentation, especially for advanced HIV, so that we can be able to manage our patients better, even when we see them in our hospitals. Thank you very much. As we are about to finish, maybe come up here and we line up. As we appreciate, can we wake up and we stretch ourselves so that we can, come here, Dr. Maritim. As we, stretch yourself, and then we try to pick flowers. We try to do something good for them because of what they have done. And we appreciate them for the good work and even for the short time that they have given us their presentation. And I think we have learned a lot. May we appreciate them in the best way we can do. Flowers, 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 flowers. And then we give them with a clap. Thank you. I think we are having the symposium number 10. Who is coordinating it? Thank you.
I think Joanne stole my technique. I was going to copy Dr. Sam and make you all do some clapping, jumping, and thank you for that. I was thinking of what best, but I'm still going to do it because seriously, I think we have had now 20 hours of fantastic sessions ranging through the entire spectrum of TB, lung health, HIV, I think post-TB lung disease. I think it has been, for me personally, extremely educative, and I'm very thankful. And I'm very proud of myself for being able to join this session and learn so much. So before we start, I thought maybe each of you can give yourselves a hug and say thank you to yourselves, to being here, to learn, to be better, and to do better. Thank you again to the entire organizing group, the scientific team, for inviting us. I'm, of course, Ronika from the Cure.ai team. We work closely with multiple implementing partners, supported by, of course, the National TB and Leprosy and Lung Disease Program. We have worked in the country, in Kenya now for over 4 years, and usually this is my 4th resoc, so I'm usually here speaking about our product, doing the usual sales pitch as we call it, but today I'm again very proud that we have come a long way in the past 3 to 4 years, where we have wonderful users who have come with their lived experiences of using digital X-ray with AI within their communities, within their counties, to keep the patient in mind and add value to the services that they're providing. For us today, the focus, of course, is to look at how AI has not just improved service delivery in the last mile with targeted screening and active case finding, but also how Kenya has been a leader when it comes to augmenting AI solutions in existing infrastructure within facilities, where we spoke about how can we make that $1, every dollar kind of go the extra mile. And I think Kenya has been a leader in that way, to think ahead and look beyond disease silos and make the existing systems more intelligent. So today, of course, a lot of the panel will cover their lived experiences there. And just before I hand it over and introduce our wonderful moderator who has made time out today to lead this session, I'm going to also sit and enjoy the shared learnings. I have a quick question here, and I'd like to get some guesses. How many digital X-rays do you think currently have AI software installed or augmented or retrofitted onto it across the country? Can I get some guesses? Go for it. There's no right or wrong answer. If it's more, it's good. If it's less, you can increase it. Any guesses? Come on. It won't start till we hear a number. 30, I hear 30. Do I hear a 40? Do I hear a 40, 40? 80. 80, yes, we are getting 80 going once. No, I'll reveal the suspense. I think the most important point is that we have close to 184 machines today within the TB program, and with multiple partners who support the program, who are actually rolling these technologies out. Back 3 years ago, this seemed impossible. So thank you to the ministry, to the partners for making this a reality. We are a long way to go. And today we get to hear a little bit of that experience, the good, the bad, the ugly. And happy to now start the session. And I'd want to welcome our moderator on stage. We have today Mr. Joshua Limo. Joshua is a public health specialist with over 15 years of experience in tuberculosis care, control programs, health system strengthening. He's played an active role in Kenya's TB response, contributing to the development and review of tools and policies that guide TB care and control. Joshua is an active member of the PPP Sector Center of Excellence TB Research Task Force. He's, of course, done multiple publications. He is also the program manager at Population Services Kenya, and he leads initiatives that make service delivery and patient outcomes happen. Before I kind of wrap up, I could go on about some of his skills, but there are 2-3 things that I think are important here as well. He is, I think, a serial award winner, so all the other scientists here better watch out. I I see there's a three pages long list of all the awards that he's won, but he's also the 2022 Young Scientist. He's done at the Kenya International Lung Health Conference, he's got the Award of Excellence in Advancing Mental Health and Well-Being. And most importantly, he's also worked very closely with the program and with multiple partners to make digital X-ray services accessible to the last mile. So welcome, Joshua, again, and thank you for supporting us for this panel. Over to you.
Thank you so much, Ronka. Thank you so much. Let's clap for her. Applause. Wonderful, wonderful session. I know we are towards the end of the tail end of this event, and this is the very last juicy one. All right? So I promise you it will be very juicy, so please stay tuned. It will be very juicy. We will be delving deeper. Since yesterday, we've discussed quite several things, and AI has truly come through in almost every conversation, almost every symposium that we have done. We have had AI coming through as a key tool to support TB response here in the country. And so I know when we hear AI, quite a lot comes in our mind, technology comes in our mind, but I think beyond technology, what comes up largely is the response at the facility and the response at the community. So that is what we'll be trying to center this evening, to look at the response and the adoption of AI in the response of TB with the experience from the facility and the community. And I will be having quite a number of panelists joining me here for us to look through and have this conversation and specifically bring the patient at the center, and not only just not just the policies around, but also bringing the patient perspective in this particular conversation. Yesterday, Dr. James Wagude alluded clearly to this conversation of this evening about the use of AI. One particular facility that he used was the Madiani in, I think should be in Homa Bay. And there was evidence, he presented evidence about the use of AI, how AI supported this particular facility to increase by 50% the case detection. And I think to me that was very catchy, very impressive, because the conversation is about implementation, impact, transformation, and of course, inclusiveness. And I think that was great impact just to highlight the conversation into this conversation to show surely there's great impact on AI use and also support as a tool to aid TB response. Again, I think this evening, my good friend Dr. Maritim also shared about the integration. And I think in terms of integrating TB, HIV, and I think also yesterday there was also the integration to other lung health diseases. This morning there was the PTLD integration in terms of TB. And I think that brings in the center, puts the AI at the center of the TB response, and also making sure it cuts across, not only just for TB, but also going beyond the TB into other disease areas, which is part of this conversation this afternoon. When we hear about AI, one of the key things, and all these innovations that we have had this afternoon, we have had from the two presenters that also presented in the session 9 about AI. And in there lies equity, lies access, and also lies sustainability. And I think I like the question which was asked by my good friend Steve about the cost, so that we also understand about sustainability. And I think this particular session gives us a room to have a conversation around this, and also make sure we also see the opportunities that this AI present. I think Rhoda Paula yesterday, someone asked about whether someone has used AI for the last few days. And I think the response was quite, that almost all the participants that were present had already used AI in some way. And I can still repeat the same, and I know the answer will be the same. I know some of you have used AI in one way or the other, and so because that is so, we will be looking at how that can now be strengthened and taken as an opportunity in TB response. In 2016, of course, the prevalence survey, which is, of course, a great reference in this country in terms of TB response, chest X-ray was a great reference in terms of finding the missing cases. And looking at this, at that particular as a reference, of course, through the TB program, this has also already been structured and also adopted in the new national TB strategy, whereby now adoption of chest X-ray and all other digital innovations to be used as tools to support TB response. And I think that's great, and we must commend the TB program. That means adopting, not just being a survey, now it stands to policy, now it's being now pushed into the implementation. And I think the numbers in terms of the chest X-ray that are available in this particular country are quite immense. We have, as you have mentioned, 184 digital chest X-ray across. And I think through the TB program as well, this has already have a great penetration to the communities. But I think in terms of adoption, we may need to understand some of the opportunities that these 184, what opportunities do they present to the people we serve? And so finally, as I wrap up this, is also to look, I looked at the data, which of course, from the TB program for last year, 2024, around 996,865 TB cases were notified. But when I looked keenly, around 49% of these particular cases were able to be done access a chest X-ray. But looking at it keenly, I think we still had, in terms of the chest X-ray, the quality, in terms of the chest X-ray that this patient in particular accessed, I don't know whether, I don't know how much the chest X-ray tool machine was an AI enabled. And so this particular conversation this evening presents to us an opportunity to have a conversation on how we can optimize the 184 digital chest X-ray that are present in this particular country and also serve our patients better. So together, I want to invite the presenters, the panelists today, this evening, to join us here, to bring us the facility perspective, and also help us to have a candid discussion on this particular topic. So I want to invite, let me start, Dr. Nuru Chebet Mbarak, a radiologist from Kericho. So as I invite her, please join me as you have to clap for her until she comes here. All right, so Dr. Nuru is a consultant radiologist at Kericho County Referral Hospital. She's also a medical doctor. She has master's degree in radiology and imaging from Moi University. She has done mini fellowship in breast imaging from Apollo Radiology International, Hyderabad, and preceptorship in international radiology at Eldoret Radiology Specialist Radio Care. Together with that, she is a passionate radiologist with a special interest in women's imaging radiology and intervention radiology. And on top of that, she's been doing telemedicine support in terms of interpretation of chest X-ray to other counties beyond Kericho County. Welcome, Daktari. And let's clap another applause for her. Great. So together with me, I will invite Dr. Robert Ndei Wadhome, who is also a clinical officer currently at, sorry, let me just, okay. Robert is a registered clinical officer and has a PSc in clinical medicine, community health, as well as a diploma in clinical medicine and surgery. Robert has 7 years experience in patient care and HIV/AIDS. Please clap for him. Management and emerging medicine. Currently, he manages patients in comprehensive care clinic at Kangundo Sub-County Hospital under CHEP in Kenya HIV program. His passion lies in delivering compassion, care, supporting HIV prevention and treatment, and contributing to community health. Beyond clinical practice, he is so dedicated and passionate about professional development and mentoring other mentoring other healthcare workers wherever he works. So let's clap again for Dr. Robert. Thanks, Robert. So together with us, I will also be inviting Dr. Elijah Yulu, who is a family physician. Let's clap for him. Dr. Elijah is a family physician and head of outpatient services at AIC Kijabe. Dr. Elijah is a qualified medical doctor with master's degree in strategic management. He's currently pursuing PhD in global health, focusing on health system strengthening, technology integration in Africa context. Part of the innovation include AI TB and stroke diagnosis telemedicine developed to expand care access. He's also a co-founder of Pan-African Care for Health Equity, driving research, advocacy, collaboration on NCDs and health equity. Passionate about global health system, and AI innovation to tackle the health changes. So let's join hands and welcome the panelists this afternoon. All right. Yes. Thanks. So, just to set the stage for this, and thanks to team for having joined us in this particular conversation this evening, just to give the patient perspective. So I think, I hope this is working. Okay, seems it's not working, so I'll share mine. So I'll start with you, Dr. Robert, from your clinical practice. Maybe just highlight a few things as you tell us more. I might have not introduced exhaustively, but you can just give us a snapshot of an addition of this in terms of your engagement in also TB response and at the facility. Yeah, over to you.
Thank you very much. Good evening, all of us. I will start by saying that what Dr. Maribeth has done is just clearing the way for me now to bring it practically what happens on the ground. So I sit in HIV clinic, and I will say we do a good job. You can clap for us. Now, when I receive a patient who is newly diagnosed, I have a lot of tasks to do. Number one is to show compassion to this patient and give hope. So that is very important. And where many healthcare workers miss it is at that particular point. When you miss it in the beginning, at the initial stage, you can mess up this patient in a big way. So the first thing is to show compassion to this patient and give hope that you will go through this, and I'm with you. So when I receive a new patient, let me start with a new patient because a lot has been projected here by Dr. Maribeth, and I may touch one or two, three things. And so if you are keen on what she said, is there was a slide which ended by saying do good adherence. And so that's where the meat of everything is, the backbone of everything, good adherence. So when I meet this patient, what I do is give them hope, and then I go in the clinical part of screening, doing good screening. Good screening means taking good history, which taking history as being so much diluted, and you'll agree with me if you are practicing medicine. You do good history, and then you do good physical examination. On doing that, my key emphasis is I want to rule out all opportunistic infection, because I realized that at the point of this patient coming to the facility, they had a complaint. A bigger percentage, they had a complaint. The complaint was the OIs. That's what brought the patient to the facility. So when they reach the outpatient and the PITC status is reactive, then everything changes. They are all referred to the CCC. And so when they are coming to my desk, they are exhausted, they are tired, they are panicked, they are frustrated, they are angry, and every negative thing you can ever think of, they are going through that. So if I'm so keen on doing screening, I will pick the OIs. And the number one OI for interest of this meeting is the TB. And when I pick the TB, if the patient has the TB, then there are several things I need to do. I need to send them for, one is to register them on the presumptive register. They have to be in the presumptive register. If I don't do that, Mr. Limo will not be happy with me. They have to be in the presumptive register. And then I channel them to radiological department or laboratory department for specific testing. And this testing is either gene expert or chest X-ray, and I will come back to that on the second part. And now, if the HIV, I mean the TB is confirmed, then I have to start the TBs if all factors held constant, and I will have to hold the ART. Now I'm holding that because of the iris which Dr. has mentioned, and I will hold for 2 weeks. Then remember, again, do good adherence and confirm to this patient that TB has cure. That has to be very clear. Just to give an example, Madam B.I., just for the sake of hiding her name, she came to me very frustrated. She's HIV positive, and the radiological image shows that she has TB. She's so frustrated. She thinks she cannot maintain a marriage, and she has to drop out of her workplace because she was not able to perform. So she was laid off. And again, she has a family. She doesn't know what to do. She's a very young lady. She came back to me some time later because I was transferred from the facility, and then I came back. And she said, "You remember me?" And then I'm like, I'm just trying to go to my database. Then she said, "You encouraged me." And that is the thing. She has to be encouraged that at the end of the day, TB will be cured. As then, if the patient has TB, she has to go through the process of TB treatment. If the patient the TB is not confirmed, or she doesn't have any symptom, or she's not presumptive of TB, then I will go in and start the ART. But again, I have to do a very good adherence. Do baseline CD4 count, do adherence, start TPT, which is very key. Let me say, these things, they sound very easy theoretically, but when you are sitting with the patient, you have to be very keen and very deliberate on what you are giving to the patient. The packages of care, 8 of them, you have to give them and ensure the patient that it shall be well with you. What I normally do, I normally confirm to them that you are not alone. Then I give the data. I have this number of people at this particular age, this, and where you fit, I have this particular number of people who have HIV. You're not the first one. Then I will do subsequent TCS, and I follow them up. It is true, some clinicians miss the screening for TB. That's why we have TB in HIV patients. But I will say this. There is a lot of work which is there. But it is all about self-drive. What do you want to achieve at the end of the day? Is it to clear the queue or to help the patient? And at the CCC, it is not about clearing the queue. It is helping this patient, because at the end of the day, if you're not careful, they will develop advanced HIV disease. Yes, I have been called to the wards, as the doctor has said. The physician and the MOs and the nurses will see this patient HIV positive, room number, I don't know, the room which is at the farthest end of the ward. And then I will come there. But what I've been doing as I'm coming to a close is doing mentorship to the MOs. With all humility, just ask them, you can manage this patient. And this is what you do. So the gap I noticed, they do not know what to do. So when you give them a clear guideline on what to do, and tell them you can confirm with me, not calling me to come, confirm with me what to do. It helps. About integration, which has been difficult, friends. It has been difficult, but I've realized you don't force it to people. So what have I been doing? I make sure the clinicians, the outpatients, understand HIV first. Because the reason why they are rebelling, they don't want to handle any HIV patient, is because they don't know what to do.
So I make them understand what is HIV, how do you manage it. And in the place of X-ray, which was the big problem, most of them, they don't have time to read the films. They don't have time to read the discs. And the AI has changed that narrative. They don't know how to do it. And if they know they don't have time to keep on looking at the films and reading it, they don't know what to do. So I make sure they understand what will you do in case you find a TB patient, an HIV patient. Maybe I will add more as we continue.
Thanks. Thanks so much. Let's clap for him. Thanks so much, Robert, for that particular input in terms of the perspective from outpatient perspective and also integration. You have brought a very strong perspective of integration as well as the outpatient, where you interact with the patient. So, Dr. Nuru, being a radiologist, and also at the county level, maybe you can bring to us perspective of a radiologist within your space in regards to TB response as well. Over to you.
Okay, thank you very much, and thank you for the invitation to be part of this panel. I think this talk has come at a very timely time where we are actually getting a lot of uptake of radiology as a whole. So all the modalities have increased in terms of requests from ultrasound, X-ray, CT, MRI, and AI has come at the right time to assist us. We had the fear of the unknown. I'm sure some of you who started the process, they said there was a lot of resistance from radiologists. I would like to think that it was just hesitance, and maybe it came from a point of lack of information, lack of knowledge, and not knowing where this thing is headed. So what I'm going to give is the general perspective first. The number of radiologists in the country will range between 300 to 350, with almost 40 to 50% of those being in the private sector. We have another big number crowding in the big cities, so Nairobi, Eldoret, Kisumu, and Mombasa, and now the counties, the rest of the counties. So those are almost 5 counties holding up the radiologists, and the rest of the counties have scattered numbers of between 0 to 5. So we have very few radiologists in the country on the ground, and when you think about a radiologist in a county facility, so when the MES equipment were released to the counties, we were given X-rays, ultrasounds, CTs, plus or minus MRI, plus the dialysis and ICU equipment. So this one radiologist, for example, I was posted as the first radiologist in the county referral hospital, and you would see they would do maybe about 15, 20 CT scans per day, but about 50, 70 X-rays and a number of ultrasounds. So when you look at how the X-rays were reaching the radiologist, it was based on need. And as he said, he will try to squint. And what I noticed is that the wards, the clinics don't have viewers. We are supposed to look at X-rays on viewers, but everybody is looking for the nearest light, the nearest sun, to look at your radiograph and make a decision about that patient. So already we were at a bad place because we are looking at X-rays first. The person trying to interpret is not trained. He's looking at it in a wrong way and does not have access to a radiologist who they can consult. So we were trying to struggle and just, muddle in the mud, trying to find out where to send this patient. And a lot of those patients would end up on TB treatment, and you say TB presumptive based on X-ray. Sometimes if they don't have access to gene expert, they would use the clinical presentation. Sometimes this patient would go directly to CT scan because it is there. So now AI has come to assist us, and the way I'm looking at it, we have so different levels of the AI equipment in the county. And the first one was distributed to about, I think, 7, 8 counties. The pilot study with CAD for TB, it didn't reach us. We had the retrofitted AI on our pre-existing MES X-ray, and we tried to use it for a few weeks actually, but it got a challenge with internet, and so we've not used it for a while. So my experience is based on the training that we've had in Nakuru for almost the whole of August and beginning of September. And for myself, I was able to interact with the Cure AI equipment, and I saw over 300 X-rays in the 3 days that I was able to interact with it. If you look at a day-to-day basis, if you give a radiologist 300 X-rays to look at in 3 days, they're just going to be angry at you. And what I'm going to say is that the assistance that it brings fast, it's going to pick up the normals. And so you don't have to worry. You're going to say, this one, negative for TB, no other cardiopulmonary abnormality or MSK abnormality in the chest, and leave them alone, release them, and they go and deal with the clinician with anything else that they're having. The second group is the ones who have TB presumptive with a high score. So TB presumptive, the current Cure AI score is, the threshold is at 0.5. So if you get a high score of above 0.8, 0.99, 0.98, then you are pretty confident that there's probably TB here, and you go ahead and do your gene expert. If you have, so what we noticed is that it's not very sensitive for post-TB lung changes, and it will still give a 0.99 score. You will still take this patient for gene expert, which is good enough because they could still have active TB, but that is much less than getting everybody through gene expert. And we have this middle group where you have the chest x-ray is abnormal. It is not TB presumptive. It's giving you a score of maybe 0.4, 0.46, but it's not TB. So you're thinking now, what are we going to do about this patient? And now, as a radiologist, as I was sitting there looking at these x-rays and trying to see where are we going to fit in, how are we going to assist this process, this is the biggest population that we need to assist. So number one, we need to re-educate the clinicians on basic chest x-ray reading. You will still be in the field alone, because when you're going to go for outreaches in schools, in churches, in markets, you will not have access to the radiologist at that time. So you need to have some basic x-ray reading knowledge. You should be able to pick out common pathologies, common artifacts, and be able to agree or disagree with the x-ray. That is number one. Number two, you should be able to know what to do with a patient who doesn't have TB. So you have gone to the field with your sputum, spirometry, HIV testing guys, and the integration of HIV, TB, and the lung health is taken care of. But if it is not those things that you need, then you should be able to link this patient to care other than to TB treatment or further testing. So we are trying to see how to assist. I'm thinking you need to actually map the radiologist as the equipment are being rolled out, and see if I am sitting in Bomet or in Narok, who is the nearest radiologist. Those are counties who don't have radiologists right now. You're in Siaya, you're in Homa Bay. Who am I going to send this consultation to? Apart from that, you have seen and you've seen cardiomegaly. You don't need the radiologist to tell you. The AI has told you there's cardiomegaly. It has told you there's pleural effusion. It has told you there is a hilar node. So you want to send this patient to a cardiologist. So our linkage to care to TB is very good, but we need to find out how we are going to link these patients to other specialists and complete their circle of care also. So I'm looking forward to having AI assist us, having X-ray actually come back to radiology, because it was going away the way many other things are going, and we would like to participate in the process to see the differences. We are already seeing that AI is speaking about 15% more cases than the radiologists. So already, and you know, if you're going to look at images, if you've sat near me, you have seen that I was trying to work. If you start working in the morning, by around 2-3 p.m., you've seen 30-40 cases going across the body. You're going to the head, you're going to the chest, you're going to the abdomen, you're looking at CTs, MRIs, X-rays, you start getting exhausted. And yesterday when Dr. James was talking about what he had seen on the ground about the initial equipment, it's actually very unfortunate, and I got pinched a little. I felt bad that could be happening in our counties, and was hoping it's not true, but I'm sure they found some of those things in those counties. And we need to just integrate and bring everybody on board, have the buy-in, and this is the only way this thing will work. So as much as we are saying, don't leave any TB patient behind, don't leave any healthcare worker behind. As long as you're going to be involved in TB lung health care, whoever you are, right from the community health volunteers and health promoters, all the way to the highest levels of care. So we hold each other, we hold the patient better. Thank you.
Thank you. Thank you so much. Let's clap for Dr. Nuru. Great. You've brought the perspective of AI as a great tool. You've also brought and showed the gap in terms of those who have been capacity built and those who are missing to be capacity built, and also 300 to 350 radiologists across the country with a population of 50 million. population. So I think that's a huge magnitude in terms of coverage. All right, so I want to now bring in Dr. Elijah, who is also a family physician, but also from a manager perspective. I know you do outpatient management within the facility. So maybe you can, just from a general perspective, your experience as a practitioner. Over to you.
Thank you so much. Mko salama? I hope we are not talking too much. Sindio? Tuko sawa. And let me just say something about what Dr. Nuru has reminded me. A time when we used to look for the nearest light, jua uangalie X-ray, and then, so I'm just thinking about some of us who were in those days, and then you're being called to come and review a patient, unasema, oh, hakuna X-ray. Yes, jua limetua, not coming to check the X-ray. But from where I stand, I still about 60% of my work is clinical, so I oversee teams, I see patients, with another 40 that is administrative and quote-unquote managerial. So what bothers me many times is, of course, the patients are getting the appropriate care when I see them, but especially when I cannot see them, when they are being seen by a clinician, when they are being seen by, somebody else without a consultant oversight, or even another consultant, because we all at different levels. And so every day passing, I'm thinking, how can we make systems efficient? Now, just by assumption, most of us here would have gone through public health systems in Kenya. And the TAT, the time that it takes for patients to be seen from gun to tape, it's just amazing in a bad way. And so the question for me every day is, how can we leverage on technology to improve things? And fortunately, though, this is not a new thing. I would want to see how many of us here are still using paper files. Oh, good job. So we have moved quite a bit, and I guess most institutions have, from paper-based files to EMR as we speak now. Speaking to my colleague earlier in the day, she did mention that the government is also, rolling out an EMR. And you realize this has been just an evolution that it's just a matter of time. And there was machine learning before we came to AI, but now, lo and behold, AI is at our doorstep. The question is, and I'm sure that our patients use AI, a good number of them come and challenge my clinical skills with AI, and it's pretty interesting. So it's all over, and we cannot ignore it anymore. The question, therefore, every day I keep asking myself is, research seems to show that AI tends to help people with information more than those with less information. And case in point is especially radiologists. So AI is more useful and helpful to radiologists than the other cadres, because their base information is also a lot more than the general population. And so that's something we have to be cognizant about. I do some, like has been said about AI, it's not only with TB and chest x-rays. There is, we are looking at stroke care and AI out that can, help us improve our systems. And I do not know, when I go through our clinical rooms, I get my clinicians. They are very good. They will be typing and typing. Now, unfortunately, typing is not something we are taught in Kenya, or at least I was not taught, and therefore it takes quite a bit of their time. And so we are also piloting something we are calling speech to text, so that we can see whether a conversation between a patient and a doctor can be transcribed by AI, and therefore give them, a synthesized, clinical encounter. So I think there is a lot, and I did hear somebody say that, think about AI as your, as your very good friend who does not care about what question you're asking them, and has a vast amount of knowledge and does not easily forget. So that's how I'm looking at AI from my perspective.
But the question is then how can we transfer this, this great asset to the patient? In this context, we are talking about, lung health. Then, TB is a big deal, and because I oversee ambulatory care and, CCC is one of the units that I oversee, it's something I'm looking forward, and I have interacted with QII. We'll be getting to that in a bit. But I think if we are not using AI wherever we are probably not giving the patients the best. And you can take that with a pinch of salt, but that's my assertion at the moment. Thank you.
All right, thanks. Can we appreciate him? All right, thanks. Thanks. I think that is great general perspective from each of you, and that brings us, thanks, Dr. Elijah, in terms of highlighting the integration with other lung disease areas, as well as also painting the picture of the health system strengthening. All right, so I want to come back to you, Dr. Elijah, Robert, in terms of, just to ask, how has it helped, how has AI helped in terms of navigating the environment and navigating the environment in terms of your clinical setting, checking and taking care of your patients, and what advice can you give other clinicians in terms of the use of AI, or all of us here as well? Over to you.
Yeah, so as I said earlier, so we could receive patients with X-ray films, others carrying discs. So you have to put them in the computer and read the X-ray, or take the X-ray, try to find the nearest window, and try to figure out what is happening to that patient. And yes, it works at some point, but now with the introduction of AI, things shifted in a good way. Let me say this. I'm putting on these glasses. They are enhancing my eyesight. I'm able to see clearly and in finer details. So that is the close example I could bring on using AI on the clinical setup. Yes, things were going on, but now you are much more enabled, because when it was introduced to our facility, remember our facility is 80 kilometers away from here. So we are a little bit in a remote setting. But in such a place, the AI was, the X-ray was AI enabled. And with that, when a radiographer or a sonographer does an X-ray from the radiological department, with the synchrony of data where the laptop has to be in the internet and I have the application on my computer, then I'm able to see that X-ray timely. So with that, those patients who needed to wait for films to be printed, remember the setting we are in, so sometimes the X-ray, the films are out of stock, and I have to walk 5 kilometers. Well, 5 kilometers are too many, but I have to walk from one department and go and read it from the X-ray monitor or take a picture, then try to figure out what is happening. Now, that is over. It is a matter of just clicking on my desktop, and I'm able to open the Q track, and I'm able to see that X-ray. So long as the sonographer put patient's identifier, that is something which we need to enforce. So with that, then I'm able to, just by looking at it without much details, it has, the AI has done a lot of work on that image. By dissecting it in such a way, you are able to trace where the issue is. So what it does, it takes that image and then it highlights the points of concern, and it gives, it may tell you there is cavities here, consolidations here, lung collapse here, and then you are able to see it. Some of them, they are so detailed, they are so minute that if you are looking at a film, you'll easily miss it. So when the AI picks it up, first you are able to see it, and then it gives you a description, and then it dissects the entire image, from the lungs, from the mediastinum, the heart, the bony part of the chest, and we're able to see all the details. And then after that, it gives you a score that it may give you a score of 0. If the score is nearer to 1, then there is high risk of TB. But it will not tell you there is TB. It will just make sure your eyes are opened. You can make a sound judgment faster. You don't have to take a lot of time. Let me say this. Before, we used to look at those X-ray, and because we are trained in school, definitely you are supposed to read an X-ray and find the pathologies and the abnormalities. But there are some details you are not able to pick the find one. So what we used to do is, because there is a TB coordinator in the facility who is trained in the TB management, you have to take a picture of that film and send to him, and probably is in an interior place, maybe in a dispensary doing a mentorship, and then you have to send it to him for him to read it. And maybe he's so busy in maybe engaged in mentorship program, and he has not seen your message, or he doesn't have data, or you don't have data. So issues and problems, and then you have to call him, Daktari, please, there's something I've sent you a WhatsApp, can you respond ASAP? And the patient is outside there waiting for you to send an X-ray to someone else to read. But now, with the QIA, AI, it is able to give you details, and from there you can make now your clinical judgment from there. Do you need further examination, maybe for gene expert? Do you need to refer to another place? You are able to make your judgment timely. The other thing is, now, that is in the CCC, where we have embraced the technology. But the other departments, just the other day I was called, the issue of calling is still there, to the ward. Please run and review this patient. The patient actually is what we call return to care, is Dr. mentioned. The second category, if you remember, she gave the category of the newly enrolled return to care are those who have treatment failure. So the return to care, they are the problem because they have stopped taking their medication at a particular point, and they develop OIs, and the number one OI which will step in very fast is TB. So I was called, come review this patient. And so I'm asking them, have you done any investigation? And they gladly say, yes, we have done an X-ray. So where is the X-ray? I'm expecting to be taken to the computer and see it, maybe try to read it with Q-Track. Or hopefully they have done it and they told me, Doctor, it's here, then they give me their phone. And you see, look at try to read it from their phone. It's not, it would have been easier to read it from Q-Track. So do you know what I did? I told them, guys, you're a little bit behind, but I'm here to help you learn. So I just told them about Q-Track, and now I'm praying that they will embrace it. But you know, I'm there to make sure I mentor them and champion the integration process. Again, the other department is outpatient, where they are overworked, definitely, because there is a limit. The number of care workers there's shortage, definitely, and that is the reality in Kenya. And so for them, when what they used to do is, when they see any X-ray, so long as chest X-ray, there's no discussion. TB, CCC, just go there and you will get help. But now with AI, at the initial stage, yes, there was some resistance, because what is this? It is adding more work. Let me say this. For us who work in the program, working in CHEB for now and CHS for now 5 years now, we are used to changes. We are used to new things. Every time you are told there is this new tool, please work on it. There is this new guideline, work on it. So in a good way, we have started to embrace new things. Because these new things, they help us produce better results. And the better results is a good thing to the patient. And so for some who are working with the patient, they don't want anything added to them.
So bringing AI, it might seem like you are adding us new thing. I have to open QTrack, try to find whether it is working, connect with the radiology, and so on and so forth. But now the message which we are bringing to them and helping them understand is you don't need all that. You just need to open it. Click, open, and read. Very simple. So with that, there is no congestion in the outpatient. There is no congestion again in the TB clinic. If patient is, as Dr. has said, it will show you if whether chest X-ray is normal. If it reads normal, please manage other issues and other conditions depending with what the patient has presented. So in summary, what I'm trying to say is our work has been made easy, and I pray and I ask each one of us, try to embrace it. It will help you make your work easy. It will make your work easy in the way you do your reporting, the way you see X-ray. Again, the way it interprets the X-ray also gives you more knowledge, understanding of how to look on an X-ray. If you're given X-ray, you know where to look. I need to look at the cosophrenic angles. I need to look at the heart, because the QTrack will show you all those details. So when you are looking at the X-ray, even if it is not in the QTrack, you are able to look at those finer details because already you have been exposed. And this is a good thing for us, healthcare workers. Let us embrace it.
All right, thanks so much, Robert, for that. In terms of, let's appreciate adoption by more clinicians. So I think the aspect of adoption is quite key, as you have pointed, and also that it aids the decision making, so that you don't over rely on one person. Okay, of course, the person we over rely so much is the radiologist, and so I want to bring Dr. Nuru as the radiologist, because you seem to be the cadre in which this over reliance are placed heavy. So could you maybe highlight how a chest X-ray or innovation in terms of use of AI has helped and brought opportunities in terms of responding to providing radiology services, and also improving accuracy, speed, and all that. Just in terms of how has it brought change. Over to you.
Okay, thank you again. So we are looking at AI as a new tool, like the stethoscope that will be used by clinicians, radiology departments, and other people in the healthcare system. And first to think about it is that the AI was trained by radiologists. It was given millions to billions of data sets, and the radiologists are the ones who are showing it that this is a nodule, this is a cavity, this is a fibrotic band, this is a fusion, and it has learned, and so it's able to just regurgitate that information and give it in a faster, more accurate way. And so we have already been told the sensitivity, the specificity, the accuracy is very high. We are seeing that it's going to allow us to see a lot more patients. So the number of patients you could screen per day or per week has almost tripled, because you're able to take it to the vulnerable groups. You're able to take this machine to prison and screen everybody, to the school and screen everybody, to the village and screen everybody. So the capacity of the machine is that it can screen up to 200 patients in a day. So it means if you have done everything right, you charged your batteries very well, you have everything you need when you go to the field, you'll be able to see up to 200 patients. That was not humanly possible before that. So we need to accept that it has transformed what we are able to do, and embrace it and now work with it. I agree that the bottom-up way of looking at it is better. So you start from the smallest groups, targeted groups, instead of scattering all this energy, then you will be able to see the impact of AI. But I can say that as radiologists, we're embracing it. Last week, we were having our Pan-African Congress of Radiology and Imaging, and AI had almost 8 sessions in that symposium, in that conference. So it's AI everything, AI improving your workflow, AI triaging your patients, AI giving you a preliminary report, AI contacting the next point of care. For example, in stroke management, AI is going to alert the relevant team to respond to whatever is needed for that patient in good time. So it's a matter of accepting, embracing, and starting with it. So run with it from the beginning. Don't misuse it. learn to know when it is having a few pitfalls. So I can name a few examples. We had a patient who had massive pleural effusion in the field on our first day screening in Nakuru. And we are seeing this pleural effusion is on the left. So after taking the image, the radiographer is supposed to optimize it. So you zoom, you label, and then you finish the scan and give it a few seconds for the AI to report. So we have seen a left effusion. We are waiting for the AI to report. It processed, and voila, it flips the image and tells us the effusion is on the right. Just because the cardiac contour turned to face the other side, then it changed the effusion to the right, gave a very nice description, and you know, you have seen it is there, but now the description has flipped. So you have to be alert to some of these very small pitfalls. It can circle a nipple and call it a nodule. So you need to check the other side and see, is the nipple there? And just, you know, and the good thing about the Q-Track reporting part of it is that you can change that report. So you can add an addendum and say circled nodule is a nipple, patient is not positive for TB, or there's no nodule, or continue with other management. The other one pitfall that we saw is that we had a patient who had an aortic aneurysm and it said normal. So it might not be sensitive to other mediastinal things apart from the heart. So you need to be able to see when there's abnormal mediastinal widening. But by and large, it is improving care, it is improving access, it's going to bring equity, especially to the people, the vulnerable groups. You see, as a radiologist, actually, I was very distant from what is on the ground. And when we went to screen these patients in the slums in Nakuru, I was like, these patients will never come to hospital, no matter what you tell them. They are high, they are drunk, they are poor, they are frustrated. So the fact that you have looked for them, you have sensitized them, you have told them you have come to do this, and you will make sure that you link them to care, is going to make a very big difference. So it's important that we see all these good aspects of it. And the portability part is good. The only thing is that it's a bit delicate. So let's not receive these 184 machines and in the next 2-3 weeks, or the detector is broken, or the tripod cannot hold the watt. So whoever is going to handle the machine in the county has to be very responsible. They have to have, like, you know, what do we call this, inventory. You know, you have this number of chargers, this number of cables, this number of batteries, this is your detector, this is your watt, and be responsible enough to have it intact at all times. Otherwise, we will not be able to use it as long as we want to. So AI is here to stay. It's only going to get better. It keeps evolving, and whatever we use it for right now will determine how it grows. Even the one we are using, I'm sure, is an improved system of a previous version. It could be 1 year, 6 months, 3 months ago. There's something they've noted, and it has been improved. So how we are going to improve it is how we use the data we get from it. So if you get any challenges, if you get any data, any numbers, how it's picking TB, how we are differentiating post-TB changes from active TB, it's going to inform the next phase of decision making, the next phase of policy. So let's make sure we are actually using this data. It's going to be at our disposal, but we can't use this data if we are having it wrong right from the beginning. So a lot of counties have this issue of just putting, I was told that you just put one identification number and you put all your patients on that identification number. The AI software will know that is one patient with 1,000 X-rays. So it will not make sense. So we encourage our people, train, retrain, emphasize. If you're in management like Doc here, make sure they are doing the right thing on the ground. They are taking the X-rays, you know, all the quality measures that we look at, positioning, good inspiration, so that we can actually get quality. The images themselves are of very good quality. They are digital, they are clear, you can get information from them. But if you're going to take the apices away, the costophrenic angle is not there, you are taking the whole abdomen, then you're interfering with what this thing is able to pick. So we should ensure that those QC measures are in place, and we'll be able to see the value of AI. And I'm sure we will, in the next 1 year, we're just going to be amazed at what we've been able to achieve with this product. Thank you.
All right, thanks so much. Let's appreciate. Thanks so much, Dr. Nuru. Specifically on that AI is not complete. It also still needs the intervention or the engagement by the clinician. So I want to now shift to Dr. Elijah in terms of sharing with us the impact of using a chest X-ray AI screening tool in terms of patient management, of patient flow, improving the turnaround time and all that, in terms of patient management within the health system. Over to you.
Thank you so much. And perhaps it's by now abundantly clear that the patient care element, the patient sitting across the desk is getting good care if we incorporate judiciously, of course, AI. Let me just handle the issue about, just what this actually means to the patient from my perspective, and of course, it would be interesting to hear what other people see this as. We need to start thinking about throughput. When we talk about throughput, is actually an entire process, getting from the beginning to the end of the process, and that's how usually in healthcare we would measure efficiency. How many patients we can get to see. So the AI will see many of those, but let's for a moment think about this one patient who has an abnormal chest X-ray that has been flagged by the AI. And the reason why I do not use generic measures like, the patient's transition time increase or rather reduce, because that's what we are all looking at. But how I like to look at it as a metric in healthcare is that it's the time between when the patient was seen and when we got an accurate or an intervenable diagnosis. And that is particularly what AI seems to improve a lot, because in a facility like mine, if there's an abnormal finding on a chest X-ray, then actually your process sort of gets much longer because, now you have to do this, do the other, and so on and so forth. But what for sure has improved is the duration between start and when we actually got a diagnosis and something that can be intervened. I think I'll have it at that, and then back to you, Limo.
All right, thanks so much, Dr. Elijah, for that. I think just as we wrap up, you can see my co-facilitator is here at my case. But just to bring to your speed, just to bring us to speed, give us the patient perspective. I think that's what I truly needed to hear about. What do you think the patient perspective in terms of digital X-ray, AI use in terms of TB response? Just in a short, maybe 2 minutes.
Okay.
Yeah.
I'll say this. Well, most of the patients not know what you have done to bring this diagnosis until you explain to them. Because they are used to carrying films and discs. That's what they are used to for them to have an X-ray. But now with the new technology where they go to the radiology department, X-ray is taken, and they are told just go back to the clinician. You will get the detail. Then they come to me, and I'm able to give a well-detailed information to them. Well, for them that's plus, and for those whom I've interacted with, I've explained, because again, remember the setting, so most of them may not understand what you are saying, but for the few, they are appreciating it, that I'm able to give fine details without wasting time. I remember I served a patient and then they were like, "You're done." That was so fast, because they are used to coming at 8 a.m. and then they are leaving at 5 p.m. more frustrated and sick. But they come to me and I'm able to serve them very fast and efficient without go to this department, do this and do this. They're appreciating it. Now, the only thing which I know the counties are working on it is about the cost part of it, because some of the patients have to pay for the X-ray so that the image can be, the X-ray can be done. Those who have share, probably they are not able to pay a certain amount of money for the share to be used. So that is the constraint part of it. But in terms of the service and how I'm able to give them better service and good service within
good amount of time, then they appreciate it more. So it is working. It's working well for them.
Thanks.
Yeah.
So to you, Dr. Nuru, in terms of opportunities, what opportunities remain in terms of adopting AI in terms of TB response? What other opportunities remain? 2 minutes.
Okay, so the way I'm looking at the opportunities is what we are able to do to improve what we are getting from AI, getting out of the frustrations we had. And one biggest opportunity is that we are now going to talk national and county government integration. And you know, the way the national government is organized is not the same way the county government is. There's a lot of politics in county, there's a lot of interference in the healthcare system in the county. So we are going to try and see how to improve and how to interact better for the sake of the patient. We got an extra Cure AI machine and we are taking it to a sub-county hospital. And the MCAs were there telling us, we have prayed for this machine. Na Mungu amesikia maombi yetu. This machine now will sort all our problems. So we had to tell them, please continue praying. This machine is for chest X-ray screening for TB, because now they will know they will scan the whole body with that machine, and that will just reduce the lifespan of the machine and be detrimental in the long run. So we have opportunities to reach the lowest people in the community, the lowest health care providers can be trained, and we have opportunities for research, we have opportunities for getting papers out and improving how we give care to our patients. One thing I don't want to leave without mentioning is the radiation protection part. So a lot of hesitance from the radiology department is because of that. And we need to be sure that the people we are sending out to the field to do 200 X-rays are safe. So as much as we are saying the cure, the ultra-portable X-ray, the radiation it's releasing is less. Radiation is radiation. Once it reaches you, it has reached you, and the quantity that you're going to receive in that field after scanning 200 patients is going to affect you. So we need to think about it broadly. We need to include all these stakeholders so that we don't face that kind of resistance. Otherwise, we will reach with our machines, and the radiographer will refuse to use it. Thanks. Because they are not protected, they are not monitored. I asked a few of them if they had dosimeters for the card for TB, and they didn't have dosimeters. So we are happy that the Q-Track and Cure AI is coming with dosimeters. It's coming with enough lead gowns with thyroid shields. And so we need to just emphasize, because we also know them. They had other radiation protection gear, which they stopped wearing. But now when you're bringing this one, they say we can't do without the gear. So Kenyans are always Kenyans. We just need to cover all the loopholes, cover the ground, integrate and involve everybody so that we ensure continuity of this process and ensure that we grow with it. Otherwise, if we have one of the machines in Homa Bay is broken and they're saying they cannot get assistance, they need a part replaced. So let's ensure the tech support, the IT support is smooth for the counties, even if you don't have the service contract expires in December. Show them what they can do to make sure this machine does not have any downtime. So thank you very much.
Thanks so much. Thanks. I know we are short of time, but thanks so much, Dr. Nuru, for bringing that. I would have loved to hear whether there is return on investment. This is a question to Elijah, maybe 30 seconds, whether there is return on investment in terms of digital chest X-ray. I mean, have a minute.
Less than a minute. So it's certainly good return on investment, and one of the things for us to consider is looking at return on investment, not only financial, but also on the well-being of the patients that we see every day. Thanks.
Thanks. All right, thanks. That was it. So sorry for the we were pressed of time, but thanks. Can we clap for our panelists? Can we clap? Let's clap for them as they stand. Thanks so much. Thanks, you have done great. Thanks for great inputs. Thanks, Dr. Elijah. All right, so thanks. I think at this particular point, I want to truly appreciate all of you for staying in up to this particular time to listen in terms of AI. I think two things we have picked and that has come from this is in terms of mainstreaming the use of digital X-ray in terms of in our health facilities to improve access of services. And I think that's exactly what has come from this conversation this evening. we need to see on how to mainstream and make sure all the facility system are adopting this. The other one is also the retraining of the healthcare workers in terms to improve adoption and also improve for them, each and the healthcare workers also to understand the importance and the benefit what digital X-ray is bringing to them, or the AI as well. Thanks so much. That was our very short time, and enjoy your evening. Thank you so much, my friend.
Thank you so
and
much,
have
Limo.
your time.
All right. Limo, before you go down, we need to appreciate you. You can't just run away like that. Move closer. So we are now approaching the closing ceremony, and turn to your neighbor and say, "Wah, you made it, wah." All right. Mangoes and fish. Do we remember that song, eh? So when it's M, the gentleman, you just, I know we are tired, eh? You raise your hand, eh? When it's F, the ladies, you raise your hand. When it is sweet, when it is, you clap. For who? For who? All right. Mangoes and fish are very, mangoes and fish are very, if you follow me. Thank you so much, Limo. Thank you for a good session. All right. Dr. Nkirote, are you almost there? All right. So thank you very much. I would want us to stand and stretch a bit, please. I know we are tired. Just stretch, stretch, stretch. Please don't knock your neighbor. Stretch a bit, stretch a bit, stretch a bit. In your closing ceremony, you can stretch forward, not only sideways. You can stretch forward, stretch forward. That's wonderful. All right, you can take your seat. And at this moment, we want to go into our closing ceremony. And I know our next speaker is Dr. Nkirote. She's setting up something. In the course of the last 2 days, we have been reading our bios. And the depth of experience, depth of expertise, and sharing and achievements has been wonderful. But allow me to honor you today by reading back to you the bios of all the people gathered here for the last 2 days. And it reads this way. As we close this symposium, I want to take a moment to acknowledge what you have accomplished over these 2 days. Because you are living here different from how you arrived. You are now part of an elite group of health professionals who have engaged with Kenya's most current TB and lung health evidence. You've examined the latest burden data, grappled with the realities of our prevalence surveys, and understood how social determinants shape every patient's interaction. You have sat in this room with decision makers ranging from the Ministry of Health, from Global Fund, from partners. And you just didn't listen. You participated in shaping conversations about sustainable financing, innovation, diagnostics, and evidence-based prevention. Like today, you have learned about cutting-edge innovations, AI, chest X-rays, in TB, for example, in CIA, the vaccine pipeline, and you have moved from possibility to reality. You have engaged with non-sputum diagnostic tests, changing how we find TB in children, the shorter regimens that help us improve outcomes. And these are just not distant dreams. These are practical tools you can now advocate for implementation. But most importantly, you've heard how TB survivors themselves. You've witnessed, there was Millisent, there was Charles, how they have transformed their pain into purpose, and reminding us that behind every statistic is there a human story, and that our technical excellence must always serve human dignity. You've explored person-centered care, gender-responsive programming, and how to address the needs of adolescents and adults who are falling off the care cascades. You've learned about post-TB lung disease. You've learned about chronic respiratory care. You've learned about pulmonary rehabilitation, and recognizing surviving TB is just the beginning of a journey. You now understand that Kenya isn't just implementing global best practices, we are creating them. And from our integrated chronic lung disease frameworks to our community level innovation, we are contributing knowledge that the world is watching. Over these 2 days, you've built a network. The person sitting close to you, the speaker you approached over tea break, the colleague you exchanged contacts, the connections are your support system. And you're taking this knowledge back to your counties and back to your communities. You just didn't attend, you contributed, you shaped Kenya's future. Thank you for showing up. Thank you for staying engaged. And thank you for caring enough to be here. Let's give ourselves a big clap. I'll hand over to Dr. Nkirote to take us through the next session.
Thank you very much, Dr. Sam. Could we please stand and give Dr. Sam a rounding applause? Yeah? Let's start with 1 finger, 2 finger, 3, like that, and we'll finish with a big one, all right? 1 to go. 1, 2, 3, 4, and then a big one. Thank you very much. Thank you, Dr. Sam. All right, my presentation, please. Mine is not really a presentation. It's an overview of what we have covered these last 2 days, just highlighting the role that each and every one of you has played in ensuring that we had a very successful symposium. I want to just convey my gratitude on behalf of Prof. Chakaya, the chair of this particular committee that was organizing this conference, and myself as the chair of the scientific committee. We want to thank all the speakers, the panelists, the moderators, and the delegates. And we really appreciate your work towards organizing this. The snapshots really are various photos that have been captured over the last 2 days, mostly from yesterday. We will share all of this with you once we have collated all this. I also wanted to just highlight that in these last 2 days, we were able to bring together over 150 delegates. We had planned for 150, but we actually managed 160 today. So a big hand to all of you. We had multiple exhibitors and sponsors for this particular symposium, as listed there. RESOC, thank you very much. CHS, Cure.ai, Glenmark, MSG, Medica. We really appreciate your support in ensuring that we had a well thought out symposium, one that was funded. There were many learnings, and Dr. Sam, thank you for summarizing some of that, so I won't get into that. But one of the things is that we had a very engaging session, Dr. Kadure, on health financing for TB and lung health. And I think the takeout for me is that we all are part of that solution. This is not a donor agenda. This is an every Kenyan agenda because this is about the health of our people. But then there's another session which was presented by one myself, and it was on food as prevention, nutrition as prevention for TB. But this doesn't just apply for TB, but also for all diseases and all lung diseases. Looking ahead, I would like to share with you the exciting news that next year we will have and hold our Kenya International Scientific Lung Health Conference that will take place from Wednesday the 5th to Saturday the 8th of August in Mombasa. A big hand. We are very excited about this one because we usually hold this scientific conference every 2 years, and then in between we have a symposium such as this one. So we look forward to everyone's engagement. And for our sponsors, Ronica et al., we look forward to engaging you actively. Thank you very much. So really, this is to appreciate each and every one of you. In this particular photo, I want us to recognize the people that you do not see seated here. You do not see them speaking. All you do is interact with them in the corridors. And these are the volunteers, the people behind the scenes. And the first one that I would like to recognize is the gentleman seated right here. Please stand up, Jeff. Can we please stand and appreciate Jeff? Jeff has been holding fort for us as the secretariat. He's an amazing young man. Thank you so much, Jeff. Thank you for your support. Thank you for always sending those emails, reaching out to the delegates, the sponsors, etc. And there are many others, but I just wanted to call out Jeff because of all the support that you provide. And with that, I want to close because of time and invite Dr. Kadhure to come here and just close for us officially. Thank you, everyone.
Thank you, Dr. Lorraine. Now, I know who to make, sasa ninajua the people who, when the time is short, who to put on the agenda. But first and foremost is to express my very sincere appreciation, not just to the team here, first and foremost to God. I think He has been good to us. We've experienced fair weather. I do not think I saw people running in and out because they ate one thing or the other. He has kept us, He has preserved us to the end of the symposium. But secondly, as has been mentioned and cannot be overemphasized, is for the team that actually came together to put together the symposium and support its implementation. But thirdly, to all of us in this room. We came, we showed up, we stayed, we listened, we participated. But now this is where the rubber meets the road. And I'm glad for Steve because he asked a very direct question. We talk integration. Is it on paper or is it practical? But basically what I am saying is the theme of this year's symposium was very simple. We are looking at innovation and integration in advancing TB and lung health. But then when we go back to the places of work, whether you're a policymaker, a clinician, an activist, a community health worker, and even just a member of society, because we are all coming from communities, whatever role we are called upon to play, if it means advancing the technology and making sure that it is applied, please let us do it with passion and commitment. If it is providing the resources, again, when we knock the doors, please open them. But also for us to ensure that as government, we remain accountable to the people that are providing the resources, but also to the communities that we serve, to ensure that all the information, knowledge, and learnings that have come from the many presentations we've had today will actually translate to action. And I can commit that God keep us in the next iteration and the next conversation we are having, we'll be bringing back evidence that from the challenges and the recommendations we had in this symposium, this is how far as a program we've actually managed to translate those to action. So I hope we will remember. I know if you don't, Steve will remember. Remind me to be held accountable to those actions so that at the end of the day, we didn't just come here to waste our time, but to actually improve the quality of lives of the very patients that we seek to serve.
Now, because I'm always the one who has the unfortunate responsibility of standing between people, neither going for food or going home, I want to stop there, appreciate each and every one of us, request a volunteer to pray for us, and then after the prayer, declare the meeting officially closed and allow people to disperse. So I don't know if we have a volunteer to close for us with a word of prayer. Do we have any logistical announcements? Okay.
Just one. There's a QR code that we will put up on the screen, and this really is for you to give us feedback. So kindly scan this code. We would love to hear from you on how we can do better and how we can improve. Who will volunteer to pray for us?
Good evening, everyone. It's an honor, at least I get to speak on the mic. Yeah, so my name is Claire Kamau. I'm a nurse in Avenue, and I'm the vice chair for RISOC, and I represent the nurses on the board. I've really felt empowered with the engagements, and I believe we will be, by the time we come to the conference, the nurses will come with something. We've started some discussions, and so we'll bring some reports. Yeah, so let us pray. Our Father and our God, we thank you. We thank you for the gift of life, the gift of community, and even for giving us the calling to serve you through serving your people. And so, Lord, we pray for each and every one represented in this place, and even the facilities that have been following online, oh God. We pray that by your Spirit you cause us to change, because all this is wisdom that comes from you, so that we can even serve your people better. We thank you for the wisdom. We thank you for all the learned and all the projects that have been done to put all this together. And we pray, Lord, that you expand our capacity, each and every one of us, that as we go back, Lord, it will not be just another conference, but God, by the time we come back next time, it shall be much bigger and better. We pray for the journeys back home, oh God, no incidents, no accidents, oh God. And we pray even for the team that has put this together, Lord, that you may grace them even more and more. And it is in Jesus' name we pray and believe. Amen.
Dr. Immaculate, that is the declaration of the meeting is closed. Let's appreciate Dr. Immaculate. We do. No. Let's be upstanding. Let's be upstanding. She's done a good job, and she's closed it with a hug. Eh? Asante. You people are tired. Asante. Kwa kazi. Ulio. Again, asante kwa kazi ulio Thank you, Doc. We appreciate you. Asante. All right. DJ, you can give us some instrumental, and we can leave at our pleasure and leisure. Thanks. Please make sure you give us feedback on the QR code.